सब मैसेज ये चलता रहता है। इसलिए इफ वी वांट टू बी स्ट्रेस फ्री और मदर को हम सिखाना चाहते हैं तो हम उनके एटलीस्ट जो फिजिशियन वी शुड फॉलो दिस पार्ट। तो हम तो फॉलो नहीं करते हैं। तो दिस इज द ग्रेटिट्यूड टैबलेट और वी हैव टू थैंक ऑल। सिर्फ मैडम को नहीं, सबको थैंक है, हॉल को थैंक है, माइक को थैंक है। एटलीस्ट आई कैन कन्वे माई मैसेज टू यू। तो सबको थैंक है। और why it is important? Because subconscious mind is active during morning and evening hours, and all the sanskar is in the subconscious mind. So if you want to change your personality and mother's personality, then you have to change your subconscious mind, and you can make your morning miraculous morning. And this is the affirmation. बहुत सुंदर ये गीत था affirmation. टाइम मेरे को तो फास्ट बोल रहे हैं आप। कौन सा? इसके पहले था ना? नहीं, स्टार्ट मॉर्निंग। अच्छा, मिरेकुलस मॉर्निंग यू वांट? ओके, यस, दिस इज द मिरेकुलस मॉर्निंग। आई थिंक कि आज जितने लोग हैं वो अपने मॉर्निंग को मिरेकुलस मॉर्निंग तो जरूर बनाएंगे और हमारा ये मैसेज जरूर कन्वे करेंगे। इट्स ओके, इट्स ओके ना। विजुअलाइजेशन आप सारे दिन के लिए विजुअलाइज करिए और मदर को हम क्या कहेंगे, आप बेबी के लिए विजुअलाइज करिए कि आपका बेबी कैसे होगा। दैट इज गर्भ संस्कार, लेकिन इट इज़ वेरी इंपॉर्टेंट फॉर अस आल्सो। और फिर हमको अफर्मेशन क्या करना है कि जैसे आपका बच्चा आपके सामने है ना, दिस इज वेरी गुड सॉन्ग बट यू कैन नॉट लिसन। ऑडियो वीडियो कुछ नहीं चल रहा, स्लाइड ही चल रही है। दैट इज ओके, दैट इज ओके, दैट इज गुड। अफर्मेशन जो है ये इसमें सॉन्ग नहीं था अफर्मेशन। दिस द आप अर्ली मॉर्निंग प्रैक्टिस करें। आई एम पीसफुल बीइंग, आई एम पावरफुल बीइंग, आई एम लवफुल बीइंग, आई एम हेल्दी एंड सेफ, माय इम्यूनिटी पावर इज हाई, माय बेबी इज healthy and safe, my family is healthy and safe, God is my protector। हम सबको बच्चे के लिए तो करना ही है, लेकिन मुझे खुद के लिए भी करना है। You will change your life। आपको अपनी लाइफ में बहुत चेंज आएगा। और फिर बिफोर आपको you have to detoxify your digestive system। How many of you drink water in the morning? How you did that is very important। Why? कैसे लेते हैं? बस affirmation डाल के। Thank you। Why? You have studied this। You have heard the name of Dr. Emoto? नहीं सुना? Water absorb the energy, नेगेटिव और पॉजिटिव। इसलिए कहते हैं ना, जहाँ क्रोध होता है वहाँ पानी के घड़े भी सूख जाते हैं। तो अगर आपको पॉजिटिव अपने लाइफ में लाना है, चेंज, देन यू हैव टू पुट एफर्मेशन इन दिस वाटर। तो आज से इतना चेंज करेंगे। पानी डालते हैं लेकिन उसमें आप डालें आई एम पावरफुल, आई एम पॉजिटिव, God is sending the positive purity in this water। तो ये बहुत सारे स्टडीड हैं, साइंटिफिक, यू कैन लर्न, आप पढ़ सकते हो उसमें। और वाटर क्रिस्टल आप पढ़िए, उसमें भरिएगा, उसमें इंटरनेट में यू कैन गेट ऑल द मैटर। व्हाट इज द सेकेंड ब्रेन? ऑल डॉक्टर्स, व्हाट इज द सेकेंड ब्रेन? Gut। Why? Why? 90% of serotonin release from the intestine. तो आपको अगर एंटी डिप्रेसेंट चाहिए तो यू हैव टू चेंज योर डाइट. हेल्दी हैप्पी. और हेल्दी हैप्पी डाइट क्या है? फ्रूट्स, वेजिटेबल्स. वाई? कैसे? एंटीऑक्सीडेंट्स तो होते हैं, लेकिन इसमें आपको पता है क्या होता है? ट्रिप्टोफैन. व्हाट कॉजेज ट्रिप्टोफैन? ट्रिप्टोफैन इज द प्रिकर्सर ऑफ सेरोटोनिन एंड ऑल्सो रिलीजेस मेलाटोनिन. तो इतने सारे उसमें इसलिए व्हाट इज दिस? ऑल गायनिक शुड नो. What is this? We all are gynecologists. We should know. What is this? हाँ, ये तो सभी बच्चा भी बता देगा. ये तो बच्चा भी बता देगा. They are friends. We are gynics. आप बोल रहे हैं कि gynics के point of view से आप बताइए. We have heard the toxoplasmosis infection. क्या करता है वो? जब ये रैट को toxoplasmosis infection हो जाता है, तो I wanted to say कि डाइट चेंजेस आवर बिहेवियर. तो वो क्या करता है? उसको प्यार हो जाता है और वो कैट उसको गल्प कर जाता है. तो ये दिस इज एंड यू शुड स्टडी, यू शुड रीड दिस. हाँ, कि दुश्मन से भी प्यार हो जाता है टॉक्सोप्लाज्मोसिस इन्फेक्शन के कारण, है ना. ये इसमें शो करा. फिर एक्सरसाइज, ऑफ कोर्स एंडोर्फिन इज रिलीज्ड. सो और फिर आपको क्या करना है? दैट इज़ वेरी इंपॉर्टेंट. हमने मॉर्निंग का किया और सारे समय हमें क्या करना है? कर्म योग. वी आर डॉक्टर्स. लेकिन एक बहुत इंपॉर्टेंट पॉइंट जो आप सब यहाँ से लेकर जाना, शाम को जब आप सोते हो तो एक चीज जरूर चेक करना. क्या 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 कुछ याद रहे या ना याद रहे, इतना ही याद रहे, इट इज इनफ. क्या आज मैंने कितने लोगों को हैप्पीनेस ट्रांसफर किया, या मैंने बद्दुआएं ली, दुआएं ली या बद्दुआएं ली. दैट इज कर्म योग. आप कुछ भी करें. और मुझे जब कैंसर हुआ तो शायद ये दुआएं ही काम की कि मुझे यूट्राइन कैंसर हुआ था. It is up to vagina, upper 2/3 was involved, but it was in 2017 and this is 2026, but I am healthy and happy because of दुआओं के कारण. दुआओं के कारण. तो we should, हमें अपने मदर्स को भी बतलाना है. गिविंग एटीट्यूड्स, दैट इज द माई पर्पज ऑफ लाइफ. एंड गर्भ संवाद. एंड this is during labor. We should also talk with our baby. And this is one study. आप ध्यान से देखिए, थोड़ा सा ध्यान से देखिए. What is going on? साउंड किसी में भी नहीं है. The name of this experiment is still phase experiment. अब बताइएगा. Mother's face is now still. Now what the baby is doing, you see. Only 2 minutes. अब क्या करेगा वो? Start crying. तो बच्चों को 2 साल तक मोबाइल से दूर रखें. आप खुद उससे बातें करें, अदरवाइज द बेबी विल बी एबनॉर्मल. आजकल तो पेडिट्रिशियन बोलते हैं कि 2 इयर्स तक आप उसको टच करने नहीं दो। ये बहुत सुंदर है, बहुत सुंदर सॉन्ग है इसमें कि फादर का क्या रोल है, कि फादर को क्या कहना चाहिए। आवर स्लीप शुड बी हेल्दी एंड वी शुड फॉलो द स्लीप हाइजीन। मोबाइल रात में भी 1 घंटे पहले, यहाँ जो भी बैठे हैं वो अपने पास रखते हैं कि नहीं, कि अलग कर देते हैं? अलग कर देता है। वेरी गुड, वेरी गुड। एंड दिस इज द मेडिटेशन। मेडिटेशन मीन्स टू चैनलाइज द थॉट्स इन पॉजिटिव डायरेक्शन। तो हम 2 मिनट मेडिटेशन करते हैं। आई विल फिनिश द दिस इज द एसेंस कि वी शुड स्टार्ट आवर मॉर्निंग राइट। वी शुड टेक vitamin G tablet, repeat positive affirmation, practice digital detox and stay connected with divine. That is meditation. 2 minutes we practice meditation and it's finished. Okay? Are you ready? Then you start the scientific session. This is also scientific session. Yes? Done? Huh? Chalo. Relax, sit comfortably, feet on the floor, not cross legs. और चल रही है। इसमें बोल सकती हूँ, ठीक है? आवाज आ रही है? It's okay? ऑन तो है वैसे, ठीक है? मेडिटेशन में वैसे भी थोड़ा स्लो हो जाते हैं। You can open your eyes or you can close. It is up to you. Now withdraw your mind from the surrounding and concentrate on your breath. अपनी श्वासों पर ध्यान दें। आपकी श्वासें आ रही हैं और जा रही हैं। हर श्वास के साथ यूनिवर्स की पॉजिटिव एनर्जी मेरे अंदर आ रहे हैं। हर श्वास छोड़ने के साथ नेगेटिविटी, लो फीलिंग सब बाहर निकल गया। Now ask yourself, who am I? I am part of divine light. I am peaceful being. I am peaceful being. शांति के वाइब्रेशन मेरे ब्रेन में और सारी बॉडी में फैल रहे हैं। ये शांति चारों तरफ फैलती जा रही है। Now visualize a second star in front of you. His supreme energy powerhouse. और feel करें healing energy आप पर आ रही है। Like a laser rays, आप बिल्कुल शांत हो गए।
are healthy, happy, relaxed and recharged. Now you are ready for the scientific session. Thank you. Om Shanti. Thank you so much, Dr. Pushpa ma'am from Jabalpur, for your wonderful talk on गर्भ संस्कार. तो मैं आप सबसे बताना चाहूँगी कि एक मेडिकल वीक का कॉन्फ्रेंस है ब्रह्मा कुमारीज का फ्रॉम 17th to 21st September at Mount Abu, Rajasthan. You are most welcome, and if anyone is interested, please let me know so that we can register for that conference. Ma'am, I will request you to be on stage, and I will also invite Dr. Komal ma'am, our president, and Dr. Tina ma'am, our secretary, to felicitate ma'am. Kindly put your hands together. I will now call on stage Anu Didi. And also Dr. Gayatri Singh ma'am. And Chavi ji. I will also like to invite on stage our Vice President, Dr. Neetu Sahai ma'am, for the felicitation ceremony. I would request our Vice President, Dr. Neetu ma'am, to felicitate the Brahma Kumaris. Komal ma'am. From the Brahma Kumaris, there's a token of appreciation for our president and our secretary.
मधुरता, आपके हर बोल में स्नेह और संयम है, इसलिए आपकी वाणी सर्व को मधुरता का अनुभव कराती है। I don't know, ma'am, how much is this true for me, but I'll try my best to follow this. Thank you, ma'am.
स्नेही, आप प्यार के सागर और परमात्मा की संतान, प्रेम की भरपूर गंगा बनकर सर्व पर प्रेम बरसाने वाली स्नेही आत्मा है। थैंक यू मैम।
We say this is the Vardhan card on behalf of Anushriti. I'm taking it, circulating it. All of you, please take out and read it. And I'm sure it is according to your personality and everything.
Good morning, everybody. We are about to start the scientific session. The session before this by Brahma Kumaris was really healing, especially the meditation at the end. But we have to move in the day ahead. So we would start our scientific session by calling upon stage our chairpersons for the first session. I would like to invite Dr. Seema Sahu ma'am. Dr. Seema Sahu ma'am on stage to chair the session. I would also like to call upon stage Dr. Komal ma'am, our president, to chair this session. And I would also invite Dr. Nupur Chandan ma'am to chair this session. And Dr. Krishna Agarwala ma'am. Thank you, ma'am, for joining us for this session. The first talk of the day is about contraceptive implants, a new addition in the basket of choices by Dr. Souvik Das sir. Souvik Das sir has a fellowship in reproductive medicine and surgery. He is in affiliation with All India Institute of Medical Sciences, Kalyani, West Bengal, and the area of interest for him is reproductive medicine, minimally invasive gynecological surgeries, and midlife and menopause. I would invite sir for the talk.
Hello. Good morning, everyone. I'm Dr. Souvik Das, and I would like to thank DHANBAD Obstetrics and Gynecological Society for inviting me. So the topic today given to me is contraceptive implants. So let's begin. So on a lighter note, the topic today, it's about Implanod. It's a tiny rod with a huge responsibility. Probably it's something, it might be just 4 centimeters long, but it can prevent panic for more than 3 years. So we should not take it lightly. Anyway, moving on. So what is an implant? It is basically a small flexible rod which contains progesterone, and it can continuously work for 3 to 5 years depending upon the So it is a type of long-acting reversible contraceptive which is which contains etonorgestrel, which is a third generation progesterone. It is actually an active metabolite of DSOGCON. So currently Implanon NXT, which is a single rod contraceptive, is currently being introduced in India under the National Family Program Planning Program in certain districts. Okay, so I have already covered this. Implanon, the release rate of progesterone is around 60 to 70 microgram per day initially, which stabilizes at around 25 to 30 microgram per day at the end of 3 years. And it is also impregnated with barium sulfate, so that in case of missing implant, it might be easily located by an X-ray. Okay, so mechanism of action is similar to that of progesterone pills, that is ovulation suppression, endometrial changes, it makes the endometrial atrophy, cervical mucus thickening, and tubal motility alteration. It's the same. So today, most importantly, since this is a novel, not novel, it is not being currently used in India so popularly. So my aim would be to educate everyone on how to put the implant. So the implant is put at the inner aspect of the non-dominant upper hand, 8 to 10 centimeter proximal towards the shoulder, and 5 centimeter posterior to the bicipital groove. I'll come to this later in great detail. So yeah, as I was talking, the implant should be far away from the bicipital groove, because some major vessels like the brachial artery, the basilic vein, and the median nerve passes through this groove. So we have to mark the site of insertion prior to inserting the implant. So yeah, before insertion, these are the prerequisites. We need a marker, we need a scale, a sponge holding forceps, some antibiotic, some antiseptic, lignocaine, the implant, which is the preloaded applicator with the single rod implant, some gauze, dressing, and pressure bandage, and of course sterile gloves. Okay. So yeah, coming to the main part, positioning of the arm. So what we do is we ask the mother or the lady who wants this contraceptive to lie down supine on her back and put the non-dominant upper hand behind her head. What this does is it flexes the arm at the elbow and externally rotates the arm. In this position, we have to mark where we want to insert the implant. Okay. So yeah, this is where we mark. It is first we mark the medial epicondyle of the non-dominant hand, and then we go 10 centimeter, around 10 centimeter proximal towards the shoulder. We mark this point as A. Then we have to go 5 centimeter posterior, so that this A point is where the bicipital groove is. So we have to go posterior to it, mark a point B, and then at the same level we mark a point C around 5 centimeter proximal to point B. So in between these 2 points B and C, we need to put the implant. So after marking is done, we put some sterile antiseptics, and then we infiltrate the area with lignocaine, 2% lignocaine, around 3 to 5 ml. After that, what we have to do is we have to stretch the skin at the point B and open the applicator. Once it is done, we have to take the applicator, make an angle of 30 degrees and insert the needle till the bevel at the point B. Alright. Once the needle has gone inside the skin, we need to make the applicator parallel to the skin, so that it goes in subdermally. So first, we take the applicator, open the applicator, pierce the needle at the point B, and then once it has gone till the bevel, we make the applicator horizontal. While it is horizontal, we have to push the applicator till point C or till the entire length of the applicator has gone in. So once we are sure that the entire implant is inside the skin, only then shall we slide or unlock the slider of the applicator and pull it backwards. What this does is it pulls the needle inside and the implant stays subdermally in its position. We should be careful here about not pulling the slider before the entire implant has gone in, because once you pull it, there is no going back, so that implant will be wasted. Okay? So once this is done, we verify the presence of the implant, we check for some minor bleeding, and we bandage the area. And we ask the mother to open this bandage after 48 hours. So what are some of the side effects? The frequent complaints that mothers come to us with is infrequent bleeding, irregular spotting, and amenorrhea. It's similar to that of DMPA, injection DMPA. Okay. So global experiences, the highest users is among African countries and Southeast Asian countries, and India is also slowly catching up. ICMR study says that continuation at 6 months is around 96%, which is excellent, but continuation at 3 years is around 66%. We have to increase this number. And return to fertility is also pretty high. I want to tell something that implant has a lower pearl index than even sterilization surgeries. It's around 0.01. So it is a very good contraceptive if used properly. Anyway, so it's highly effective, safe, and comparison with IUS and copper IUD 1 year continuation rate is lower because people are not that aware. Yeah, so the recommendations of WHO is, just as I said, it's the most effective reversible method, most effective contraceptive. WHO endorses it as a first-line option for women seeking long-term contraception, and it is also effective amongst women living with HIV or who are on ARV drugs. Yeah, so Foxy endorses single implant. And Foxy also conducts training of service providers. I want to add that Organon Pharma along with DKT Pharma, they collaborate and they also give training to private practitioners who are interested. So if anyone's interested, they can ask me, I will provide you with the information. Okay. So yeah, these are the phase 1 states. In India, Implanon is still in phase 1, and these are the states where it has started. At our institute, we get Implanon, and we provide Implanon for free since we get it from WHO. Even state medical colleges in West Bengal, they also have the provision of Implanon.
The recommendation is when you give Dubertulin, you got to trace their continuous heart rate. So now the Maxal, which again you know the Maxal, and actually we also give for the neuroprotection, and we also give if there is a hypertension. So Maxal is a good drug, but Maxal you cannot give for longer time, and obviously giving Maxal means you are committing to the delivery. Now I am not talking about indomethacin, it can cause so many problems. We also add in our clinical practice nifedipine, which can cause hypotension and placental hypoperfusion. So that is also a problem, and it is contraindicated in a very bad obstetric cholestasis. Now, so there is no typical ideal tocolysis. So there comes the autosebum. Autosebum is actually, this is the slide, I want to wait for some time. This is the most evidence-based, more rational thing, and it is developed for this indication only. It is most effective than any other tocolytic thing. It is most rapid, it works within 15 minutes. It is very safe for the mother, it is very safe for the baby. We will come to all this in detail, why this is safe for mother, why this is safe for baby. And it is most safe for us as well, because it is licensed for, it is the only licensed tocolytic for this indication, preterm labor. None of the other is actually licensed for this indication. And this day, when the, like all those IVF babies, and when they are into problem, those parties can sue you. Really, that is a fact. If the result eventually do not come out good, especially. So now I'm going into detail of this. I will be just skipping through. So you can see they are actually inhibit the IP3 product. Prostaglandins. So that is one of the things, the babies remain so healthy. And days gained, actually can you see here that I have got a patient who actually gained 2 weeks in a very severe preterm, and you can understand at this 28 and 30 weeks, those 2-week gain makes a big gain, and the average in the study is 41 days. So the therapy continuation generally very good because there is no side effect. This is the Indian study where you can see it works on the Indian people, and nifedipine versus atosiban trial is there, which clearly shows that it is more effective than nifedipine and it is more safe than nifedipine. So it is an effective, safer tocolytic. There are plenty of clinical evidence, and you can see all those things in my slides. I'm not going to read all these things because I won't have time. So you can see even with the duvadilan, it is more effective than duvadilan drip. The only problem I see about the atosiban is that it is costly. But if you calculate the cost of the neonatal admission, and if you calculate the cost of that neonatal admission thing, then it is actually very cheaper. First bill is there. This slide I would say that you need to take how to put that. This is 3-way thing. First is you give a scan dose, then a 3-hour bolus dose, and then you continue maintenance dose. This is a very important slide. All of you should remember this slide. And even if you retreatment, give a retreatment the same way you got to give. So it has got the recommendation. So I came back to the same slide, which says this is the most safe for mother, baby, and the doctors. Now I'm coming to the assisted reproduction. Basically, in assisted reproduction, it actually improves the role of implantation, because during implantation, as you dilate the cervix a little bit, there is some prostaglandin secretion there, and if you infuse the atosiban that time, the implantation rate increases along with the other things. Obviously the progesterone and all is there, so but along with the other things, it has got a very good result, and it has already shown, and you can see there is a, so it is an advancement over current therapy. It improves the outcome of the embryo transfer, and it reduces implantation failure, and increases the clinical pregnancy rate. This is very important, not the biochemical, clinical pregnancy rate in cases of embryo transfer. So it should be used for all high-risk cases or previous implantation failure cases. That is how it is now at this moment. There is not much guideline clear from the society as yet, but we hope it will come very soon. So thank you very much. It is a really hurried thing, so but I am happy to answer any of your questions if you have any. Please.
For prevention of premature labor pain, how many doses are required?
No.
Just single dose?
No, it is not single dose. First you give one stat.
Yes.
And then I need to go to that slide, and then you give a infusion over 3 hours.
3 hours.
Yes. And then you continue with that about 30 hours or so. And then you stop. And most of the time, if you continue up to 40 hours, that's my experience. They are saying 45 hours. But if you can continue up to 40 hours, then she will go on again another 4-5 days at least, if not more.
Followed by another oral
then yes.
prophylactic drugs?
You can give oral prophylactic drugs. Those are much safer than IV DHANBAD.
Thank you, sir. Thanks.
Yes.
Thank you, sir.
Yes, ma'am. No. Okay, no more questions? Thank you then.
Thank you, sir, for your
It's
wonderful...
very nice for me to come here and get acquainted with all of you. This is actually my first visit in DHANBAD. I'm very happy to be here. Thank you all for inviting me to present this session, and thank you all.
Thank you, sir, for your presentation.
Thank you so much, sir, for the enlightening on the role of DSOGCON. Now we'll carry forward with the felicitation process. I now invite the speakers back on the stage, Dr. Souvik Das, sir, Dr. Pankaj Singhania, sir, Dr. Sarkar, sir, and Dr. Pallab, sir. I also request our chairpersons to kindly join us on the stage, Dr. Krishna Agarwal, ma'am, and Dr. Seema Thakur, ma'am. And also our president, Dr. Komal ma'am, our vice president, Dr. Neetu ma'am, and our secretary, Dr. Reena ma'am, to come join us on the stage. Dr. Krishna ma'am, kindly felicitate Dr. Souvik Das, sir. I would again ask Dr. Krishna ma'am to felicitate Dr. Pankaj, sir. Dr. Pankaj Singhania, sir. Dr. Seema ma'am, kindly felicitate Dr. Avish, sir.
Hello.
I would ask Dr. Seema ma'am to felicitate Dr. Pallab, sir. I would now ask Dr. Komal ma'am to felicitate Dr. Krishna ma'am. Dr. Neetu ma'am, kindly felicitate Dr. Seema ma'am. Dr. Pankaj, sir.
Thank you to all the speakers and all the chairperson for their valuable input. Now moving on to the second scientific session for the day. I would like to call upon stage our chairpersons for this scientific session. Starting with our Vice President, Dr. Neetu Sahai ma'am. Ma'am, kindly join us on stage. I would also like to call upon stage Dr. Sanchita Mandal ma'am and Dr. Raj Lakshmi Tubin ma'am. It is my extreme pleasure to invite our first speaker, Dr. Mitra Saxena ma'am. And by now we are all familiar with ma'am. We've had a very good workshop with ma'am yesterday, and I will ask her to take the stage.
Thank you once again, DHANBAD team. Can I have with the permission of the chairpersons, I will just take my talk over. I know the constraints on the organizing team is too heavy. We'll be falling short by 1 hour. And so let's see. Please hurry up and put my presentation. So I'm going to be talking about past, what's new. We all know that past is something which is our own doing. I would like to put it as a nitrogenic obstetric complication. Na cesarean hota, na pass hoti. So friends, the journey with PASS has gone from fear and now we are on the verge of having a balance. We began in ignorance. We met placenta accreta unprepared and lost mothers to uncontrolled bleeding. Then came fear. Remove all you try to save the mother became our reflex. We swung from underprepared to over-radical, hot heads, morbid surgeries, young lives altered forever. But surgery matures with anatomy. Today we are finding a balance. I know there have been instances where such kind of uteri are opened and you are advised that if patient is stable, please don't open if you are not prepared. And there were times that people were confronted with this kind of clinical situation. So, cadaveric dissections have highlighted the segment-wise blood supply. Surgical staging has given us a map. Protocolized approaches have replaced panic with a plan. So now we can safely say that PASS isn't a call for blind hysterectomy, it's a call for mapped surgery. When to resect, when to conserve, and when to stop bleeding before it starts. So anatomy, strategy, and restraint. To harness this largely iatrogenic obstetrician-made epidemic. So yesterday those who have attended my session would have gone through the anatomy class well, but all I want to say is that we are all very familiar with highly vascular organ which has, nature is already prepared a woman for labor, for growth of uterus and then its retraction. But we have to understand that the presence of these colpouterine vessels, they were not very well defined. As late as 2006, they were actually given a name and their course was designed. So this is again from my talk yesterday only, that these are the key diagrams. We have to remember S1 segment, S2 and S3. When we talk about PASS or placenta previa, we have to focus on S2. And we know that the most important reason for PASS is a previous cesarean. Of course, there are a million other reasons why a placenta can be adherent, but let's restrict to the commoner things. And I have no time constraint, so I will try and hurry up so that we can cover important aspects. The key thing to remember is that blood supply of uterus, cervix and vagina all is going from below upwards. So in the upper segment, again we know the uterine comes by the side, but it ascends up. Similarly, the vaginal arteries, the pudendal arteries, their branches, they are the ones feeding the colpouterine. Again, it's a vertical thing going below upwards. But here at the lower segment, there is a confluence of lots of vessels. So this is a very important part, which is in relation to the bladder. We have to understand that when we deal with the bladder properly, that's the time we'll be able to control any and every kind of extension, tear, adherent placenta or a low-lying placenta previa. So that is the first important crux in understanding and managing complex cesarean section, placenta previa and placenta accreta spectrum. I have already in detail I have mentioned this slide yesterday, but this is the most important thing, the bladder dissection. Now also a word about internal ileal artery ligation. We all thought and we still do think that it helps in decreasing the blood flow to the uterus and also in all cases of PAS, but that's not the truth, because the major vessels are called uterine, which also get some part from the posterior division. So actually speaking, spending a lot of time in trying to occlude the internal iliac artery would not be very important, because we have other temporary measures like aortic compression, aortic clamp by Dr. Piley, or clamping the common iliac. That is just to decrease the blood supply to the area where we are going to do the dissections and dealing with the area. Hemorrhage is the most important thing we are afraid of. So we have to understand that if you see the incidence of severe placenta is very low, it's only 3.4%, and majority are 76%. But imagine if you are going to do one size fit for all, meaning hysterectomy for all, you can understand you are taking out many more uteri than they are needed. So coming to my talk, actually what's new is making you all understand the vascular anatomy, which I did yesterday, and I think the other next important part is surgical topography. So what are the principles, how do you map? So this is very simplified now. We had the pleasure of inviting Dr. Jose and Alvaro to our workshops with Dr. Manjupuri under aegis of NARRI, and we ourselves learned a lot of new insights into logically controlling hemorrhage, logically doing a thing which we've been doing by instinct. And of course, if time permits, I would like to discuss just points of the surgical options. Never mind, most important thing which we have to understand is no patient of yours, whether it's of course if it's a book patient, you would know the site of placenta, but otherwise also if you undertake any patient in emergency, comes right into your OT only, please don't take up a patient without having done a scan so that you know where the placenta is. So the most important thing is that there was a big hype that you have to do MRI, this and that. No. If you know the ultrasound features of PAS, you really can rely only on 2D, and where needed color can be put in. So actually speaking, we in our own setups must encourage our sonologists to tune their eyes so that they learn to see the actual important feature, especially the hypoechoic zone behind the placenta. If that is not there, we know this is an adherent placenta. If a placenta in the upper segment, if it is adherent, if we start looking for it, we'll find it. So friends, I don't want to spend much time, but each one of you, it is your duty to kind of collate the whole information for yourself before surgery and for your sonologist friend later, so that you can tell this was overdiagnosed or this was underdiagnosed, you missed it, so we can complete the circle. And what is important is to teach them to do conceptual 3D reconstruction. How do we do it? That is by doing transabdominal and transvaginal scan in 3 planes, sagittal, axial and coronal. And actually, this is what we learned in our classes, that it's not difficult. Those who have an ultrasound machine, start doing it. You'll be able to make up a mental picture of where is the placenta. And the features of placenta accreta, adherent placenta, are very simple. First of all, it's not an echogenic placenta. There will be lakes. If there are lakes, if you put color, it will be alive. You can see a lot of blood, lots of color in the placenta. But most important is the retroplacental layer between the myometrium and the placenta. That hypoechoic zone, if it's missing, it means it is adherent. And then of course, its relationship with the bladder and all the other things. So what is important is the movement, how you will do in axial, sagittal and coronal planes, and also do the same things in the transvaginal probe. Now, the most important thing that everybody can understand, learn, see and practice is the topographic classification. What do we see is, basically speaking, we should know what is the segment of the blood supply and where is the placenta located. So it's very important to know. I've already shown you the segments S1, S2, S3, but you have to understand that what the surgical staging is going to do. Each part has got arterial pedicle which is identified, and what procedure should be done to control the supply from that area and decide how to do conservative total hysterectomy or modified subtotal hysterectomy. So dissection of the retrovesical space, as I said, moving the bladder away, and that is the single most important surgical step. And if that you can achieve bloodless, and there are techniques, no rough and blind, blunt dissection of the bladder. Every connection of the bladder, because it's a new vessel, just doubly ligate it, cut it, and gently remove. So actually speaking, I'm not going to go into the nitty-gritties, because I invite all of you to join our masterclass on 21st May 4 to 7 p.m. ICOG platform, where Dr. Manju and me have arranged the masterclass. Our teacher will be there to deal with most of the topics, so that will be a better thing. But however, we have to understand that on-table staging, if you understand the concept, I think my job would be done. So let's see. This is looking very difficult, but if you see at the right end, there are only 3 options. You can either do total hysterectomy, or you can conserve the uterus where it is needed, or if you can't do a hysterectomy, instead of trying to do a hysterectomy in every case, just learn to do how to modify subtotal hysterectomy. Now, what is the actual aim of this classification? What we are looking at when we are doing surgical staging is what uterine wall is affected. Is it upper segment or is it lower segment? Is it the anterior wall or is it the posterior wall or is it the lateral wall? Then can the bladder be dissected? And the main point to recognize the S1, S2 is the peritoneal reflection. So are we dealing with things above the peritoneal reflection or below? And what arterial pedicles? Upper segment we know it is the uterine artery, and the lower segment we know it is the colpouterine vessels. And how difficult will the surgery be? Imagine if the placenta, if the topography tells you it's on the lateral parametrium. Obviously the operability is going to be difficult. So no need for you to actually remember everything, just these things are good enough for you to stage the type of placenta. And what it helps is that, what are the past features? Most importantly, there is neovascularization. What we were understanding is that the placenta invades through the myometrium, goes into the bladder. Fact of the matter is that the seed is good, the placenta is good actually, the soil is not good. So when the myometrium is not good, the serosa is not good, the friendly neighbors, that is the bladder, is giving help to the for the vascularization of the placenta. So it's the other way around. Only thing is that if there is fibrosis, which happens more because of previous adhesions, because of the bladder being adherent to the uterine wall, which makes it inoperable. So whenever there is neovascularization, if you learn the technique of dissection, then it's easier to separate any bladder from the wall. What you cannot separate is there is fibrosis. So if you assess all these features, which is not difficult, you can actually decide on table what you are going to do. Now, so the next few slides are just very beautiful visuals of the levels of type 0, 1, 2, 3, 4, 5. And this is one slide I really want to wait on this slide, because what does this tell you is intraoperative staging. So how do we do intraoperative staging is, first of all, you have to do bladder dissection. Before you start doing anything, if you can separate out the bladder, you can at least do a hysterectomy. For hysterectomy, you have to mobilize the bladder. So once you are able to mobilize the bladder, hysterectomy is always possible. Now the second thing is, if the patient desires fertility, or if you can save the uterus and you can do it nicely, then it's easy for you to decide on one-step conservative surgery. And lastly, if there is fibrosis and you cannot separate the bladder, stop. Don't cause excessive hemorrhage. just stop and first take out the baby by the wards maneuver. I'll show you some slides, and then you go ahead and do one amongst the three. So the most important question, okay, I'll just finish it very fast. So the three questions are, is it possible to separate the bladder from the uterus? Is there at least 2 centimeters of healthy myometrium caudal to the pars area above the cervix? Or what is the spread of the placenta? Is more than 50% of the uterine circumference is healthy? It means in this uterus you can offer the conservative surgery. So this is very important to understand topography, and topography only tells you what complications you are going to face at the operation. So if it's lateral spread, if there is fibrosis, definitely you won't be able to do hysterectomy or conservative surgery. So basically it's very simplified, and these are some slides for one-step conservative surgery. Then the three things, if you can separate the bladder, some other time or in our master class you will be able to see all these in video. So how to separate the bladder, all those things, and then whether you have 2 centimeters of healthy myometrium, and see the posterior aspect. So you exteriorize the uterus and then you assess all these things. The operability, the separation of the placenta, posterior wall intact, no lateral spread, and healthy myometrium below. You can go ahead and do the conservative surgery. So next few slides are just with this, and this is wards maneuver, where you give a transfer incision above the placenta, take out the baby, like we were taught to how do we manage placenta previa, that don't go through the placenta, go above or separate the placenta and then go. So that's been given a nice name, wards maneuver. After that, you can exteriorize the uterus and see the posterior wall, and then go ahead and do whatever it's possible. So this is the on-table part of on-table surgical staging. Yeah. And then when we have to do the conservative surgery, you have to ligate the colpouterine vessels, and then of course you chop off the placenta bearing wall and then repair the uterus. What our surgeons have told us is that they've had follow-up cases of these patients with conservative surgery where there is no placenta accreta and patients have had healthy deliveries, I mean cesarean sections. So this is when there is bladder can be mobilized completely, you understand that hysterectomy will not be difficult. You really don't need to go up to internal iliac or anything. And anytime when there is on-table hemorrhage, instead of trying to figure out where the internal iliac is, just clamp the common iliac as I showed you with the deep Blakey clamps, or you put the aortic compression. So we have to remember all these things. And subtotal hysterectomy, this is again, just I'll take 1 minute. When you cannot separate the bladder, please, you will not be able to do anything apart from subtotal hysterectomy. So how will you do subtotal? You have to make sure that the part that is left behind the placenta is there. So there you have to compress the posterior and anterior wall. So details of these surgical steps will all be shared in our master class, and due to paucity of time, I do not want to take more time than what is given to me. My final message is pars and cesarean section go hand in hand. Many times it is dehiscence and not inheritance. That is why we say if you are taking out a hysterectomy, doing a hysterectomy, later subjecting the patient to hysteropathology, and you see there was no invasion. So I think as an obstetrician you can review your knowledge, your surgical expertise to deal with pars in a more confident and as a teamwork. So I would say that have your own colleague who is conversant with the anatomy, with all these steps, and then do it together. And of course, we cannot forget the importance of being prepared, that it is a multidisciplinary approach. Obviously, you have to have an HTU, your anesthetist, your pediatrician. That goes without saying. All the guidelines for pars should not be ignored, but our competence should be raised by our knowledge of all these facts, and we can put them all together to, carry out things without causing complication for the patient or for our own self. So, in pars, I would say for this iatrogenic complications, outcomes of placenta accreta spectrum are not determined in the operating room. They are decided in planning and preparedness of teams. Today, mastery of vascular anatomy topography and intraoperative surgical staging has transformed the management of this once insurmountable life-threatening complication. Thank you very much.
Mitra Saxena ma'am. And we must have that the knowledge of how we are going to approach each and every different case, the topography, the anatomy that you talked about. I'm sure the audience today are more emboldened to go into surgery for placenta accreta spectrum. Thank you so much.
Okay, thank you so much.
Because we are running short of time, we would avoid taking questions from the audience. And next in the session, I would like to invite Dr. Kavita Barnwal ma'am for her talk. Ma'am is a fertility specialist at Indra IVF. Okay. Dr. Kavita Barnwal ma'am.
Thank you, DHANBAD Society, especially Komal, Reena, Neetu, Neha, for giving me opportunity to speak very less talk and boring topic. In fact, after such an colorful slides and exciting talk by Mitra Madam, I am here to speak on voiding dysfunction females, which is very less talk. In fact, only these cases are dealt by urologists. So, ये पूरा बड़ा स्लाइड नहीं हो पा रहा है, पूरा आ जा रहा है, बड़ा हमको करना है, एक सिंगल स्लाइड है, दोनों आ रहा है, थोड़ा आप प्लीज एक बार हेल्प कर दीजिए. So normally bladder is under sympathetic control and there is storage when there is relaxation of the detrusor muscle and contraction of the sphincter, which is assisted by the somatic pelvic floor contraction, and this leads to storage of urine. While during voiding there is parasympathetic detrusor contraction and urethral sphincter relaxation, which leads to maturation, and this is under control of cerebral cortex and cortex. ये थोड़ा बड़ा करना है प्लीज, पूरा दिख रहा है उसमें. Okay, so I will start my presentation with this case which I have faced recently. Mrs. Geeta Devi, 20 years old, para 1 living 0, presented with a complaint of fullness of abdomen, incomplete emptying of the urine for last 2 months, following a normal delivery at a small clinic 4 months back. She visited many doctors, but her problem was persisting. Routine investigation with ultrasonography pelvis was done, and it revealed post-mortem residual 450 cc. She was given methanacol, and indwelling catheter was kept for 2 months. Pelvic floor relaxation exercise were advised, and now her post-mortem residual urine is 70 cc, and she is feeling much better. So this topic, voiding dysfunction, is an enigma. The International Continental Society and International Urogynecological Association defines voiding dysfunction as abnormally slow urine flow rates and or abnormally high post-mortem residuals. It's a spectrum rather than a single entity. Current literature emphasizes like detrusor underactivity, dysfunctional voiding, primary bladder neck obstruction, Fowler syndrome, functional urethra obstruction, and mixed storage voiding disorders. Most common symptom is terminal dribbling followed by incomplete emptying, weak string, and there can be frequency overflow, incontinence, straining, double voiding, increased post-mortem residual urine, and recurrent urinary tract infection. Due to bladder dysfunction, there will be detrusor hypoxia, hydronephrosis, and even renal dysfunction. Exactly, this incidence is not known because it is underdiagnosed due to overlap with the overactive bladder and lower urinary tract symptoms, but prevalence increases with age. It is often associated with pelvic organ prolapse, neurological disorders, prior pelvic surgery, and more commonly diabetes mellitus. We can define causes like functional causes, which is due to dysfunctional voiding, Fowler syndrome, detrusor underactivity. Anatomical causes where there is stricture in the urethra, prolapse of the pelvic organs, bladder neck obstruction, and some neurological causes like multiple sclerosis, spinal cord injury, and Parkinson's disease. So pathophysiology behind this problem is impaired detrusor contractility, increased increased urethral resistance, which is associated sometimes with pelvic dyssynergia and neural pathway dysfunction. So all these lead to they inhibit the contraction of detrusor muscle. And adrenergic agonists, which increase urethral resistance, and they lead to incomplete bladder emptying. So these drugs are antipsychotics, anticholinergics, antidepressants, anti-Parkinson drugs, opiates, antihistaminics, and decongestants, which are very commonly used in day-to-day practice. And after examination, we have to go for the investigation. First and foremost, routine culture unit. 40% women had history of recurrent tract infection. Ultrasonography should be done to see the postmortem residual linear bladder wall thickness, stone, diverticula, or any pelvic pathologies. Perineal ultrasound should be carried out in these women to see the pelvic floor movement to prevent dyssynergia. Bladder diary should be recorded for at least 3 to 7 days, which provides objective data, fluid intake, frequency of maturation, maximum body volume. Uroflowmetry measures volume and flow rate. So normally it's well separate in normal cases. If it is pre-2, then it suggests obstruction. If it is intermittent or sawtooth pattern, then it suggests dysfunctional body. Low flow plus high postmortem residual is suggests detrusor underactivity. Micturating cystourethrogram helps in diagnosing bladder outlet obstruction. Bulging the proximal urethra suggests stricture in the urethra, and classical spinning torque is suggestive of pelvic floor dyssynergia. Electromyography, especially needle electromyography, when put in the urethra, helps to diagnose functional structural obstruction. High detrusor pressure with open bladder neck, non-relaxation pelvic floor, and poor flow suggests pelvic floor dyssynergia. Cystourethroskopy gives information about the causes of bladder obstruction like urethral stricture, growth, or any diverticulum. Video aerodynamics are advanced tests which helps to distinguish between detrusor underactivity, bladder outlet obstruction, dysfunctional body, follow syndrome, or detrusor sphincter dyssynergia. It also assesses capacity of the bladder, compliance, sensation, overactivity, or any body pressures. It assesses outlet urethral function in cases of functional obstruction, failure of sphincter relaxation, urethral stricture, and pelvic floor dyssynergia. It also provides anatomical imaging of the bladder neck, urethral anatomy, mesenteric reflex, or any type of prolapse or diverticulum. It's not done routinely, indicated in cases like complex female body dysfunction, chronic urinary retention, if failed previous treatment, suspected urogenic bladder, or if there is incontinence with the body dysfunction. And in cases of recurrent uteri when the cause is not clear. Advantages are it provides simultaneously functional and anatomical assessment, more accurate diagnosis than conventional aerodynamics, but it has limitation like it is invasive procedure, it needs expertise, radiation exposure is there, and it's also expensive. MRI-based pelvic floor evaluation and computational modeling are newer investigative tools aimed at understanding of urethral biomechanics, pelvic floor coordination, neural pathways involved in the body. So, bladder contractility index, this is very commonly used where detrusor pressure plus 5 times maximum flow rate is taken. If BCI is less than 100, it suggests underactive detrusor. And for bladder outlet obstruction, index is taken, which is maximum detrusor pressure minus 2 times maximum flow rate. If it is less than 5, then less than 10% chances of bladder outlet obstruction. If it is more than 5, then 50% chances of bladder outlet obstruction. And if it is more than 18, then more than 90% chances that the woman is having bladder outlet obstruction. So now, after investigation, we have to treat. First of all, we have to see the cause. If it is due to detrusor underactivity, we need to give behavioral therapy like lifestyle modification, bladder training. Assisted boarding by abdominal straining is an option for women who are able to relax the pelvic floor muscle while straining to God. Drugs which can be used in cases are methanocol, which is muscarinic receptor agonist, and alpha blockers that will relax the urethral sphincter like tamsulosin. Intravesical electrical stimulation improves bladder dysfunction by stimulating alpha mechanoreceptor reference. A sacral neuromodulation is used for correction of disturbed reflex action, especially in Fowler's syndrome. It has been found that with this sacral neuromodulation, 72% of the women could void spontaneously with less post-voidal residual. Detrusor bioplasty is a very advanced surgery. It was first described by Senji et al. And Gekis et al. Where litissimat is used for detrusor bioplasty, and it was found that 71% women gained complete spontaneous voiding with mean post-voidal residual of 25 mm. In future, we can expect stem cell therapy which will be used to restore contractile function of the detrusor muscle. And Next is bladder outlet obstruction. If it is mechanical like iatrogenic after SOI surgery, then loosening the tape resolves in most of the cases. If it is due to urethral stenosis, we need urethral dilatation. For narrow strictures, hydrophilic dilators are preferred over a guide wire. If urethral dilatation fails, then we will go for the augmentation urethroplasty using vaginal flap or buccal mucosal flaps. For functional bladder outlet obstruction, like Hinman syndrome, because it is wrong, faulty behavior, so we need biofeedback, physiotherapy, and relaxation exercises along with bladder retraining program. In women with a functional bladder outlet obstruction, which were treated with alpha blockers, constantly found that improvement in body symptoms 71% cases and decrease of post-mortem in 62% cases. In interstitial sphincter dyssynergia, clean independent catheterization is the standard treatment because it bypasses the dyssynergic sphincter. Botulinum toxin A injected in the urethral sphincter, it also found to be effective in cases of neurogenic detrusor sphincter dyssynergia and improvement in about 67% cases. So to summarize, if bladder fails to contract or if there is a diagnosis of detrusor underactivity, we should give behavioral therapy, pharmacotherapy, intravesical electrical stimulation, clean independent self-catheterization, sacral neuromodulation, and if not getting cured, then functional detrusor bioplasty. If urethra fails to relax or if there is bladder outlet obstruction, then we have to see the cause. If it is due to collapse, we have to repair. If it is due to tight sling, then we have to go for conservative surgery. Or if there is stricture, then we can go for dilatation or urethroplasty. In functional cases, we have to devise valvular relaxation along with the biofeedback, alpha blockers. Detrusor sphincter dyssynergia cases, we need Botox plus clean independent catheterization. Circular nerve modulation is being tried in many centers and it has got very good role. It has been practiced by Dr. Amita Jain in Vedanta and she has submitted a paper also. It has very good role in cases of DCT. So to conclude, female body dysfunction is a complex disorder, poorly understood and difficult to manage. Accurate diagnosis is essential before starting treatment. Video aerodynamics remains crucial in diagnosis and management. Neuromodulation is a major disadvantage. Thank you so much for your patient hearing. Thank you, River, chairperson. I could have told you because I thought time will be up.
Thank you so much, Dr. Kavita ma'am, for such a detailed presentation in such a defined time.
And actually, many women couldn't be diagnosed, especially after obstetrics cases like after delivery, after pelvic surgery. Women go into covert retention, and thereafter they will be having detrusor hypoxia.
Very highly enlightening.
So this should be kept in mind. So
clinically relevant. Thank you, ma'am, and thank you for being so considerate to the organizing team and keeping time.
Thank you.
Thank you so much, Kavita ma'am, for your talk on voiding dysfunctions. Now, I would like to request respected Dr. Pratibha ma'am for her talk on the non-contraceptive uses of long-acting reversible contraceptives. Dr. Pratibha Singh ma'am, she is a consultant at Healing Touch Hospital, Bhagalpur, and she is governing council member ICOG 2627. Welcome ma'am.
Respected chairpersons and my dear friends, a very good morning to all of you. At the outset, I would like to congratulate the organizers of DHANBAD Afghani Society for this wonderful conference, especially Dr. Komal Singh, Dr. Reena, and all the stalwarts of DHANBAD Society, Dr. Pratibha Rai Madam, Dr. Shivani Jha Madam, Dr. Neha, and everybody for organizing such wonderful conference, and also want to thank them for giving me this opportunity. Now today I have been asked to talk on non-contraceptive uses of LARVs. So if you see, for many years LARVs were viewed only as highly effective contraceptive tool, but today evidence and clinical experiences have expanded their role far beyond family planning. So LARV, that is long-acting reversible contraception, is defined as a contraceptive method that require administration less than once per cycle or month. It is long-acting, reversible, user-independent method and these are the different types, that is LNG, levonorgestrel intrauterine system, copper intrauterine device, and etinogestrel subdermal implant, which is now freely available in India. So apart from contraception, these large plays a major therapeutic role. In our day-to-day practice, especially in the country like India, where anemia, heavy menstrual bleeding, dysmenorrhea, endometriosis, and limited surgical access are extremely common, LARCs, particularly the LNG IUS, have emerged as a powerful therapeutic device because they provide sustained delivery, drug delivery, or mechanical effect with highly efficacy and excellent safety profile, making them ideal for long-term gynecological management. All LARCs are contraceptive, but not all have equal therapeutic values, and among all, 52 mg LNG IUS has the strongest evidence for non-contraceptive benefits. Whereas copper IUDs, they are mainly non-hormonal and it has a limited therapeutic benefits beyond contraception. In fact, it may increase menstrual bleeding and worsen cramps, so therefore it is not being preferred for the women with heavy menstrual bleeding or dysmenorrhea. Whereas implants, they have systemic progestin, which can reduce dysmenorrhea and endometriosis associated pain in some patients. So the main therapeutic mechanism with progestogen is that it reduces endometrial suppression, causing less bleeding, reduce prostaglandin, which reduces cramp and pain, and decidulization, which makes endometrium inactive and stable. So these are the four non-contraceptive benefits, that is, it reduces heavy menstrual bleeding, dysmenorrhea, endometriosis and adenomyosis can also be taken care by a meaningfully reduction in pain and bleeding. Then endometrial protection, especially when the endometrium is exposed to estrogen. And it improves the quality of life by improvement in daily functioning, increased work productivity, and anemia-related symptoms are also reduced. Now, apart from convenience and reliability, lighter periods are perhaps the most popular non-contraceptive benefit of this LNG IUS because they causes marked endometrial thinning, reducing blood to almost 80 to 90%. So it can be preferred in the cases of benign heavy menstrual bleeding where no other cause are there. And it also can reduce the need for surgery like hysterectomy and improves hemoglobin and quality of life. But again, counseling is very important because there may be irregular bleeding, spotting, which is quite common in about 3 to 6 months. Even NICE guidelines clearly recommends LNG IUS as a first-line therapy for women with heavy menstrual bleeding who have no structural pathology or fibroid less than 3 centimeters. Now, endometrial hyperplasia without atypia. LNG IUS is better than oral progestogen because it has higher regression rates, better compliance, and in our country, it can be ideal where long-term follow-up is difficult and there is reduced non-compliance with oral therapy. Also, it prevents unnecessary hysterectomies and support bleeding control. But it requires structured follow-up, that is, symptoms review should be done time to time and repeat endometrial assessment as per guidelines. And if there is atypical endometriosis or if there is malignancy suspected, then the patient must be referred through a specialist cancer pathway, and LNG IUS should not be used there to mask the malignancy. And according to RCOG and ACOG, LNG IUS is an effective, safe, uterus-preserving and evidence-based first-line treatment for non-atypical endometrial hyperplasia. Now this 52 mg LNG IUS can provide endometrial protection for patients using systemic estrogen. It has a lot of advantages. It stabilizes local progestin effect, reduces bleeding, avoid daily oral progestin, and useful in the perimenopausal age group with AUP, where contraception may be secondary. But again, it requires counseling, and it is quite useful in the patients who are obese, diabetic, hypertensive, or intolerant to oral progestogen. For menstrual suppression, its indication is beyond contraception. Here the aim is not only to prevent pregnancy, but also to reduce or stop menstrual bleeding to improve a woman's physical, emotional and social well-being. So it is quite useful when frequent bleeding worsens migraine, endometriosis pain, severe dysmenorrhea or anemia, and also valuable when bleeding interferes with social activities like sports, occupation and causes significant distress. So here menstrual suppression is not merely a convenience, it is a therapeutic strategy to improve women's health and quality of life. But again, counsel her properly and you should have a backup plan for breakthrough bleeding management if it persists. Then for dysmenorrhea or primary dysmenorrhea, in that case, LNG-IUS again has a therapeutic role because it reduces menstrual flow and endometrial activity, thereby causing less prostaglandin-mediated cramping, which is useful and reduces the need of NSAIDs in the cases where it is inadequate or contraindicated or when adherence is a problem. It is quite suitable for the adolescent, especially young girls missing schools, colleges due to pain. But again, counsel because improvement may take some time and it is usually gradual. And in India, in our country, where still unmarried girls putting such devices are a taboo, so we should be taking this as a last resort if all measures fail. Now in oncology and hematological setting, menstrual suppression is not merely a convenience, it can be an essential supportive therapeutic intervention. So LNG, IUDs and hormonal suppression helps to reduce bleeding complications, improves quality of life, decreases transfusion needs and supports safer cancer and hematological care which, when used appropriately and carefully planned. But again, it should be well coordinated with oncology and hematology team for individualized risk management. Now, heavy menstrual bleeding is the leading cause of iron deficiency and reducing blood loss is fundamental therapy. And LNG-IUS can improve hemoglobin and symptoms by reducing menstrual loss over time, and it can be combined with oral or IV intake with dietary counseling and other objective measures like CBC, ferritin before and after should be done. Again, counsel them properly, that will improve continuation and will improve the confidence in the patient. Therefore, it is highly relevant in India, which has high anemia prevalence, and LNG-IUS can act as a non-surgical anemia control strategy. Now, for metabolic and medical comorbidities patient, it can be therapeutically useful when estrogen is contraindicated. So it can be used when the women who smoke or obese women or women with thrombophilia or migraine or uncontrolled hypertension or previous EVT patient. In that case, this progestin-based LARC can be a safer alternative. And it can reduce in the bleeding in therapeutically beneficial here as it can improve the hemoglobin and overall quality of life. And it also can have a minimal daily adherence burden, which is important in complex medical regime. Because sometimes in these conditions there may be drug interactions. So you have to be very, very careful in using such drugs. And in that case, if you see implants can have daily adherence. With the implants, they can have a potent enzyme inducing drugs. So few anti-epileptic drugs or rifampicin or certain antiviral drugs, they can reduce contraceptive efficacy. Whereas if you use LNG-IUS, it can have a largely ineffective because its action is mainly local. So always check for drug interaction before selecting any method. Also, you should use evidence-based eligibility and counseling framework for safety and follow-up. Now, copper IUDs, we all know that it is highly effective in hormonal sleep, but often increases bleeding and cramps, so it has a limited therapeutic role. Although there are some observational data suggest its possible association with reduced risk of certain gynecological cancers, but not used primarily as a therapy. Most are manageable, temporary, and improves with proper counseling and follow-up. Common early issues are like irregular bleeding, spotting, which typically improves with time. Pain, cramping, post-insertion can be managed with NSAIDs and reassurance, but if there is bleeding is severe and if it is persistent, then you must evaluate the patient again. Then this expulsion risk is also high in the cases where there is cavity distortion or heavy bleeding. Again, you should assess the case properly. Ovarian cyst may occur in LNG-IOS patient, which is usually functional cyst and it is self-limiting. But you should always be careful about this red flag signs, that is pregnancy symptoms or severe pain occurring after that, or fever or foul smelling discharge. These all require prompt evaluation and proper treatment. Now, successful LAR use depend not only on insertion but on a proper counseling and follow-up planning, which include confirm primary symptoms, goal, that is bleeding, pain, anemia or endometrial protection. For what you are putting this, you should be very, very careful about that. Then you should discuss realistic timeline, that is that its therapeutic benefit is gradual. Women should be informed that spotting and irregular bleeding are common initially and improvement may take weeks to months, and early bleeding does not mean treatment failure. So good counseling prevents anxiety, dissatisfaction and premature recovery. Follow-up may include symptoms, scoring pain, assessment, menstrual diaries, maintaining menstrual diaries, CBC, and ferritin and anemia level concentration should be seen. Also, you can provide alternative and exit ramps, they should be told that there are other follow-up can also be done, and patients should also know that treatment is flexible and alternatives are available if problem occurs. This can include switching methods, temporary add-ons on medications or procedural surgical options if required. This assurance increases confidence and continuation. So good counseling is the fundamental of successful therapeutic LAR use. Again, endometriosis, there are a lot of drugs which has come for the treatment, but in case if you need LAR, then the practical option will be when long-term GnRH analogs are unaffordable or poorly tolerated. In Indian practice, NARRs are especially valuable in high-need group where bleeding control, anemia reduction, uterine preservation, and quality of life improvements are the major goals. The emphasis should always be on individualized care, evidence-based counseling, and patient-centered decision making, which is also been endorsed by FOXI. So, NARRs are no longer only contraceptive device; they are important therapeutic tools in modern gynecology. Mainly LNG-IUS, they can be used as a first line in heavy menstrual bleeding and hyperplasia, and it is cost-effective uterus-saving option in India, and where anemia is highly prevalent and surgery may not always be affordable. So LNG-IUS offers long-term symptom relief with minimal maintenance and non-surgical strategy, whereas copper IUDs, they are basically have less therapeutic value, but it is gold standard for effect as a contraceptive. So to conclude, I would like to emphasize that the role of LAR has evolved tremendously over the years, and today the LNG-IUS is no longer merely a contraceptive device. It is a therapeutic revolution in gynecology. Its benefits extend far beyond contraception, from controlling heavy menstrual bleeding and correcting anemia to managing dysmenorrhea, endometriosis, endometrial hyperplasia, providing endometrial protection during hormone therapy. Now in a country like India, where many women continue to silently suffer due to lack of awareness, financial limitation, fear of surgery, and poor compliance with long-term medication, LAR offers a practical, cost-effective uterus-saving solution. setting realistic expectations, explaining early spotting, discussing follow-up, and individualizing the treatment according to the patient needs remains the key of the success. Because So the future of gynecology is moving towards minimally invasive, patient-friendly, quality of life-centered care, and so thank you so much. So I would just one slide I want to say that sometimes the best contraception is actually the best therapy. Thank you so much for patient care.
Thank you Pratibha Singh ma'am for your highlights into the myriad use of LARC. Thank you ma'am.
Thank you so much, ma'am. Now I would like to invite Dr. Suman Sinha ma'am on to highlight upon the management of ward prolapse. Dr. Suman Sinha ma'am, she is a chairperson of General Surgery Committee FOXY 2024-26. She is a member Research and Good Practice Committee SAFOG 24-26. She is an SR consultant OBGYN and EH IVF and Infertility Center Ranchi, Global Synergy Hospital. Welcome ma'am. Delegates are also requested to visit stall number 17 by Avika in the exhibition area and have a look at the beautiful collection. Thank you.
So, good morning everybody. Thank you chairpersons for giving me this opportunity, but before I begin, I'd like to thank the organizers, especially Dr. Komal Singh, Dr. Reena Barnwal, all the senior members of the society and dear friends. It's a lovely opportunity to be at DHANBAD and I love the hospitality given to us. So I begin with a very important video presentation of my slide, and it consists of ward prolapse tips and tricks. So I begin with case presentation. My patient is 60-year-old female. She was admitted with complaint of protrusion of bulge from vagina with difficulty in passing urine since 2 years. She had undergone vaginal hysterectomy 10 years back for abnormal uterine bleeding, which was not responding to medical treatment, and on speculum examination, the anterior compartment defect with vaginal apex at -2 level was seen with cystocele, enterocele, and laxocele. After routine investigation and anesthetic checkup, this case was posted for surgical repair of ward prolapse. Sacrospinous fixation and repair of cystocele and enterocele was planned with craniography. Post-operative period was uneventful. As you know, dear friends, the center vaginal cuff scar below a point that is 2 cm less than the total vaginal length above the plane of hymen is known as wall prolapse, which is defined by International Continence Society. So the risk factors is given on the slide. We can have a quick look at of that.
Symptoms, we know it is pelvic heaviness, backache, a mass bulging into the vaginal canal, involuntary release of urine may be there, and some may complain of vaginal bleeding. These are the degrees and classification of what prolapse: first degree, second degree, third degree, and fourth degree. Now here we can see this incidence. It is 2 to 43%, and it can occur months, years after hysterectomy, which is very painful. Now, conservative management, we all know pelvic floor exercises and some pessaries, but it has limited use, and it is only for those who are unfit for surgery. So preventions are metabolic endoplasty, suturing the cardinal intersacral ligaments, and sacrospinous fixation. So today I will be showing you by video presentation on vaginal sacrospinous and fixation and suspension. The video is not opening. Just a minute. Can I have the video presentation? Here I am doing the hydrodissection. I am using here hydrodissection with normal saline infiltration. You can use vasopressin, you can use adrenaline. And first of all, I am going through the posterior part of the vaginal compartment and separating the vaginal wall from the vagina. As you see here, reaching the ischial spine. Now I have reached the ischial spine. I am trying to mobilize the bladder to one side. Here I am doing the fixation on the left side of the patient, sacrospinous fixation. Now I have entered the perirectal space. Just wait, it will start. Now I have palpated the ischial spine. Now I am taking bite into the sacrospinous ligament, just 2 to 3 centimeter medial to the ischial spine. This is proline number 1. One more bite I am taking. Now I am clamping the proline, keeping it at the one side. And now I am going to the anterior compartment. I am trying to separate. Now again I am doing the hydrodissection, separating the pubocervical fascia from the. It's not coming here. There's some problem. Cervical fascia is being separated from the vaginal wall. Slowly I am dissecting the fibers of the cervical fascia, trying to protect the bladder. It is taking time because I have a very big cystocele. This is the uncut video, so it is taking time. See, now I have identified the endoresil sac. I will just, it is open. Now I will cut the redundant portion of the omentum and repair the endoresil by taking bites into the peritoneum. I am confirming the endoresil sac. See, the content of the omentum is being reduced. There is that highlightation of the peritoneum around 205.
run it over. I'm going to the anterior compartment where I am stitched in the vagina from within. It doesn't have to come outside. The fluid cannot come outside we don't have to put it outside the vaginal wall. So now the sacrospinous ligament has been fixed to the anterior compartment. Cystocele repair will be completed by implantation of the. Here it is coming white. There is some problem with the बहुत नहीं इसको एसिस्टोसिल रिपेयर चल रहा है. Long time because of the use is cystocele. Cystocele repair is completed. Trimming of the vaginal walls, you can see. Now, as we do in repair of cystocele, we stitch the anterior vaginal wall by taking interrupted sutures or even continuous if you want.
Hello. evening, everyone. Carrying forward the next scientific session will be a very interesting take on endometriosis outside the pelvis by our very respected Dr. Arpita Gandhi Madam. She is founder, president, Devghar Orson NARRI Society, life member of IMA Foxy, member of SAFE Motherhood Committee Foxy. So, ma'am. And next I invite the chairpersons, Dr. Aarti Shukla, Dr. Sanjita Mandal, Dr. Swati Singhal, and Dr. Neha Priyadarshini.
I request our patrons, Dr. S.K. Gupta sir and Dr. S.K. Das sir to kindly chair this session. So please.
After vaginal delivery, the appropriate for gestations, appendectomy,
laparoscopic operation for endometriosis. Outside endometriosis has also been reported. As it can happen following abdominal surgeries, the problem can be presented, is usually presented to general surgeon, plastic surgeons, even general physicians, and rarely to gynecologists. The association of clinical symptoms with menstrual cycle should clinch the diagnosis, and the knowledge about the disease and strong clinical suspicion are needed to diagnose the condition. It has a multiple differential diagnosis like incisional hernia, scar granuloma, abscess, subcutaneous cyst, non-neoplastic tissues, even metastatic carcinoma. My first case was Nupur Das Sinha, 27 years old, para 1+0, presented in December 17 with painful swelling in the scar for 8 months. The swelling was initially very small, peanut size, and gradually increased in size. Pain had a cyclical character accompanying a menstrual cycle. Per abdomen, firm mass felt at the middle of the scar. USG showed ill-defined hypoechoic area of 1.52 to 1.17 cm. Surgical exploration revealed a firm mass of 3.5 into 1.5 cm. While dissection was done, histopathology report showed fibroblastic tissues scattered in endometrial glands with stromal cells. Malignant changes are not present. Scar endometriosis. This is the operation of the patient. Video is not working. These are the reports. Here you can see histopathological report from Lal Pathology and from Patna, Dr. R.S. Jha. Scar endometriosis. My second case was Rina Bandu, Indu Bandavan, 32 years, para 2, +0 history of swelling near the left margin of transverse scar following subtotal hysterectomy due to rupture uterus 1 year back by general surgeon. Pain was non-cyclical. Dilemma was incisional hernia, suture, granuloma, abscess, etc. She wandered from one surgeon to another surgeon, and really I was also confused whether it is incisional hernia or what. On diddling, black tarry blood came out. Surgical excision was done at my clinic. Histopathological report was scar endometriosis. Lucy Jha, 35 years old, para 2+0, presented in 2016 with severe dysmenorrhea, heavy bleeding, and painful swelling in the left margin of the C-section scar. Mirena applied in 2014, medical treatment for 2 years. Only symptomatic relief. Ultrasound report you were saying, MRI was done, and then in her case I did hysterectomy, and the report was scar endometriosis. These are her reports. MRI report and histopathological examination report. This case was the most frustrating case. She was Preeti Kumari, 30 years, para 1+0, presented with pain and swelling in the lower abdomen at the middle of cesarean section scar. It was about 6 cm into 4 cm, bluish, firm lump, very, very painful and very ugly to look at. It was just looking like nevus. Very, very painful on palpation also. Ultrasound showed scar endometriosis. Surgical excision was done on 28/10/25, and these are her reports.
Welcome Dr. Bhaskar Pal, our respected president at this moment. Policy. Thank you.
Video is not working. Actually, the principle is wide excision. Here, the endometriotic tissues are just like raftovic. ये जहाँ गिरेगा वहीं पनपेगा. So, we should have a wide dissection of the tissue, and at times we can use tumescent solution also. It should be taken out. And in my case, even after being fully satisfied that I have taken out everything, I curated that area and take out every bit of the tissue. When the patient asks, because there is too much chance of recurrence even after the primary surgery. When the patient asks, Madam, kitni baar chaku chalaoge? How many times? It is really very frustrating situation. Scar endometriosis, whether it is due to rising rate of cesarean section or faulty technique, is unknown. Popularization of miscarriage technique may be an attributing factor for the but no definite conclusion can be said regarding this. The preventive strategies are there. Video? Cesarean scar endometriosis is a rare and misleading condition has to be kept in mind while evaluating a patient with painful mass in previous surgical site. Best tackled by complete excision of the wide margin of about 1 cm and reconstruction of the abdominal wall if needed with mesh. Role of elagolix is under study. I would like to conclude by saying that the functioning of human body is a miracle. We are mere instruments of God. He channelizes His energy through us. So I always pray Him to be my side and help my hands to heal, but never hurt. Take home diamonds, of course glad. And after the war, its price has been increased doubly. So my take home is externalization of uterus only when it is needed. Throw the mop if at all used for wiping the uterus. Double layer closure of the uterine musculature excluding the endometrium. Change the gloves after you have closed the uterine musculature. Closure of the peritoneal layers. Strict irrigation of the abdominal cavity. I use 2 liters of normal saline for irrigating the abdominal cavity. Separate needle and suture materials for uterus, peritoneum and rectus sheath. कभी कभी लगता है अरे बाबा इतना कैटगट इतना विक्रिल बच गया उसी से रेक्टस कर दो, but never. Let me strive only for selflessness and become the weapon in the hands of God. Not for me to ask how, not for me to plan methods. For me it is only to lay myself down at the altar. The gods do the rest. The divine carries me. Mother, mother, take away from me this self. Let no fame or gain or pleasure have dominion over me. Be thou the sunlight and me the dew dissolving in its heat. Thank you.
Thank you, Dr.
I invite all of you to the coming 11th OSGS conference at Ames. Please come and make it a successful conference. Thank you.
Thank you, Dr. Orvita, for your beautiful case presentations of various types of scar endometriosis. But one thing, you are a bit short about this scar endometriosis of the cesarean section scar. I have faced 4 or 5 cases and have operated by laparoscope. These type of cases and only diagnosed after MRI. They come with bleeding abnormality, pain abdomen, but nothing has been detected and ultimately detected. scars, ear section scar, and it has been tackled by laparoscopy.
Yes, sir. Yes, sir.
Thank you, Gandhi ma'am. It was a wonderful take on scar endometriosis. Carrying forward, the next speech will be from Dr. Vikas Banerjee, robotic and laparoscopic surgery. An interesting take on limitations of robotic surgery. And chairing the session will be Dr. S.K. Das sir, and Dr. S.K. Gupta sir, and Dr. Neha Priyadarsh.
My respect to the FOXI chairman, FOXI president, Dr. Bhaskar Pal, for his kind presence, respected chairpersons and respected audience. Thank you, DHANBAD Society, for arranging this and inviting me here to speak some words. These are basically boundaries of conservative robotics in pelvic endometriosis. What to do and what not to do in pelvic endometriosis. I am the director and HOD in Calcutta Hospital, CMRI, CK Birla Hospital, Kolkata. Robotic surgery for pelvic endometriosis has remarkably improved in last recent years. Indeed, better results are coming and better outcome in pelvic endometriosis are quite common nowadays with robotic surgery. Factually, to my opinion, robotic surgery in pelvic endometriosis is a real boom in gynecology. Why? I will explain. Objectives there, you see, there are 4 types of pain: dysmenorrhea, dyspareunia, NMPP, non-menstrual pelvic pain, and dyschezia. To add to the misery of the pain, the conjoint pain is always invariably present, that is subfertility. Our goal of surgery is to substantial relief of pain and significant improvement of fertility. There are 2 cases. A 30-year-old lady represented with CPP and progressive dysmenorrhea with primary subfertility for 4 years, diagnosed as PE, pelvic endometriosis, and underwent hysterolaparoscopy outside but without any intervention. With USG and MRI, she was diagnosed as bilateral ovarian endometrioma with obliteration of the posterior compartment with additions all around. You know all more than me that posterior compartment is the notorious place where mostly the endometriosis occurs and habitates. There is a surgery. There are 3 instruments being used. These are basically conservative surgery in pelvic endometriosis. The dissection is mostly done by the right hand side monopolar scissors. I am not using much of the another instrument is in the top corner, that is the ProGas. You must be very careful in handling the fallopian tube, in handling the torus uterus, handling the posterior compartment. You have to map the disease. This is the revised version, basically edited version. Now I go to the back of the uterus to the left. These are the frequency additions from the back. On my left is the bipolar process. On my right is the monopolar scissors.
time does not permit. It's a 3-minute, 4-minute video. Should I jump? Another case of 34 years lady with CPP and dysmenorrhea with non-menstrual pelvic pain and subfertility for 3 years. Advanced B, bilateral ovarian endometrioma with obliteration of POD. This is a bit more difficult. First of all, when seeing at the pelvis, mapping the field, you have to decide where to start from. How do you start from? This is the plane where I decided to start my work in robotic surgery. This is another case of robotic surgery in pelvic endometriosis. But you must be knowing this is a cystectomy, right-sided ovarian cystectomy. How it should be taken out. There cannot be an ovarginous dissection. There cannot be ovarginous electropopulation. The right one is a bigger one, the left one is a bit small. These are the flimsy additions on the back of the appendage of the left side. Results. Aim was to measure the pain relief and fertility. I told you 2 points. Pain relief and fertility enhancement. 2 patients were mostly alive. The results were amazing. Both patients conceived afterwards with different outcome. One aborted shortly and the other pregnancy still continuing as on date. Now discussions and dissections. Adhesions are surgeons wrote blocking the site. So here we discuss various types of adhesions and how to kill them. Flimsy adhesions, vascular lines, pillars of pain, fibrotic stents, and then neurogenic bands. These are the 5 points we keep in mind while doing the robotic surgery. Flimsy adhesions are most commonly found that you have just seen the previous videos. Thin, transparent and loose. Sometimes they don't need energy sources also. Just poke them apart and they peel off easily. They rarely come along and they are often the surface marker or surface tension of deeper disease. Just relieve them gently and then assess what they are trying to hide. Vascular lines. As the disease progresses, neovasculature finds its own way into these structures. These adhesions are typically thicker, pinkish, deceptively alive. Managing them needs attention towards the isolation. Find their supply first, then coagulate. Choose precision that is available in robotic surgery. Skeletonize the structure, identify the planes, and then control the bed. Pillars of pain. Once endometriosis grow and build structure in place, they change anatomy. These bands will be tugging an ovary that isn't lateral anymore, but posterior, or a fallopian tube that doesn't carve but kinks, and around a rectum that does not descend but climbs. Don't divide them straightway. Do some orientation, like what they are pulling at, what is the blood supply. Release the adhesions without damaging the adjacent organs. Restore spaces first before restoring organs. Fibrotic strands. These things don't stitch, they don't bleed also, and they don't forgive either. Fibrotic adhesions are white and unmoving. Difficult part of these adhesions is that they conceal anatomy, pull nerves into unnatural pathways, flatten the vessels, and erase the surgical planes. Use clear and sharp dissection only. No blind traction or heroic tearing, stretching. Use a 5x5 dissection and you get a clear plane to work with. Neurogenic bands, the most dangerous things are the ones you can't see. Adhesions that lead to the fibrosis around hypogastric nerves, inferior epigastric plexus, and sacral nerve roots. Nerve conservation is critical and indispensable aspect of dissection in endometriosis. That is a must. Have a close examination while doing the surgery. If symptoms are disproportionate, adhesions may be neural. Dissecting this requires some patience because conservation is a key, is a must. Always prefer fiber by fiber dissection because endometriosis grows layer by layer. Conclusions, I am unable to go. I can only suggest, do not lift the uterus with the dilator, instead ease the uterus. Clear the posterior compartment fast and meticulously. Do not grasp the fallopian tubes very firmly. Refrain from overzealous electropore and too aggressive pelvic dissection. Keep it away from your aggressive dissection. Structures altering adhesions are half the problem of endometriosis. Their common presentations include a frozen pelvis, ovaries that are plastered into the ovarian fossa, and obliterated pouch of the uterus. The problem is that you can't simply cut these adhesions. At the onset, you must understand where is the pool, where is the blood. Doing all this needs space, if you don't mind, both in your head and in the surgical field. So before dissection, do some orientation. Don't injure, map the field first. Medial pararectal space is your compass of dissection. Orient using structures around it. Ureter is your constant. Never pull an organ whose attachments you haven't fully mapped. If a plane does not exist, create it slowly by using fiber vital fiber dissection. Because endometriosis grows layer by layer, I repeat. Soon you will find a clear plane to work with. The principle of total surgery dictates that we must remove all possible functional endometriosis tissue while preserving all organs and their functions, which makes nerve conservation a critical and indispensable aspect of dissection. Take-home message: robotic surgery is meant for dissection of pelvic endometriosis. What I think I measure. If done well and meticulously, in well-selected patients with proper preoperative mapping, conservative robotic surgery in advanced pelvic endometriosis will yield better and much better results with time. Also true, surgeons must know their limitations. My appeal to you, please document your work as much as possible and publish in index journal. Why? Because while I am going through the Cochrane literature, much of robotic surgery advancement is not there. So my request, where and when the people or surgeons are doing robotic surgery, including me, to publish their results. Thank you. Thank you very much.
Thank you, sir, for your beautiful exceptions of robotic surgery and separation of the tissues. But sir, I have a little doubt. Will you add some adjunctive therapy after this resection of this endometriosis cases? Do you want to keep any medical therapy?
Yes, of course, sir.
But what combinations would you like to suggest?
Nowadays we are doing it is called sandwich therapy. We are not jumping into the surgery straight away because when the patients are coming, they have traveled at least 4 to 5, 6 hours of medical consultation, different states. Then they are coming. We usually start the surgery not before 3 to 4 weeks of GNRH antagonist. Then we do the surgery. Then put up again on GNRH antagonist. Then rest of the treatment. It is called sandwich therapy. Last time I went to Hyderabad to speak about the sandwich therapy of robotics. It is there in the references.
That's a good technique of giving GNRH antagonist. But sir, do you like to suggest nowadays the new app, this is Econis or something like that?
This is a company named Econis Robotics.
Yeah.
Thank you.
Thank you very much.
There is my hospital, you've given me a time. They will show the slide where we do what of the hospital complex in Kolkata. Thank you. That is not there. Thank you very much for giving me a patient hearing. Thank you, Mr. President.
was a wonderful take on boundaries of conservative robotic surgery in pelvic endometriosis, and there were many takeaway points. And carrying forward the next session, I invite our next speaker, Dr. Soma Datta, consultant gynecologist, Kolkata, on menopause and HRT. Specialization is minimal access. And chairing the session will be Dr. S.K. Das sir, Dr. S.K. Gupta sir, Dr. Neha Priyadarshi and Dr. Sanchita. Thank you so much.
A very good afternoon to all of you, respected delegates, respected faculties and the chairpersons. Thanks to DHANBAD OBSTETRICS Society for giving me the opportunity to speak on this topic, menopause and hormone replacement therapy. We all know menopause, it is defined as 12 consecutive months without menstruation. The average age is 51. Premature menopause is when menstruation ceases before 40 years, and early menopause when it is less than 45 years. If we go by the world population dynamics at present, 1 billion women worldwide is in the perimenopausal and the postmenopausal age group. And many of them turns up to our clinic with hot flushes, night sweat, mood changes, sleep dryness, vaginal dryness, repeated UTIs and stress urinary incontinence, reduced libido, joint and muscle pain. It impairs their quality of life. So it is important that health strategies are put forward to optimize the health and quality of the life of this 1 billion women. While considering menopause, we should take into consideration that many a times the women may be asymptomatic and may later land up with chronic diseases, chronic problems like cardiovascular diseases or increased risk of osteoporosis. So while treating menopause, we should be treating it both from the management and also the prophylactic point of view. The management includes lifestyle management, routine health checkup, treatment of comorbidities, exercise, diet modification, and menopausal hormone therapy plays a very important role. Now, what is menopausal hormone therapy? It only replaces the hormone that declined during the menopause, mainly the estrogen. So, when it started, the concept started as it will conserve the femininity of the women. FDA initially approved HRT for the treatment of hot flushes. In 1988, it approved prevention of osteoporosis as one of the indications. So all was going well and good, but a WHO study came out in 2002 and it said that hormone replacement therapy led to increased breast cancer risk, increased risk of stroke and blood clot, and among other health issues. So the decade that followed, we saw a sharp decline in the use of menopausal hormone therapy with a lot of hue and cry in media. But what we didn't consider is, in the WHO study, it is only 30% women who are below 60 years of age. We didn't consider that only one type of oral combined menopausal hormone therapy, that is conjugated equine estrogen and medroxyprogesterone acetate, has been studied. They have only focused on the relative risk of breast cancer and not the absolute risk, which is very low. So in 24-25, there was an extended long-term follow-up study of WHI. And that study said, updated data indicate that women aged 50 to 59 years or where the hormone replacement therapy is started within 10 years of menopause, the benefit of MHT outweighs risk. So, in 2025, November, FDA announced the removal of all the warnings from the MHT product. So now, we are in a medically safer zone of prescribing MHT to our women. That can be estrogen, that can be progestogen, that can be androgen, that can be tibolone, or and the HRTs in various forms. Sometimes it's a tablet, sometimes it's a transdermal preparation, sometimes it's a vaginal ring. So mainly the supplementation done is for the estrogen, and the various estrogens that we consider are conjugated equine estrogen. It can be estradiol valerate and 17-beta estradiol. The doses can be ultra low dose and standard. When the uterus is being preserved, when the uterus is there intact, so along with the estrogen, start the progesterone to prevent the endometrial cancer due to incessant use of excessive estrogen. The progestogens that are used can be in continuous combined regimen or in a sequential regimen. And the products used are mainly norethistedone, metroxyprogesterone, micronized progesterone, and dydrogesterone. But to note that natural micronized progesterone and dydrogesterone are metabolically more friendly. So they have a natural effect on the breast, and cardiovascular and thromboembolic episodes are less with these two progestogens. So two types of progestogen, estrogen progestogen pills are available for MHT. One is the continuous combined regimen, and another is the combined sequential regimen. And generally in a perimenopausal age group, we prefer a combined sequential regimen, while in the postmenopausal age group, we prefer a combined continuous preparation. So while considering the prescription of hormone replacement therapy, the patient first should be counseled adequately, the risk and benefit to be analyzed, and then the estrogen and the type progestogens are to be selected. And we usually start with a minimum dose, and the patient should be counseled that she should come back to the clinic for annual checkup, particularly the breast and the mammogram. It is better to start menopausal hormone therapy immediately once symptoms appear. It can be before or after menopause. But if it is premature menopause, that is before 40-45 years, start the MHT irrespective of whether patient is having symptom or not. And it is better to start it within 10 years of menopause. Start with a low dose and titrate it gradually until the symptoms controlled. And generally, if the symptoms persist beyond 4 to 12 weeks, the dose can be increased. Patients with severe symptoms often need to start with a higher dose. How long to be taken? Generally, patient discontinue by late 50s and 60s. But age alone is not an indicator. If the patient needs it and there is no risk factor to prevent the prescription, we can give it to the patient, but yes, with adequate counseling. For genitourinary syndrome of menopause, topical vaginal creams works wonder, the topical estrogen creams. When a patient is with venous thromboembolism, it's better to avoid. Oral estrogen is contraindicated, and their transdermal estrogen preparation can be considered. Benefits of MHT, so by now we know it relieves the symptom, it improves the bone, gives bone protection, improves the heart health, decreases the diabetes risk, and improves the cognitive health of the women. Risk to be considered, breast cancer risk is there. Oh my God. What happened? So the risk to be considered, breast cancer risk is there, venous thromboembolism is there, stroke is there. So women who have a high risk of blood clots, generally we prefer a transdermal preparation, and when there is history history of breast cancer, especially hormone receptor positive breast cancer, we avoid the HRTs. So key takeaways, menopause is a natural transition and symptoms can be significant and deserve treatment. HRT is the most effective treatment for menopausal symptoms and has important long-term health effects. So MHT should be started at the earliest. On the modern MHTs, transdermal preparation has a better safety profile. Treatment has to be tailored and individualized. The time, route, dose, duration, everything depends upon the patient. Lifestyle measure complements HRT and overall health during and after menopause. All women should have an access to evidence-based, informed discussion about their options of MHT. Thank you. For the technical glitch.
Thank you for the enlightenment, and there are a lot of controversies all over, especially in our country. So I think this clarification of this should be spread so that we as Indians can use it for our benefit. Thank you very much.
Thank you so much, Dr. Soma. It was really very insightful and comprehensive talk. I have many queries which surely I am going to discuss in the lunch break because of paucity of time. We'll continue with the orations. Thank you so much.
Thank you, Dr. Soma. It was such an insightful talk. And the topics which we face in day-to-day practice. Carrying forward with the felicitation, I invite Dr. Arpita Gandhi ma'am, Dr. Vikas Anji sir, Dr. Soma Datta ma'am, Dr. Komal, Dr. Reena and Dr. Neetu, and Dr. S.K. Gupta sir, Dr. S.K. Das sir, Dr. Neha Priyadarshini and Dr. Sanchita Mandal on to the dais.
May I request our President, Dr. Bhaskar Pal sir, to please join the stage.
Please give a round of applause for Dr. Pal sir. Thank you, sir. Carrying forward the felicitation, I request Dr. S.K. Das sir to felicitate Dr. Arpita Gandhi ma'am. I request Dr. S.K. Gupta sir to felicitate Dr. Vikas Banerjee sir. I request Dr. Neha to felicitate Dr. Soma Datta. I request Dr. Komal to felicitate Dr. Das sir. request Dr. Pal sir to felicitate all the chairpersons.
Good afternoon, everyone. Moving to the next session. For the keynote address, I would request our chairpersons, Dr. Apurva Datta sir, Dr. Sameer Hazra sir, and Dr. Sadhna Kumari ma'am to please come on the stage and take your places. It gives me immense pleasure to introduce our keynote speaker, Dr. Sampath Kumari ma'am.
Can I? I don't need the CV of ma'am.
Sure.
So we are really very delighted to welcome Sampath Madam way from Chennai. Ma'am doesn't need any introduction. Ma'am is a teacher par excellence. Ma'am herself is an encyclopedia. Ma'am is a past vice president of FOGSI. Ma'am is a past chairperson of Adolescent Health Committee and whatnot. Ma'am is a past founder secretary of Tamil Nadu Officer Cancer Society. So thank you so much, ma'am, and welcome in Dhanbad. Thank you so much, ma'am. The stage is yours.
I am a secretary, Dr. Rakesh Singh. Me, सब पूरा प्रोग्राम का ऑर्गेनाइज करते हैं। तो दिन सर जो प्रोग्राम हुआ, हमारे में जो प्रोग्राम में आने चाहते हैं। सर 40 साथ में क्या जब बोला
morning all and Apurva, thanks for the nice words and the chairpersons, and thanks to Dr. Reena and Komal and the entire Dhanbad Society for inviting me for this wonderful conference. It is a well-organized conference. The topic given to me is the recurrent pregnancy loss. See, whenever you think of this recurrent pregnancy loss, what is the etiology and the management? See, there are many causes for the recurrent pregnancy loss. See, first, it can be due to the genetic causes for which still we are under process for the treatment, and it could be to the anatomical causes, that is the fusion, absorption, that is from the embryology, where sometimes it will go for the surgical corrections, and the immunological causes. Some things can be congenital and acquired. What in these cases, what can be done? It can be done for this immunological. Then the medical and the endocrinological disorders. That is the only thing which I think it can be corrected. Then our lifestyle. This is the most important topic with the recurrent pregnancy loss. See, we may be seeing lot of treatment and the investigations. Now, rather than going with the etiology and management, I want to take this topic with the recommendations and the evidence-based. What could be given? As all of us know, tender loving care. TLC is the main treatment for RPL. Before going to the topic, I am Professor Sampath Kumari from Chennai. This year I am contesting for FOGSI President post. Hope the nomination process would have been done and I hope all of you would have nominated my name. Please vote me. The election process is from August 1 to 10. See, the recurrent pregnancy loss, as I told, it is the spontaneous loss before the period of viability. That is before 24 weeks. So it can be the primary RBL where there is without previous viable pregnancy, and it can be the secondary. So whatever the etiology, depending on that, we are going to manage. So when there is, okay, there are different guidelines, NICE guidelines, RCOG guidelines. When there is 2 or 3 loss, we consider it as the recurrent pregnancy loss. So in majority of the cases of RBL, the cause cannot be found. Even if the cause is found, there may not be the treatment. So what we are going to do, what is the guidelines? The risk factors. The risk factor means it is, we cannot change these things. That is the lower age, teenage, and after 40 years the pregnancy, sometimes it may go for the loss. And the stress is present from adolescent to midlife. The stress, if they are continuously stressed, means it will lead to the RPL. And the BMI, again very low and the high. Always it should be an optimum BMI. Even low will go for the protein energy malnutrition, some it is the obesity. Again itself is a cause. And the habits, smoking and alcohol. Nowadays it is very, very important to elicit the history of smoking and alcohol, and we have to tell them it has to be stopped or it has to be reduced. That can prevent the RPM. Then the investigation. It doesn't mean that we have to do from top to bottom all the investigations. As we elicit the history, depending on the personal history and depending on the medical history, whether she is diabetic, whether she is hypertensive, whether she is having thyroid, and the family history, if there is any possible negative history in the family, which is congenital to the person, that history is very important. Accordingly, we can investigate. Then, do you think that all patients has to be screened for everything? First, we go with the genetic factors. Screening. This genetic factor analysis of the pregnancy tissue, this is not routinely recommended, but it can be done for the explanatory process because there can be some association and some other contributing factors may be present. But whether it will be helpful in the prognosis or the future pregnancy, it's not. Again, the parental karyotype, it is also individualized. Suppose if the patient has the previous congenital anomalies maybe and the unbalanced chromosome abnormalities, it has to be done, but still the prognosis will be good in the future pregnancies. And the translocation, these translocations nowadays we have latest advancement. This can be done by the invasive test and the corrections can be done. So this is the screening. And the thrombophilia, whether the hereditary, acquired. Hereditary, all of us we know that is not at all essential and not recommended. That is FEL, prothrombin mutation, MTFHR mutation, protein C deficiency, S deficiency, antithrombin 3 deficiency. These are not done, but sometimes there may be some on our rare cases will be present, which will help for the prognosis in the future pregnancy. The acquired, this acquired thrombophilia, that is APS, that is very important. It has to be done, and 6 weeks after the pregnancy loss, we can do that. Always in between the pregnancy loss only we have to do this, mainly the lupus anticoagulant and the anti-cardiolipin antibody, IgG and the IgM, which will work out for the good prognosis. And the treatment part, again, it is the weak evidence. This anti-beta-2 glycoprotein, it has no data, but sometimes it can be done and it is also possible. So the hereditary, we are not doing acquired, has to be individualized. Then the immunological, whether this immunological to be done, this anti-nuclear antibodies and HLA. Normally it is not recommended, but suppose the maternal HLA class 2 determination is present, means it has the negative impact in future pregnancy. But in this pregnancy, what is strong, whether the association with other causes, that can be individualized. So don't do all the tests for all the patients. That test which is not at all recommended, but for the completion's sake, we have to know this HLA compatibility, HLA1 and cytokines, polymorphism, anti-HIV immunity, NK cell cytotoxicity, anti-sperm antibody, anti-HLA antibody. These are all the things which is is not done, but some may be again controversial and there is no prognosis in this pregnancy or in the future. We don't have the evidence. Again, this metabolic and endocrine. If you take this thyroid, it can be correctable. Now we have the universal screening. But as far as I am concerned, these things to be done before the preconception, the thyroid, sugar value, height, weight, BMI, obesity, this all should be done in the preconception itself. Then we can reduce the complications. The test again which is not recommended. So this thyroid T3, T4, TSH you can do. Sometimes you can do the prolactin also. But this other things, elevated free androgen index, serum LH, ovarian reserve. Now we are doing this AMH and the luteal phase deficiency, homocysteine, vitamin D. These are all the things which is not recommended, but there is no harm in doing. Vitamin D, all of us will be deficient only. Without doing the test also, you can start on the vitamin D drug. Then the screening, anatomical. Now we have seen that genetic causes and the immunological causes. Now comes the anatomical. These anatomical causes can be seen with ultrasound or with the HSG or sonosalpingography. If at all needed, if you have some doubt, you can also go with the MRI. So whatever it is possible, the correction is on diagnosis in the preconception level and start with the levothyroxine. Subclinical again, once in pregnant, recheck the TSH and you will be doing the antibodies and see whether that has to be given. Thyroid autoimmunity, euthyroid means there is no need for the treatment. But once pregnant, always you do the TSH. TSH level should be done at least 3 times during the pregnancy to find the subclinical and to adjust the dosage. So this is the endocrine abnormalities and the other treatment, luteal phase. So the luteal phase deficiency, we do not have any proof for this. We are not doing the serum progesterones or the endometrium. So just like that, you can go with the progesterone. Always the progesterone has to be given, preferably vaginal. Capsule progesterone in the vaginal. Again, HCG, we are giving, but still insufficient evidence to improve the life birth. Ovulation induction, again with PCOS, the evidence is little limited. And the metformin you can give for this glucose metabolism. Something if you have in mind whether to give or not to give, if there is no side effect, you can better give the treatment. And the vitamin D, this is given for all the patients with all the cases. It is. And the uterine abnormalities, as I told, if it is a bicorporeal uterus, you do the metroplasty. If septum is present, depending, evaluate the septum, where it is, whether it is in the vagina, whether it is in the cervix, or whether it is up to the uterus, partial or complete. Depending on that, you do the septal resections. And the heavy uterus, again you do the uterine reconstructions. But whatever surgery you do, the first surgery should be the best surgery to prevent the complications. And the advanced fibroids, submucosal, intramural, if the fibroid is 2 cm and 3 cm, there is no necessity for the treatment. But if it is going to affect the pregnancy and the implantation and it may produce abortion, means in that case you can go with the submucosal, hysteroscopic removal, intramural myomectomy. No, most of the time it is not recommended. Intrauterine adhesions, again with the hysteroscopic removal can be done. Again the evidence, it is insufficient. The uterine abnormalities which I told, the cervical insufficiency, the second trimester losses, cervical weakness, whether it is the singleton or multiple, if it is the needed cases only, second trimester loss only, and if the length is less than 25, you are going for the cervical stitch. The male factor, the lifestyle, the cessation of smoking and reduce the weight, normal body weight, alcohol consumption and the exercise better. The psychological counseling is needed for both the partners. No evidence is there, but still it has to be done. Antioxidants you can give, but again it is not going to increase the labor. But if the patient comes, there is no evidence, you cannot give this treatment rather than talking something which is not harmful can be given to the patient. So the normal unexplained RPL, the vaginal progesterone. whenever you think of the progesterone, always go with the vaginal progesterone, 400 milligram. It improves the birth rate, and don't wait. As per evidence, 2 or 3 pregnancy losses. Nowadays, even 1 pregnancy loss is not tolerable by the patient, so you can go with the vaginal progesterone. This high doses intravenous immunoglobulin, again 400 milligram per kg for 5 consecutive days in the early pregnancy. And this is the treatment which is not recommended, so there is no need to go with this. And again, the psychological impact. Always it is very important when providing and planning care for couples dealing with RPL. The clinicians and clinics should consider the psychosocial requirements of these couples. Talk to the patient, listen to the patient, and try to counsel the patients. The list of investigations routinely recommended is TSH, ultrasound, and APLA, LA-DSA, explanatory purposes, ANA and sperm DNA, and selective cases, parental karyotype, and this HLA is not in our places. Not recommended is immunological test and most of the metabolic and endocrine factors. These are all the guidelines which tells the definitions of the RPL and when to start the treatment after 3 miscarriage or after 2 if the pathology is suspected and the normal karyotype is less. And thrombophilia testing, as I told, not for the acquired cases, we can go with the whatever the treatment, aspirin and the LMH. This is the genetic testing. Depending on that, you can do, already I have discussed, uterine assessment, do the ultrasound, HSD, and do the surgery whichever is needed. Endocrine assessment, thyroxine is very important. Immunological non-routine advice, lifestyle advice is very important. Antiphospholipid syndrome, the treatment has to be given at least for the till 34 weeks. Progesterone supplementation can be given at any time and for women because we don't have the side effects, so it has to be given from the day 1 till the 34 or 36 weeks. Supportive care is very important. Summary of treatment, genetic defects, counseling, and talk to them about the pros and cons. And APS after aspirin before conception, LMH once it is positive, that is the molecular weight. Uterine anomaly, do the surgery whatever is possible. Cervical insufficiency in needed cases, selective cases. Thyroid problem, it has to be corrected. And a high sperm DNA fragmentation. Antioxidants can be given, lifestyle changes, and MIPSI is the important thing. And unexplained ANA positive HLA cases, no specific treatment. Most of the time it is unexplained. In these cases of unexplained RPL, you try to give the vaginal progesterone if it is more than 3 loss, but for the practical purpose, even if it is the 1 loss, we can start giving. So the grey areas left is APS diagnosed after 2 pregnancy loss, ANA positive or HLA2, and surgical correction of the uterine defects in spite of that they may be having the abortions, and ACH and anti-TPO positive, and circular, when to do, how to do, whether it has to be given for all, that is again hyperhomocystinemia, and again unexplained progesterone and IVIG. Still it is in grey areas, but it can be continued. The take-home message is start investigations after the pregnancy loss and focus on evidence-based care. Don't make the patient text and do all the investigations. Encourage healthy habits and the limit alcohol. Provide clear information and the psychological support. Recognize that many couples may not have a clear cause. Even if the cause is found, the treatment may not help. Address the research gaps for the future care. Thank you once again. I thank the DHANBAD Society for this opportunity. And again, please support me for FOXI President. The election is on August 1 to 10. 1 to 10, you will have that. Thank you.
Thank you, Madam. It was a beautifully illustrated, enigmatic topic of our gynecologist we face day-to-day life. And thanks for whitewashing all our doubts. I don't think anybody will have any doubts after listening to her. And I wish her to see her as a president next year. And I thank you very much.
Ma'am, thank you so much, and we all hope the next time when you come, you will be as a president of FOXI. Thank you so much, ma'am.
With all your support, I should come here as president-elect next year again. Thank you.
Now for felicitation, I request our President Dr. Komal ma'am, our Secretary Dr. Ina ma'am, and Neetu ma'am to please come on the stage. come on the stage. I request Dr. Komal Singh ma'am to please felicitate Sabir Hajra sir. I request Sampak ma'am to please felicitate Apurva Datta sir. I request Sampak ma'am to please felicitate Dr. Sarvi Kumari ma'am. For the next session, Dr. C.C.
Good morning everyone and welcome once again to 6th DSOG conference. On behalf of DHANBAD Society of Obs and Gynae, we welcome our All India President Dr. Bhaskar Pal sir, President-elect 2027 Dr. Madhuri Patel ma'am, all the dignitaries present here and all the delegates. in our city. We now move on to the most prestigious segment of today's academic program, the C.C. Hajra Oration, instituted in honor of late Dr. C.C. Hajra sir. May I now request our esteemed chairpersons to grace the dais, Dr. Manjupuri ma'am, Dr. Rita Hajra ma'am, Dr. Rajlakshmi Tubin ma'am, and Dr. Reena Bardwal ma'am, requesting all hall in charges to accompany the chairpersons to the dais. May I request all hall in charges to kindly escort our esteemed chairpersons. This oration is dedicated to the revered memory of late Dr. C.C. Hajra sir, a pioneering gynecologist and obstetrician of DHANBAD and founder president of DSOG, whose immense contribution to women's health care continues to inspire generations. Born in 1930, Dr. C.C. Hajra devoted his life to the service of humanity and became one of the most trusted names in obstetric and gynecology in this region. He established the renowned R.C. Hajra Memorial Hospital in early 80s in DHANBAD, which evolved into a landmark center for maternity care and fertility treatment in the coalfield region and beyond. With his exceptional clinical acumen, compassionate approach and unwavering dedication, he brought hope and healing to countless families across and then undivided Bihar and neighboring areas. His contribution towards safe motherhood and women's well-being earned him immense respect and admiration from both patients and the medical fraternity alike. His legacy of excellence and service continues through the institution he built and through the generations he inspired. Though Dr. Hajra departed for his heavenly abode in 2014, his legacy of compassion, service and excellence continues to live on in the hearts of all who knew him and benefited from his care. I welcome all the chairpersons on the dais, and now it's my privilege to invite our distinguished orator, Dr. Madhuri Patel ma'am, to deliver her oration on prevention and prediction of preterm labor. May I request Dr. Varsha to kindly escort Dr. Madhuri Patel ma'am on the stage. Ma'am, we request you to come on the stage. May we have a gracious round of applause for our distinguished speaker, Dr. Madhuri Patel ma'am, before the oration begins. May I request our esteemed chairperson, Dr. Rajlakshmi Tubin ma'am, to introduce the orator.
So good afternoon and welcome all. The star speakers are here for the sessions. I would request all the delegates to come back to their chairs, and I would also humbly appreciate if there is silence in the hall, because a lot of effort goes into these presentations. So may I present before you the star speaker for one of the star speakers for today, Dr. Mrs. Madhuri A. Patel, President-elect FOGSI, Editor-in-Chief Jogi 2024 and Editor Emeritus Jogi, Joint Secretary FOGSI 29, Committee members FIGO Preterm Birth and ACOF GMFF Committee. She was the Honorary Clinical Associate in N. Wadia Hospital, former professor and HOD OBGY MGMH Mumbai. She was awarded with the prestigious MGS Award, Mrs. Shailaja and Mr. Narayan Pandit Award in the year 2019-20 and 2021. She was also awarded the prestigious Gunatra Charitable Medical Center Award in the year 2020-23. She also walked away with the prestigious D.C. Datta Prize for the Best FOGSI publication in the year 2024 for a chapter in the book of D.C. Datta Test Book on FOGSI Update in Obstetrics and Gynecology. Again in the year 2024, Category B Award for the Best FOGSI publication on new molecules, equipments and procedures in obstetrics and gynecology. She has delivered many iconic lectures at national and international forums, and it's our luck to have her here on the stage today. So give her a warm welcome. Speaker for today, Madhuri A. Patel, President-elect FOGSI. Madam, the mic is yours.
May I request all the audience to please maintain silence so that we can actually understand what Dr. Madhuri Patel is going to talk about, a very important topic, and that is preterm labor. Dr. Madhuri.
Can you have a slideshow of mine? Okay, respected Madam, thank you very much for your kind introduction, and I'm really happy to be here in Dhanbad. So, respected Chairperson, Dr. Bhaskar, Dr. Sampat Kumari, and my all dear friends, very good afternoon to all of you. At the outset, I would like to thank Dr. Reena, Dr. Komal, Dr. Neha, and entire Dhanbad society for giving me this opportunity. And I'm really honored to deliver this prestigious, oration, Dr. C.C. Hazra oration, who was a founder member of the Dhanbad OBGY Society. So I'm really, really honored for that, and I'm really thankful to you. So I'll start my talk, prediction and prevention of preterm labor. Despite of the advanced management in preterm labor remains one of the most challenging obstetrical problem and continues to be the major cause of perinatal mortality and morbidity. Incidence is about 5 to 8% globally, 18%. 15 million babies are born preterm every year, and preterm birth complications are the leading cause of death among children under 5 years of age, responsible for almost 1 million deaths per year. 3/4 of these deaths could be prevented with current cost-effective intervention. So what about India? India contributes 3.6 million premature births every year. So now, as preterm labor, we know it is born too soon. If there are a regular uterine contraction, 4 in 20 minutes or 8 in 60 minutes between 22 to 37 weeks of gestation, with cervical dilatation greater than 1 centimeter and effacement is more than 80%. It can be suspected when uterine contraction occurs, but is
obstetrics from him. I worked with him for quite some time, and his daughter, Dr. Rita Hazra, is sitting here, and in the audience also I can find his son, Dr. Sameer Hazra. Please stand up. Dr. Nilima Hazra, Nilima Ghosh, and Dr. Shushma Sutradhar. So all are his bright children, and he was such a good teacher and mentor that whatever I am today. And Saroja Hazra is his daughter-in-law. I request Dr. Saroja Hazra to also stand up. I have worked with all of them, and it was also, he just treated me like a family. So it is a big pleasure for me to be here. And he had a son, Dr. Vikas. Unfortunately, we miss him today, both Vikas and Dr. Prema. They had a very unfortunate fire incident in his nursing home. You must all have heard it. So we remember him today. His memories are alive in my heart, and I think in all the doctors of Dhanbad and also all over India. Vikas was very active, very handsome to look at also, and I think he had got good managerial skills also. He was managing the nursing home very well, what I remember, because I was also a young kid when I worked with him. So over to you, Dr. Madhuri. It is very befitting that a person as learned as you is awarded this oration. So may you please proceed, Dr. Madhuri Patel.
Thank you, Dr. Abaji, for giving me such a details about sir. And I'm really honored to deliver this oration. So I think I should continue. So if you look at the, because we are already late by 2 hours, 2.5 hours, Bhaskar is also waiting for the oration and the inauguration. So I think, no, it is not coming on the screen. There it is coming, yeah. So I would like to say that what happens during normal labor? There is a physiological activation and the labor starts. While in preterm labor, there is a pathological activation and labor starts. So the terminal pathway is just the same. So what causes pathological activation of this pathway? It is what you call as preterm parturition syndrome. We all are aware, cervical diseases, uterine overdistension, especially multiple pregnancy and hydromios, uterine ischemia, infection, that is the most common cause of the preterm labor, especially when you don't diagnose asymptomatic, infection. And then comes the endocrinal disorder like hypothyroidism, allergic phenomenon, and abnormal allograft reaction. Now if you look the other risk factor, the girl or the lady, woman less than 18 years or more than 35 years, they are prone to that. Then of course previous history of preterm labor, then low pre-pregnancy weight, smoking during pregnancy, and dietary deficiency. These are also the high risk factors. So can preterm birth be prevented? We know the risk factor, but those are only 50% risk factors we know. 50% are idiopathic. So we don't know the cause, so on those cases we can't prevent. But we have certain methods. Vaginal examination to assess the cervical status, cervical ultrasonography, that is EVS, screening for bacterial vaginosis, and screening for fetal fibronectin in cervicomucous secretion. Now vaginal examination, when I was resident, we all were resident and all, we used to do every 4 weekly cervical, length of the cervix. But that is out and we are not doing this anymore. So we are with the transvaginal sonography. So whenever you do transvaginal sonography and the cervix is less than 25 millimeter, that is 2.5 millimeter, when it is done between 16 to 24 weeks of gestation, then there are more chances she's going to go in the preterm labor. Now I would like to say that by default, we all have become, obstetricians have become sonologists, and therefore whenever you do sonography, you should do it properly. I would like to show you one video where you can see the internal os and the cervical length is quite big, but as soon as you give transfundal pressure, the internal os opens up, and here as a sonologist, we as a sonologist can miss this finding, and that's why I insist that whenever you do sonography, you do perfectly so you don't miss anything. Now there is something called as asymptomatic bacterial vaginosis and vaginal pH. Nowadays, if you see the recent generation, they hardly do per speculum examination and they send all the things for sonography. But you must do speculum examination at the first time where you can find the asymptomatic bacterial vaginosis or any cervical lesion, and when the patient complains to you. It has been reported in the prospective study of almost 1700 antenatal women asymptomatic. They had a asymptomatic bacterial vaginosis with pH of more than 4.5, which increased the preterm birth by 3-fold and of course premature rupture of membrane by many folds. So now let us come to the fetal fibronectin. Now this is the fetal fibronectin is produced by the fetal membrane and its function to join adherent placenta membrane and the deciduum. Now up to 20 weeks, you can see in the vaginal mucus this is normal. But if you see this substance, that is fetal fibronectin, in the cervicovaginal mucus, that means there is placental membrane and the decidual separation has occurred, and that's the reason why it comes in the vaginal mucosa. So you have to think that she is going to go into preterm labor. So there are many studies have been carried out, and I have taken from the meta-analysis that there were 542 articles, 14 systemic review, and it was associated that if you find in the cervicomucous membrane fetal fibronectin, she is likely to go into preterm labor, and the value is reported then more than 50 nanogram is the positive result. Now, what is happening? If you want to give a more correct report, then you can combine this trace, that is transvaginal sonography and fetal fibronectin. If the transvaginal sonography is negative and the fetal fibronectin is negative, then she is very, very less likely to go into preterm labor. These are other biomarkers, what you call as phosphorylated insulin-like growth factor binding protein 1. This is known as actin parters, and many places it is available, and if it is positive, we know that she is likely to go into labor. There is another one, what you call as placental alpha macroglobulin 1, which is also what you say immunochromatographic test, and it can also tell us whether she is likely to go into preterm labor. The principle remains the same, that the substance, they come either from the fetal membrane or the dysuria. When the placenta membrane and the dysuria get separated, the part of the substance comes in the cervical mucosa and the vaginal mucosa. And that's the reason we say she's likely to go into preterm labor. But now what is the FDA? They say, which are the tests you should follow? One is, what you call as fetal fibronectin, and that is done in the mid-trimester of pregnancy, which is strongly associated with spontaneous preterm labor. And the other test, a positive salivary histriol more than 2.3 nanogram is also associated with preterm labor. But remember, these tests has more negative predictivity. Is when they are negative, we know they are not likely to go into labor. But when they are positive, it is not that reliable compared to negative predictive value. Now, when I was going through the literature and I found first trimester lower maternal serum pregnancy associated plasma protein A and placental growth factor are likely to go into preterm labor. So if you see, there was a study done in the 9,298 patients where they underwent, a screening test, that is dual marker, that is Papa A test and placental growth factor, and they found they were very low. So it indicates the patient is likely to develop placental insufficiency. So patient is coming to you at 11 to 13 weeks and you are telling that she is likely to go to preterm birth. So how will you manage this? So we have to try to find out those 50% causes we know. And if you don't know, we have to treat, empirically. But you can counsel the patient and relative that she is likely to go to preterm birth, and that's why I'm starting the empirical treatment, and she has to be delivered at tertiary or the other higher center where the facilities are available. Now there is something genomic. We know the technology is moving fast, and one day we'll recognize the genes for the human parturition, and once we recognize them, we can do slicing of and treatment, and that will be the end of preterm problems. So let us hope it comes as soon as possible. Now how can you prevent this? Primary prevention and secondary prevention. When you say primary prevention, that means she is not pregnant and you are trying to treat other causes which I mentioned. And secondary prevention, now she is pregnant, we have found out something and we are trying to treat the patient. So what is the secondary prevention? Mainly is role of prophylactic antibiotic, role of cervical sarcolage, and role of progesterone. So there are many studies have been carried out the use of prophylactic antibiotic. But remember, previous history of preterm labor is because of the infection. Those patients are going to get benefited if you give antibiotics in this pregnancy, especially second and third trimester. Nowadays, there are something called as our prebiotic and probiotic are also coming, lactoferrin and all. That can also, you can give them, especially, patient, very precious pregnancy, you can give orally, and that can also, prevent the preterm labor. So this is one thing I would like to add. And secondly, now recommendation of prophylactic cervical sarcolage. Then, as we know, the indications are on TBS at 16 to 24 weeks of pregnancy, the cervical length is less than 2.5 centimeter. Then patient who had undergone, premature rupture of membrane in past and cervical trauma. So cervical stitch definitely helps when you do in an indicated patient. Now let us do, see that here we have studied as my team, and we have studied at Nauroji Wadia Maternity Hospital for 1 year about the cervical review of the role of cervical sarcophagus in prevention of preterm labor. There were 95 patients in that year. They were given a stage depending upon the history indicating, sonography indicated and clinically indicated patient or combination of them. There were 95 patients, but 5 were lost for follow-up, and so we analyzed 90 patients of the cervical stitch. And there were preterm labor in our institute was 17.4%. There were, history indicated were 51%, but sonography indicated were 85, almost 86%, and clinically indicated hardly 8%. And we did a McDonald method in 86% and Shirodkar in 13%. But remember, McDonald is the easiest operation, but whenever it is indicated, you must do Shirodkar, which can give you the better result. Then 13.3 had an election section, and 35.5 had an emergency cesarean section. Now there was a very interesting case where we did a trans-abdominal circulage. The trans-abdominal circulage has a really place in obstetrics. She was Mrs. ABC, 30 years old, gravida 7, preterm vaginal delivered. She had a first fresh stillbirth, and then she had 5 abortions. So first 4 abortions were first trimester abortion. She was investigated and found the septum. So septum dissection was done. She conceived for the 5th time. She aborted 20 weeks of pregnancy. So what I mean to say, whenever you find something abnormality in the uterus, then you should also think about the cervical incompetence, and it is better to take one stage. Then in the 6th pregnancy, we took a transvaginal cervical stitch. In spite of that, she started leaking and she had a fresh stillbirth. So in 7th pregnancy, what we did, we admitted her. I work with Padia Hospital, where it is a trust hospital, so the cost is not that problem. So we kept her admitted. At 12 weeks, 13 weeks, we did a sonography for NG and dual marker. Everything was fine, and we took her for the abdominal stage, and we kept her up to 34 weeks of gestation and did a cesarean. And she had a baby was kept because baby was almost 1.89 kg and was kept for observation in NICU, and she was discharged on the 8th day. So the trans-abdominal stage plays very important in certain cases. So our deliveries were preterm between 32 to 37 weeks, almost 38%. But remember, these 32 to 37 weeks of pregnancy, they have, and the baby, survival rate is high. And we had a term pregnancy, almost 51%. The NICU stay was for the 28.7%. Then average gestational age was 35.1 week, and weight was 2.4 kg. So if you consider the 90 patients, 2 had an abortion, 1 had IUFD, the below 37 weeks, but after 33 weeks there were 44 patients, the babies, and after 37 weeks there were 43, and there were NND in 14 cases. So out of 90, 70 babies went home. So our success rate was 81%. So Zakia, Klein, Doris we saw, and their success rate also has been reported almost 76 to 80%, which coincide with our study. Now let us come to the progesterone, which we are using in and out. All the obstetricians are using for various conditions. But what about the preterm labor? So remember, whenever you use progesterone, whether it is natural or synthetic, it will not arrest the labor. For arresting the labor, you have to give, tocolytic, and once the labor gets arrested, then she can continue the pregnancy with this progesterone. So you have to remember, it cannot arrest. Once the arrest occurs, then only this will work to continue the pregnancy. So how the progesterone works? It works at a different level. We know whether it is a preterm or a term pregnancy. And when they go in labor, the progesterone is withdrawn. On that basis, we give the progesterone. So it works at the placental level, which it regulates the cortisol, controlling stress hormone like CRH. Then it works at the amniotic fluid level, which reduces the prostaglandin production. At fetal membrane, it reduces the pro-inflammatory cytokines, so prevent the apoptosis and prevent the premature rupture of membrane. At myometrium and cervix, it reduces the inflammation and keep the uterus quiet. So there are many theories, but this I found quite appropriate. And there are many studies carried out, and when they found a short cervix or when there was a history of preterm labor, they started this progesterone from 16 weeks onward and continued up to 37 weeks of pregnancy. And depending upon your NICU facilities, some continued up to 34 weeks and they had a good, pregnancy outcome. So now there is a new era is coming. We are always with the micronized progesterone, natural micronized progesterone, that is vaginal. We agree that vaginal is superb and we agree for that. But now new thing is coming up, oral natural micronized progesterone, sustained release. And when you give 400 milligram OD or 200 milligram of BD up to 34 weeks, starting from 16 weeks, it gives excellent result. Because what happens, this controlled sustained release, what happens in the small intestine, it goes directly into the lymphatic circulation and then directly into the main circulation. While from colon, it gets absorbed from the mucosa and directly going to the systemic circulation. Now they are using, nowadays with the oral sustained release tablet, they are using a new technology, what you call as aromat technology, where it is broken down, progesterone is broken down in very micro pieces, so absorption increases, and that is called micro booster. What micro boosters are? They are solubilized agent which causes progesterone to get soluble and then it causes increase in the absorption. So this EroBoost has clearly given for the progesterone sustained oral the good outcome. Now it has been reported that existing oral natural micronized progesterone SR formulation, it works more than 3.5 times absorption is more. So this newer technology is really taking care of that. So the sustained release will be released over 16 to 24 hours and half-life is 18 hours. So once a day, it is very practical for the patient to take this tablet. There were studies done with the oral natural micronized progesterone sustained release 200 milligram BD and 400 milligram OD with the vaginal 200 milligram BD. The efficacy and safety were comparable. So why I'm saying the vaginal is we are considering best, but oral is also good and the efficacy and the safety is also good. So with their patients which are not willing to do vaginal, vaginal tablet, we can definitely recommend this patient. So there are again many studies are done and they found the oral natural micronized progesterone SR are better and they are comparable with the vaginal progesterone. And you can see they started in November 12 and then it increased in January 22, almost 10.4 crores of this prescription of given. So if you consider this, if you see the chart, nowadays 53% are using oral, 33% are using vaginal, 11% are using injectable, and only 4% are using natural micronized progesterone gel. So let us look at the injection. Now, we have so many options, but sometimes we have to give a progesterone injection. That is 100 milligram intramuscularly every third day. and it also gives a good result. Then the vaginal gel, they have done a study in patient with history of preterm labor in 547 patients and patient with short cervix in 104 patients, and they gave a very good result. The only problem with the gel, when we came, we started with the gel, but because of the stickiness, patients don't like to use them, the gel, but the results are very, very good. Now, status of synthetic progesterone in preterm labor. I remember when I was resident, we used to use 17 alpha hydroxyprogesterone caproate every weekly, starting for the second abortion, and we used to continue up to 22 weeks. And then microprogesterone came, natural micronized progesterone came, so we stopped using it. And again it came that we should use hydroxyprogesterone caproate, and now it is said the hydroxyprogesterone caproate has been withdrawn from the market, and there are many European studies, all these studies have said that they are withdrawn because it gives risk, there is a risk of upstream for the cancer. So whenever you are giving progesterone, this alpha hydroxyprogesterone, you have to remember that the child is likely to have cancer, and there are so many studies are carried out. In between I was talking to Bhaskar said that I think RCOG, hydroxyprogesterone, this caproate is, because the efficacy is not known, but there are certain people, they are saying that offspring will have cancer, and that's why it is withdrawn from the market. Now what about dydrogesterone? Dydrogesterone is very good drug. We have used since years together, but as far as preterm labor is concerned, it is still not approved by the DCGI. So natural micronized progesterone has a definitely upper hand over the dydrogesterone. So again I was going through another study where I found omega-3 fatty acids during pregnancy to reduce preterm birth. So there was a study done by KP Best in 2022, and they found that when you give omega-3 fatty acid less than 20 weeks pregnancy up to 1000 milligram, they prevent the preterm labor. So whenever we use omega-3 fatty acid, usually we use to increase the weight of the baby, but it is also beneficial in preventing preterm births, especially when you give before 20 weeks of pregnancy. Management I am not going to talk, but you must say that when patient comes with preterm labor, hospitalized and avoidance of the physical exertion by bed rest, inhibition of the uterine contraction with chocolysis, corticosteroid to induce fetal lung maturity, treatment of infection with antibiotic, and magnesium sulfate for neuroprotection should be given. And whenever possible, if you are at your nursing home, you don't have the facility of NICU, please transfer the patient in utero if possible. That will give the better result. So, conclusion, even we have all the research efforts, still the spontaneous and the premature labor has remained challenging because of the high rate of perinatal mortality and morbidity. Secondly, prediction, prevention and treatment can improve the perinatal outcome. Progestin, cervical cerclage with antibiotics, and nowadays I can add lactoferrin. With that, it can definitely play a major role in improving perinatal outcome. And we should not lose the track of proper history taking, which will tell you whether she is likely to have preterm labor or not. So history taking is very, very important. And at the end, I would like to say, there is no way to get experience except through experience. And I would like to thank all of you for the patient hearing, as well as thank you for electing me as a President Fox Day for the 2027. And during my presidential year, we'll hold hand of each other and work for the patient, women's betterment, women's advanced treatment of the women. Thank you once again for giving me this opportunity.
Thank you, Dr. Madhuri Patel, for a very good overview of such an important subject as preterm labor. And I think that all obstetricians here should also focus on two more things. One is in the postnatal period, in case your patient has got a low BMI or anemia, please make sure you correct it before her next pregnancy. And second is to have a look at the cervical length. when you get the second trimester ultrasound. And also avoid iatrogenic premature births. I think that is what is most important. We all can give 1 or 2 extra weeks to the babies if we are not under stress and we are in no hurry. So I thank you so much, Dr. Madhuri. It was indeed a very good overall overview of preterm labor. Thank you so much.
Thank you so much, Madhuri ma'am, for an enlightening and insightful presentation. May I now request our esteemed chairpersons, our President Komal ma'am, Secretary Dr. Reena Barnawal, Vice President Dr. Renu Upadhyay ma'am, Dr. Neha Priyadarshini, and myself, Dr. Neetu sir, to please come forward for the felicitation. It is my honor. Dr. C.C. Hajra's legacy still lingers in this city. We are privileged to have them here. May I request Dr. Rita Hajra ma'am, Dr. Sameer Hajra sir, Dr. Saroja ma'am, Dr. Sushma Sutradhar ma'am, Dr. Nilima Ghosh ma'am, and Dr. Swapnendu Ghosh sir to please come on the stage and grace the occasion. We have a big round of applause for all the dignitaries and our beloved C.C. Hajra sir family is with us. Can we have a big round of applause for the orator, Dr. Madhuri Patel ma'am, President-elect 2027, Dr. C.C. Hajra sir, family, all the dignitaries on this dais. May I now request Madhuri ma'am to felicitate our chairpersons for this oration. May I request Dr. Rita Hajra ma'am to kindly come forward for the felicitation. And Dr. Abharani Sinha ma'am, who has worked so many years with Dr. C.C. Hajra sir. It's an honor to have you on the stage. may I request Dr. Manjupuri ma'am to come forward for the felicitation. Manjupuri ma'am. May I request Madhuri ma'am to felicitate Dr. Manjupuri ma'am. I know the hall is hungry, but I request ma'am to felicitate Dr. Sameer Hajra sir. I request Madhuri ma'am to please felicitate Dr. Rajlakshmi Tubin ma'am. Thank you so much ma'am for the honor. And may I request Madhuri ma'am, Rita ma'am and Sameer sir to felicitate our VP Dr. Abharani Sinha ma'am for gracing the occasion. Thank you so much ma'am. Thank you everybody. I'm really sorry, maybe we always forget the main person behind the stage. May I request Rita ma'am to and Madhuri ma'am. I'm really sorry because she's always our secretary, the person behind everything. It's an honor to felicitate Dr. Reena Barnwal, Secretary, DHANBAD Society of Obs and Gynae. हाँ ये सेम हो जाता है ठीक बोले मैम वो हो जाते सब बच्चे Hello. I know we are getting late, but an oration is not merely a lecture but a tribute to excellence, wisdom and lifelong commitment to the field. We now proceed to the next oration, Dr. Leena Priya oration. May I now request our chairpersons to kindly take chair on the dais. Dr. S.K. Das sir, Dr. Pratibha Rai ma'am, Dr. Kavita Priya ma'am and Dr. Komal Singh ma'am, requesting our hall in charges to escort our chairpersons to the dais. inspiration is dedicated to our beloved Leena Priya ma'am, an unforgettable and iconic personality of Dhanbad in the field of obstetric and gynecology. Dr. Leena Priya, MS FRCOGs, was the last among our revered founder members of DSOG to leave us. A legendary figure, she devoted her entire life to the cause of women's health in the coalfields. She was one of the strongest pillars of PMCH, now known as SNMCH, and played a pivotal role in building the Department of Obstetrics and Gynecology alongside her equally illustrious husband, Dr. Shankar Priya sir. Her extraordinary zeal and dedication were reflected in the remarkable reduction in maternal mortality, decreased incidence of severe anemia, and improved fetal survival rates in our obstetric and gynecology unit at PMCH. I welcome all the esteemed chairpersons on the dais. Dr. Leena Priya ma'am also had an unwavering commitment to DSOG. Nearly 5 decades ago, she took the initiative to begin the groundwork for the fledgling DSOG and nurtured it with immense care and devotion. She served the organization selflessly as secretary, president, and later as patron. We cherish wonderful memories of her as an exceptional teacher and a clinician, a mentor, guide, and above all, an inspiration to generations. She was truly an icon and the epitome of women empowerment. Ma'am, your legacy continues to inspire us every day. You are deeply missed, but forever remembered. We welcome again all chairpersons on the stage. With great honor, may I invite our charismatic and dynamic All India Foxy President, respected Dr. Bhaskar Pal sir, to grace the stage and deliver his oration on endometriosis, past, present, and future. A hearty welcome to you, sir, on behalf of DSOG to our city once again. May we have a big round of applause for our esteemed speaker, Dr. Bhaskar Pal sir. Though he hardly needs an introduction, yet following the protocol, may I request our respected chairperson, Dr. Kavita Priya ma'am, to kindly introduce the speaker to the audience. Dr. Priya ma'am.
It is the great privilege of Dhanbad Society that Dr. Bhaskar Pal, President Foxy, is going to deliver the Dr. Leena Priya oration for us today. Sir needs no introduction, but still I will offer you these few words to explain how deeply honored we are that Sir is present here. Dr. Bhaskar Pal, DGU, MD, Bombay, DNBE, FICOG, FRCOG, is a senior consultant gynecologist at Apollo Multi-Speciality Hospital, Kolkata. He is the President Foxy 2026.
That would be enough.
Okay, so needs no introduction, so we will now proceed with the
Thank you
oration.
very much. It's a pleasure being here. And I will speak on endometriosis, past, present, and future. And the subjects where we know the least, we can talk for the longest. And endometriosis is one of such things that every year we think that many things which we've been teaching are not any longer useful. I bring you greetings from Kolkata. Just to set the context, endometriosis is the presence of ectopic endometrium and an abnormal growth of tissue which resembles the endometrial tissue and present in other locations other than the uterine cavity. Usually found in the peritoneal surfaces of the reproductive organs, can occur anywhere in the body. These days we see in the oral mucosa, we see in the diaphragm, and we have also been seeing in the scar and etc. It affects around 6 to 10% women of the reproductive age group, and the prevalence is around 1/3 of some fertile women. Endometriosis management is shrouded in controversy. The outcome is often unsatisfactory, and recurrence is the rule. Because of this unsatisfactory outcome and the risk of recurrence, the management of endometriosis does not necessarily aim at complete resolution of the disease. That is not possible. So I keep telling my patients when they come with endometriosis, most of the times it is a frustrating situation, and I tell them the only thing that is guaranteed in endometriosis is recurrence. So you don't have to get treated by me, you can get treated by anybody you want. But please don't get treated by somebody who tells you, I will cure your endometriosis. If we look in the social media, we have a lot of people talking about how they cure endometriosis, but it's not possible. So the aim of treatment would be any of these three or a combination of them. One is to reduce pain. Number two is to increase the possibility of pregnancy. And number three, to delay the recurrence for as long as possible. Now for those who are as old as me or older than me, this is what we studied when we were postgraduates. That there are several theories. One of them is retrograde menstruation, or synovic epithelial metaplasia, or hematogenous or lymphatic spread, or direct transplantation of endometriotic cells. Exactly what Orpitadi was talking about when she was talking about how to prevent scar endometriosis. But no single theory explains all the varieties of endometriosis, and there may be different kinds of endometriosis might be having different etiology. The diagnosis was by laparoscopy. We were taught that on laparoscopy, if you see burnt matchstick appearance or powder burn appearance, that is endometriosis. At the present, we know that there are many other presentations of endometriosis on laparoscopy. The only scoring we had was the American Fertility Society. And we would do an ultrasound only with a diagnosis of hemorrhagic cyst. At that point of time, we did not know the typical features of endometriotic cyst. Adolescent endometriosis was unknown, and dysmenorrhea and dyspareunia was the presenting complaint at that point of time. And what was the management? We'll give a 3 to 6 month empirical treatment for training, and then we will stop the empirical treatment and the pain would recur, and we'll do a laparoscopy. If there is powder burn, we'll say it is an endometriosis. If it is not powder burn, then we'll say it's a normal laparoscopy. If we found laparoscopy, most of the times we'll give If we found endometriosis on laparoscopy, most of the times, depending on the severity, we'll either give post-operative GnRH analog for 3 to 6 months, or in milder cases, or for prolonged treatment, we'll give the combined oral contraceptive treatment. The medical treatment was either inducing pseudo-pregnancy or pseudo-menopause. We use NSAIDs and to start with, usually in combination with progesterone or combined OC pills. Danazol was the hot drug. Means today's hot drug, for example, in 2026 is semaglutide, in 2023-24 it was dydrogesterone, at that time it was Danazol. Not a single exam would go by whether you'll either not have a short note on Danazol or you'll be asked on Danazol in your orals. And then there were GnRH analogs which were at that point of time very expensive. Danazol, we all know that it works well. It works like a progesterone, and it was used in 400 to 800 milligram per day for 6 to 9 months. But it had horrible side effects like oily skin, acne, dimpling of voice, decrease in breast size. But even then we used it because we didn't have anything better. And what was the surgical management? Cauterization of endometriotic spots. Most of the women who came with a large endometriotic cyst usually would have a laparotomy and would have an oophorectomy. And many women will have a hysterectomy and bilateral salpingo-oophorectomy, abdominal, and at a very early age. Not we have to go back to our post-graduation. Till around 5 years back, we are operating on all endometriotic cysts were 4 centimeters or larger because that's what the guidelines told us. We would do either a drainage and diathermy or we do a cystectomy. We will also restore the tubo-ovarian relationship and do adissiolysis. Now, endometriosis and infertility, the surgical treatment evolved. We always say that in stage 1 and 2. But if we look at the evidence, it comes from 2 very small studies. In stage 3 and 4, we knew gradually that ART was better. Before IVF, we drained or removed the endometrioma because we normalize on the lot of gynecologists who say very common, once you get married and have children it will get cured. Unfortunately it's not so. The same study that she had diagnosed with endometriosis, the average 9 years, which is endometriosis. Normal. I would reserve the use in our country. There's a culture mass. Telazol we mention only to avoid. The reason we avoid telazol is we've got drugs or even more efficacious than telazol with a much better adverse effect profile. Diagnosis, even today when we speak in May 2026, we say laparoscopy is the gold standard for the diagnosis of endometriosis. But imaging is catching up rapidly and maybe very soon we'll be able to say that you do not need to do a laparoscopy. The gold standard is imaging. So there is no hurry to jump to do a laparoscopy, but imaging, what the mind doesn't know, the eyes cannot see. So if you want to have a dependable imaging for endometriosis, you need to know somebody who can image for endometriosis. And a lot has been published by this International Deep Endometriosis Analysis Group, also called the IDEA group, in terms of how to detect endometriosis on ultrasonography. And this is the original paper of 2016, where they described this 4-step approach. The first step approach was routine evaluation of the uterus and the adnexa, and you look for presence of adenomyosis or presence of endometrioma. The second step was evaluation of transvaginal sonographic soft markers like site-specific tenderness and ovarian mobility. Number 3 was assessment of the POD using a real-time ultrasound. And the sliding sound is negative, that means. And the fourth step was assessment for deep endometriotic nodules in anterior and posterior compartments. A sonography for endometriosis is not only a sonography. It starts with a history, specular and bimanual examination where possible. You look for adenomyosis, and if it is present, you report it according to the FIGO-BUSA guidelines. If you find an endometrioma, you report it according to the IOTA guideline. You look for the mobility of uterus. If you see a uterus which is a question mark size, that means that the uterus is fixed. You look for kissing ovaries, you look for additions of ovaries to the uterus or to the lateral pelvic wall. You see for the sliding sign deep endometriosis and look for deep endometriosis. If a transvaginal sonography is not possible, we can use a transrectal or a transperineal ultrasound. The same group later published in 2017, when they compared transvaginal sonography and MRI, and they found TVS is as good as MRI for detecting deep endometriosis involving the rectosigmoid, uterosacral and rectosigmoid. Even then, a lot of people resort to MRI because MRI is not operator dependent, if you can read it yourself. And the main indication for MRI is only if you are planning excision of deep endometriosis, because you need to know the exact depth of your lesions, especially when it is on the urinary tract or on the intestinal tract. At the present moment, we use several staging or several scoring. We still use the modified American Fertility Society 1. The endometriosis fertility index is something which is very useful in counseling patients. And the NCN classification is essential if you are operating on deep endometriosis, because that is where you compare data across the centers to see what are your results. I will skip that and take you straight to the endometriosis fertility index. Essentially, it gives you a scoring because on historical points and also on the surgical features. And based on that, depending on what the score is, you can actually give an estimated percentage of pregnancy in the coming years. So basically, you can see that the higher the score is, the better is the chances that she will conceive in the next 2 years or 5 years, and you can actually give her that chance. This is the ACN classification, but I'll move on to medical management. We have a lot of drugs in our hands now. NSAIDs, usually started by the general physicians, and we would continue NSAIDs in conjunction as an adjuvant to other treatment, which usually is either a progesterone or specifically Dynogest or a combined oral contraceptive pill. Now please remember, when you are using the combined oral contraceptive pill in dysmenorrhea or rather severe dysmenorrhea, you have three options: is to put them on cyclical 21/7 or 24/4, or you can tricycle or quadricycle the pill. Many a times we would do that to reduce the number of periods, but at the time what we do is we give them continuously, which means they take the pill without any break. And of course the patient would ask, does that mean that I will never have a period? The answer is nature will decide when you will get a period. Means whenever you have a breakthrough bleeding, stop the tablet for 4 to 7 days and start exactly from where you had stopped earlier. We can also use GNRI Genologues, but unfortunately you can use it only for up to 6 months. If you want to use it for 6 months, you need to give NARRI therapy. You can use an LNG IUS as a prevention. We can use progesterone implants like lipometroxy progesterone acetate, which earlier, before Dynogest came into the market, we used to say it is the poor man's GNRI Genologue. You can use aromatase inhibitors like anastrozole and letrozole. And again, I will say danazole, mentioning only to avoid. I will not say go into Dynogest. I think, as we said, Dynogest was a medication 10 years, 6-7 years back. But important to remember that Dynogest is used as an oral dosage of 2 mg per day. Increasing the dosage does not increase the efficacy. That's number one. Number two, it is the only progesterone which has shown potent inhibitory activity on the growth of endometrial tissue. So the lesions can regress and can be used for 5 years. And now there is data that you can use it for 7 years. In another 2 years, we'll get data for safety of longer term use. What about aromatase inhibitors? Aromatase inhibitors called remission of pain. It reduces visible endometriotic lesions, but the symptoms will recur soon after the treatment is discontinued, and there are several side effects, including bone losses and hypoestrogenic symptoms, and that is why it is usually used in combination with oral contraceptive pill. You can use letrozole 2.5 mg per day or anastrozole 1 mg per day for 3 to 6 months, and it is particularly useful when you have DIE in the posterior compartment. At the present moment, elagolix is no longer the future, but it is the present. We have several oral GnRH antagonists, but the one which is useful for endometriosis is elagolix, and the data comes from the ELADIS trials, and 2 dosage were used. One is 150 mg per day and one is 200 mg twice a day for 6 months. And it showed that it had, especially with the higher dose, the pain improvement was brilliant to the extent of 75%, whereas for non-menstrual pelvic pain, the effect was more or less similar with the 2 dosages. But the problem is it does give rise to hot flushes, higher serum lipids, and decreased bone mineral density. And these trials were essentially done in women between 18 to 49 years of age who had surgically diagnosed endometriosis along with pain. So at the present moment, there are 2 dosages which are there. One is 200 mg twice daily for 6 months. You can use it for 3 to 6 months. Now this is the one which lowers the estrogen levels significantly, so women will get a hypoestrogenic symptoms. Unfortunately, beyond 6 months of usage, this is not recommended because of hyperlipidemia. Whereas the 150 mg single once daily dosage does not cause severe hypoestrogenemia, which means the estrogen stays in low normal levels, so she will not get symptoms. So it is good for a follow-up treatment. It can be used, there is data for usage up to 1 year, while the DGC approval is for 2 years. So essentially we can do that. There is Indian experience also with this data. So at the present moment for severe endometriosis pain, I would rather use elagolix as a second line agent if diagnosis fails, and we start with 200 milligram twice daily for 3 to 6 months. Once the pain is controlled, we move on to 150 milligram twice daily. Now elagolix has been compared with Dynogest, and it has been shown Dynogest is more efficacious. Please remember that depending on the pain, diagnostic laparoscopy should be history. Leaving pathology other than or adhesions, etc. If you are doing a laparoscopy for subfertility, you should be consenting her for treatment of endometriosis, cystectomy, adhesiolisis, clipping of hydrosalpinx, etc. So we need to have a see and treat approach, and we need to excise or ablate or feasible endometriotic lesions. Should you excise or should you ablate? If you are doing it for subfertility, whether you excise or ablate, your results are the same. If you are doing it for pain, you are better off ablating. You are better off excising, because that causes less recurrence. Please remember, first surgery should be the best. Before Dynogest came into the market, we were operating on young women with endometriosis every 3 to 5 years. Today, we have successfully reduced the number of surgeries because of 3 things. Number 1, our capability or our efficiency in endometriosis surgery has improved. That's number 1. Number 2, we now know that we can go conservative for a very, very long time. So the aim is delay the first surgery to as long as possible. And if a woman is lucky, you do a first surgery when she is planning a pregnancy, if needed, and a second surgery is a definitive surgery when she is approaching menopause. Sometimes you might need 1 more surgery in the middle, but not more than that. The first surgery should be the best, and we need to have an experienced surgeon not only to treat but also to diagnose. Because earlier we thought only powder burn or burnt matchstick appearance. Now we know that endometriotic lesions come in all colors. They can be white, they can be yellow, they can be red, they can be vesicular, they can be infiltrative, and they could be any surface lesions as well. So whatever we do, there is significant recurrence of pain, but if we excise the lesions, the recurrence is a little delayed. How do you manage endometrioma? Traditional teaching was that less than 4 centimeter managed medically, more than 4 centimeter operate. But there was a body of evidence even before COVID which showed that there was benefit or at least no harm in expectant or medical management of asymptomatic patients with small stable endometriosis. And during COVID, a lot of women didn't get their surgery, and we saw there's no harm in sitting with that. Which means a patient has an endometrioma which is more than 4 centimeters, you put her on medical, and she's not planning a pregnancy now, you put her on medical management that controls the pain, the endometrioma does not grow or shrinks, you do not have to jump into a surgery. So beyond which size should you operate? Nobody knows. Beyond a certain size, you are worried about the tube getting distorted, the tubal function getting affected, so nobody knows that there is size cutoff beyond which you will operate, but most endoscopic surgeons will feel reluctant to go conservative on an endometrioma which is more than 6 centimeters. So even our cutoff is 7 centimeters and above, we will offer a surgery. As I said, the first surgery should be the best and should be by a surgeon who is competent to deal with endometriosis. Our aim should be to do a cyst enucleation always, especially if we are doing it for pain. But the cyst enucleation done properly is great. If it is not done properly, then women will end up in premature ovarian failure. So we need to avoid ovarian damage, and we need to treat extrapelvic disease. For large endometrioma, there is something called a combined excision and ablation. I'll talk about that later. So what is excision versus ablation? With excision, which means cystectomy, the patient has less postoperative pain, less risk of recurrence, less recurrence of all kinds of pain, but there is more reduction of ovarian cancer. So when do we do an ablation, which means where we open the endometrioma, we drain the contents, we irrigate it and we coagulate the surface, some units to a laser. We do that only if the patient has come in for a fertility and the IVF specialist has said, I cannot access the ovaries, so you need to do something to the cyst, and her ovarian reserve is compromised. That is the only time when we will do this. Otherwise, if somebody comes in with pain and with good ovarian reserve, we will always do a cystectomy. Somebody comes in with pain and subfertility with reduced ovarian reserve, what we do is we send them for ovum pickup, then we operate, and then the patient goes back for an embryo transfer later. So ovarian damage does happen, but what is the query about it is, although what we see that there is reduced ovarian response on stimulation, the jury is divided on whether it affects the pregnancy rate. Our group says that although you get lesser eggs, the pregnancy rate does not get affected. And then Donez's group, because of that, they suggested the combined excision and ablation. When you deal with a very large endometrioma with very thinned out ovary, if you do a proper cystectomy, then you will lose a lot of follicles. So what you do is the essential follicles are there at the hilum. So what you do is you aspirate, irrigate and enucleate it. And enucleate it till you come to the hilum. And when you come to the hilum, circumferentially cut the cyst off with a cold scissors and then diathermize the hilum. And they have shown that this gives you a good balance between ovarian reserve and control of symptoms. And when you are doing in grapefruit endometriosis or in recurrence, it needs a very multidisciplinary approach because you need to mobilize the sigmoid, mobilize the ovaries, suspend the ovaries, dissect the ureters, and then open up the rectovaginal and pararectal space and excise all the visible endometriosis. What about endometrioma and ART? I have already said at the present moment there are only two indications of operating before IVF. One is the patient has got pain and good ovarian reserve, and there you operate before the IVF. If the patient has got pain and reduced ovarian reserve, you resort to a 3-stage procedure as I said, and you do a drainage only if the IVF specialist tells you that the cysts are so big that I cannot actually access the ovaries. There is no other reason for operating. Doing a cystectomy before ART does not improve ART success rates. If essentially while you are, the follicular fluid gets contaminated with the endometrial cyst contents, it does not affect the IVF pregnancy rate, but it does increase your risk of infections, ovarian infections, and that is why you need to cover with antibiotics. So there is no benefit of prophylactic surgery to decrease the risk of tubo-ovarian abscess post-ovarian retrieval, but you need to cover that with antibiotics. Now this is a very, very old paper, 2006, and I still love it. I put it on all my presentations. And if you see that on what characteristics when somebody presents with endometriosis and infertility, with which characteristics you are more likely to operate and when you are more likely to do an ART. You will do surgery, more inclined to do surgery if she has not had a previous surgical intervention for endometriosis. If the ovarian reserve is good, if she has pain, if it is a unilateral disease, if there are sonographic features which are suspicious of malignancy, or if there is rapid. Whereas you go for ART, if it is a recurrent disease where she had a previous surgical management, if the ovarian reserve is compromised, if she doesn't have pain, if it is a bilateral disease because her ovarian reserve will get reduced significantly, if there is no sonographic features of malignancy or it is a stable endometrioma, you are better off going for ART. With that we move on to recurrence, and I started by saying this, and the magnitude of recurrence of course depends on the longer duration of follow-up. The longer you follow up, of course the recurrence is going to be more. So you can see that the 4-year recurrence risks are more than 2 years and the 8-year recurrence risk is more than 4 years. But by around 8 years, 30 to 50% women will have recurrence, and symptom recurrence is more common than disease recurrence, which is proved by imaging. The risk factors of recurrence, severity of the disease. The more severe the disease, sooner it will recur. Extent of surgical excision. Poorer the excision, sooner it will recur. Younger age, younger is the age, a longer time you have to take her through until menopause, so there is a higher risk of recurrence. Pregnancy and post-operative adjuvant treatment with oral contraceptive pills, progestins and GnRH analogs are protective. You know, earlier people would want to do an endometriosis surgery, which was inadequate, give the patient 6 months of GnRH analog and will think that that will take care of the poor surgery. And that is why the thinking came that post-operative adjuvants are no role. But while that is true, a post-operative adjuvant does not improve a poor surgery. There is a role of secondary prevention. And secondary prevention is a post-operative adjuvant therapy for a prolonged period of time, 2 years or longer, in order to prevent or delay recurrence. And this can be done with the usage of GnRH analogs for 3 to 6 months, prolonged use of the oral contraceptive pill, prolonged use of the DHANBAD, or putting an LNG IUS at the time of laparoscopy. But then, giving somebody 6 or 5 or 7 years of DHANBAD is a very expensive proposition. And that is why one group were trying to look at an alternative. And what they did was, they randomized women into 2 groups. One is to get DHANBAD for 5 years and one is to get GnRH analogs for 3 to 6 cycles, followed by 5 years of oral contraceptive pill. And they showed that the recurrence risk is similar. So you've got different options in doing this. So this is where we stand with endometriosis at the present moment. But then what is the future? I keep telling my patients that the future is very bright. If you came 10 years back, we didn't have DHANBAD. You came 3 years back, we did not have elagolix. So the amount of money that gets poured in endometriosis research, no other benign disease in gynecology attracts that kind of research. And that is why the future is brighter. I wouldn't say it is, we can promise an endometriosis-free world. We cannot promise we can cure women of endometriosis. And I keep telling patients that you have somebody in your family who's got hypertension or diabetes, they need to take medication right now. We cannot cure it. Similarly, any disease where we do not know exactly why it occurs, we cannot cure it. We can only control it. And fortunately for you, unlike diabetes or hypertension, usually at menopause you can stop your therapies. So the first question is, can we prevent endometriosis? We need to start thinking about this because these days more women are postponing pregnancy, which definitely increases the risk of endometriosis. So what we need to do is we need to look at whether there would be any intervention that we can do in the form of oral contraceptive pill or something that can reduce the risk of endometriosis. But what is important is we need to improve awareness about pelvic pain. We need to tell women that dysmenorrhea is not normal. If your dysmenorrhea is so severe that you cannot go to school or college or go to work or can't do household work, you need to see a gynecologist. And we need to do this among women, we need to do this among general practitioners, and we need to do this among gynecologists as well. Diagnosis, we need to train sonologists to diagnose endometriosis by ultrasound. We need uniformity in reporting imaging. We need to look at new modalities of non-invasive testing. For example, the first non-invasive test now which has gone commercial, it is available in Europe and Middle East, which looks at your saliva, and there are other ones in the pipeline. Then again, today artificial intelligence is everywhere, and artificial intelligence can be used to diagnose endometriosis radiologically. If you go to the American laparoscopy conference, every year one of the prize-winning papers is on use of AI in endoscopic surgery or in assessment of endoscopic surgery. Because it does pattern recognition, it can do much better if you feed it sufficient number of images to pick up and say, well, this is a deep endometriosis, it will do that, it can do that better than the doctors. So the salivary test of endometriosis looks at mRNA expression in the saliva, and that would be great. If a woman comes to you and you can do a blood test or a body fluid test and tell you have endometriosis or you don't have endometriosis. But a similar test is being developed in the bloodstream by our own colleague Dr. Ramani Devi, similarly looking at mRNA expression in blood. So we will have more and more drugs coming in. Again, another drug which is being evaluated, it is in trial in India and the United States, and the Indian trial is complete. It has not been published, but we get to hear from rumors that it is effective, and that is cabergoline given in the dose of 0.5 milligram twice weekly for 3 to 6 months. And there is one paper, which observational study, which got published, which is from India and Bangladesh, and they compared gabapentin to Dynogest and found that Dynogest gave better reduction of endometrioma size, whereas gabapentin gave better pain control compared to Dynogest. Now there are some women who cannot tolerate Dynogest. We've had to take off around 4 women in 10 years from Dynogest because of depression. So if a woman on Dynogest or any long-term progesterone comes and tells you that I have got severe depression, please stop the medication and see, because progesterone in small number of women can cause depression. That these women, then you can put them on gabapentin for a short period. You can also put them on Elacolis. Surgical treatment. You know, today you have 2 talks on robotic surgery, so whatever the evidence says, the industry will push you towards robotic surgery. So unfortunately, robotic surgery is being used in a lot of cases where it is not needed, but endometriosis is somewhere where the robotic surgery can help us a lot, because it is more precise, it gives us more magnification, it is very useful in deep endometriosis. You can operate with much more ease than traditional laparoscopy, but of course cost is getting better. And the last thing that we do not talk about enough is egg freezing. I have seen when we were students, parents would bring daughters with endometriosis and the...
Professor, for a beautiful narration. It is really very well informative to us. The last thing of your speech, that preservation of the ovum for the younger women who are supposed to be suffered too much, is very, very suggestive. And I think, I don't know how much it is possible in our city like DHANBAD, but we should try to preserve the oocyte for their future fertility. And one question just, I think, can you speak, what is the specific management of adenomyosis or endometriosis in this case?
Our teacher, P.H. Chakravarti, used to say that endometriosis is much easier to treat than adenomyosis, especially if fertility is an issue. So if you ask me adenomyosis without fertility concern, great. You can use Dynogest, you can use generic analogs, you can, if the uterine cavity is not very big, you can put in a myopia. The problem, if the patient has got a focal adenomyoma, then a laparoscopic or an open surgery for excision of adenomyoma works very well with great results, even for fertility. But if the patient has got global adenomyosis, yes, you have heard the Uchita's technique of surgery, when they open the serosa, and like we used to do lateral tunneling for myoma, they do a debulking of the endometrium and of the myometrium, and you left out with a very thinned out uterus with the serosa stitched back. But I don't think that is feasible. So essentially, medical management, only focal adenomyoma surgery, and then hysterectomy. These are your options. If the patient has got adenomyosis with fertility and the results of IVF are much worse compared to women with endometriosis, and that is a real challenge, and that is where especially women who got a very big uterus or a very distorted uterus, I don't think the current ART bill helps them, because these are the women who typically need surrogacy, and unfortunately government will not allow you to do the surrogacy unless it is a related surrogate or altruistic surrogate, which is very, very difficult.
Thank you, sir, for the outstanding presentation. We are privileged and honored to have you here. Thank you, sir.
It is indeed a moment of great pride and privilege for us to felicitate our esteemed chief guest, respected Dr. Bhaskar Pal Sir, President FOGSI 2026, in appreciation of his exemplary leadership and inspiring journey in the field of obstetrics and gynecology. May I now request our esteemed chairpersons, Dr. S.K. Das Sir, Dr. Kavita Priya Ma'am, Dr. Pratibha Rai Ma'am, and Dr. S.K. Das Sir, and our President, Dr. Komal Ma'am, to come on the dais. May I request our Secretary, Dr. Reena Barnwal. It is our privilege to have Dr. Shivani Jha Ma'am, our past President 2016-2018 with us. May I request her, Shivani Ma'am, to please join us on the stage and to felicitate our President, Dr. Bhaskar Pal sir. May I request Kavita Priya ma'am? Kavita. They are all speaking. Yeah, I must introduce, there are many feathers in Dr. Kavita Priya's cap, but I would like to introduce her as Dr. Leena Priya, ma'am's daughter-in-law also. She has worked many years with Dr. Leena Priya. Can we have a big round of applause to felicitate our President, Dr. Bhaskar Pal. Also to join the stage, the most. And Shomati you also come. May I request Dr. Abha ma'am also to join the stage. And Dr. Madhuri Patel ma'am also, please come once again if you can grace the dais. Then Kavita Barnawal ma'am, Priya Ganeshan ma'am, please. More the merrier, there's something. May I request Dr. Arpita Gandhi ma'am and also our Vice President Dr. Renu Upadhyay ma'am to please join the stage.
ড্রাইভার আছে তো এসছে ড্রাইভার এসছে ড্রাইভার এসছে
May I request Dr. Bhaskar Pal sir to felicitate our chairpersons for this session. Dr. Kavita Priya ma'am, Dr. Pratibha Rai ma'am, Dr. Kavita Priya ma'am, Dr. S.K. Das sir, very own President DSOG Dr. Komal Singh ma'am. Felicitated by our President Dr. Bhaskar Pal sir. We have another big round of applause for all the dignitaries on the stage.
Dr. Madhuri Patel, Ma'am, President-elect FOXY 2027. Joint Secretary, Dr. Soma Datta. Can we all? Our respected patrons, Dr. S.K. Das sir, Dr. Professor Pratibha Rai ma'am, Chairperson, Scientific Committee, Dr. Kavita Priya ma'am. May I now request our organizing chairman cum president DSOG Dr. Komal Singh ma'am and organizing secretary Dr. Reena Barnawal to kindly escort our dignitaries to the dais.
DSOG today proudly stands as a vibrant 50-year-old society with more than 150 dedicated members committed to advancing women's healthcare and academics. The theme of this year's conference is SWASTHA NARRI SAMAAJ, healing women, strengthening communities. The conference focuses on preventive and practical aspects of women's healthcare relevant to our day-to-day obstetrics and gynae practice. May I now request our hall coordinators to kindly extend a floral welcome to all our dignitaries on the dais.
request everybody to take their seats.
Behind every successful conference is a leader whose dedication, calmness and hard work holds everything together.
And Dr. Komal Singh ma'am has done that beautifully for DSOG. I now invite our dynamic president and organizing chairman of the conference, Dr. Komal Singh ma'am, to deliver the welcome speech. Dr. Komal Singh ma'am.
Success we celebrate today. We stand on the shoulder of giants. The Jubilee belongs to our founders as much as it belongs to us. It is a distinct honor to host the 6th DSOGCON during the half-century milestone. As I stand here, I want to share a small behind-the-scene truth with you. For the last 2 months, our secretary, Dr. Reena Barnawal, and I have been debating day and night over the smallest details of this scientific program and every aspect of this conference. In fact, if you were to look at my call history from the last 60 days, it is filled almost entirely with Reena's call. Thank you, Reena, for your tireless dedication. And we did this because we believe that you deserve nothing less than excellence. We knew that one single insight shared here in Dhanbad could save a mother life, a remote village of Jharkhand or Bihar. And that is the Dhanbad spirit, a commitment that starts long before the lamps are lit. So since yesterday, we have seen the meticulous planning came to life. And I want to thank Dr. Sheila Mane, Dr. Mitra Saxena, Dr. Manju Puri, and Dr. Poonam Goyal, Dr. Nivedita Datta, and our own Dr. Rajlakshmi Tubik and her whole team for a PPH workshop that was truly a world class. And we were also intellectually elevated just now by the excellent presentation by Dr. Sujata Dalvi and our brilliant presidential orations by Dr. Bhaskar Pal and Dr. Madhuri Patel. And our journey has been guided by the wisdom of our stalwarts, Dr. Sampat Kumari ma'am and Dr. N.C. Patel sir. And I also thank our scientific chairpersons, Dr. Kavita Priya, for her guidance. And my heartfelt appreciation goes to our core pillars of our committee, Dr. Neetu Sahai, Dr. Neha Priyadarshini, Dr. Archana, Dr. Abhijit Mandal, and Dr. Isha Rani, and every member of the Dhanbad Society for standing with us through these intense months. And our theme is SWASTHA NARRI, SASHAKAT SAMAAJ, healing women and strengthening communities, and is the heartbeat of this convention. When we heal a woman, we do not just treat a patient, we strengthen a family, a city, and a nation. And to continue this journey of excellence, we are honored to have a Vice President, Dr. Abha Rani Sinha, who will share her insights with us just after this ceremony. Thank you all for joining.
Thank you so much, ma'am, for your inspiring words. I now request our esteemed guest of honor, Dr. Abha Rani Sinha, madam, to address the gathering. Ma'am, your academic brilliance and affectionate guidance have inspired countless students and colleagues over the years. It's truly an honor to have you amidst us today. Your presence itself adds dignity and grace to this celebration. We are privileged to hear your thoughts today. Thank you so much.
Thank you, Neha and Neetu. Respected President Foxy, the chief guest for today, Dr. Bhaskar sir, our guest of honor, Dr. Madhuri Patel, the organizing chair of this conference and the president of the society, Dr. Komal Singh, and the dynamic secretary, who has been, I think, sent innumerable calls to me, Dr. Reena Bardawal, and the patrons, Dr. Pratibha Rai and Dr. S.K. Das. The special guest for today, Soma is young, much younger to us, so always I take her name at the end, but officially I think I should take her name earlier. So welcome Soma to Dhanbad. And Dr. Kavita Priya, again a very dear junior I can say, and she was the one who called me first when she had organized, I think, the 4th Dhanbad Obs and Gynae conference. And since then I tell you that I have attended all the 3 conferences, 4th, 5th and 6th. 5th was organized by Dr. Neha Priyadarshini, and 6th is today. Well, we all have gathered here. Dhanbad holds a special place for me because this has been my birth town, as well as I have done my schooling from this place, and all the gynecologists who are here are very, very close to my heart, and it's always a pleasure to come to Dhanbad. And this time I'm so happy that our president has visited this society, and also our president-elect, and along with stalwarts like Dr. Sampat Kumari, Dr. Priya Ganesh, chairpersons Dr. Suman, I can find all of them, and Dr. Shivani Jha, she has been my school friend. We have been batchmates together, so again, the theme of this conference is very good, and we have chosen all good subjects and all renowned speakers. So my best wishes for the conference, and I hope it will be a memorable one. Thank you so much.
May I now invite Dr. Madhuri Patel ma'am to kindly share her thoughts with us. Ma'am represents the perfect blend of leadership, vision and humility. Her energy and dedication continue to inspire young gynecologists across the country. Dr. Madhuri Patel.
Thank you, dear, for your kind words. Respected our chief guest, Dr. Bhaskar Pal, President Foxy, VP Dr. Abadi. And because Abadi has complained me today that you always tell me Abba Singh, I'm Sinha. So I said, no, I'm going to talk Abadi only now onwards. And Dr. Das, Dr. Rai, Dr. Kavita Priya, Dr. Komal, Dr. Soma, and Dr. Reena, and all my back, Neetu and Neha. And of course, all my dear friends, very good afternoon to all of you. I have appreciated Jharkhand. The day I was in Brazil for the FIGO conference. And that time, Dr. P.K. Shah was presenting maternal mortality rate in a different states of India. And he was presenting and suddenly said, Jharkhand, 56 per 100,000 live birth. So I'm talking about 2018, and Jharkhand could reduce MMR in 2018 to 56 per 100,000 live birth. That time onwards, I really salute all of you that you are working really hard for the maternal health. And they have maintained. Today also they have achieved SDG goal at that time, and today also they have maintained the MMR. It has not gone beyond 58. So I am really congratulating all of you, and I really appreciate all of you that you keep on working for the maternal health. Apart from the woman health, it is now your duty to work for the woman health also, and I think you will reach to that level with other developed states. Like only out of 8 states, only SDG goal has been achieved by Jharkhand, and other are the developed states of India. So I am really happy and I congratulate and thank you once again. I am not wasting much time. I have many things to speak, but now the time is running short. So thank you once again for giving me this opportunity.
Thank you so much, ma'am. Every institution needs mentors whose wisdom lights the path for others. And for DSOG, Dr. S.K. Das sir has always been that guiding force.
Now I request our respected patron, Dr. S.V. Das sir, to address the audience.
Good afternoon to all. At the outset, I welcome our respected President of SWASTHA, Dr. Bhaskar Pal, this elected President, Madam Patil, and Dr. Sinha, and others dignitaries of this dais, and all of you here. I must praise this conference too much due to the fact that I couldn't expect that my colleagues, my junior colleagues, will be able to arrange so much outsider reputed speakers here to speak in this stage. Really, it is a question. By the way, it is a very gratefulness of them that they have done it. It has been possible for them to do it, and I shall request them to please try to keep it in mind what the respected speakers have told and maintain it in the future. That's what I am.
Thank you, sir, for your kind words. May I now request Dr. Kavita Priya ma'am, our past president, DSOG, chairman, scientific committee, to say a few words. She has been a constant support in DSOG and her academic activity, which has always been deeply appreciated by DSOG. We are honored by your gracious presence. Ma'am, Kavita.
Thank you, Dr. Neetu, so much for those kind words. As chairperson of the scientific session, I would like to say how very grateful, first of all, we are that such eminent speakers and such wonderful faculty came and attended this conference. Dr. Bhaskar Pal sir, Madhuri madam, Apasina ma'am, and everybody, all the wonderful faculty that came here. Also, I would like to thank the delegates who came to this conference, and I hope that we lived up to your expectations. Thank you very much.
Thank you so much, ma'am. It is now time for a very special and proud moment for DSOG. We announce the DSOG Pratibha Rai Madam in recognition of her extraordinary contribution to Obs and Gynae, academics and women's healthcare. Ma'am, generation of doctors and your students like myself, we have learned not only medicine but also values, discipline and dedication from you. Today's honor is truly a celebration of your remarkable journey.
Born on 23rd August 1954 in Purulia, West Bengal, Dr. Pratibha Rai ma'am was raised in an environment that valued education, discipline and service. Her father, Shri Devi Sharan Singh, a respected sub-divisional officer, and her mother, Srimati Chandrakala Devi, an educated and inspiring personality, nurtured in her the values that would later define her remarkable journey. An exceptionally bright student from childhood, Dr. Pratibha ma'am pursued her dream of becoming a doctor with unwavering determination. She completed her schooling at St. Teresa Girls' School and her ISc from SP College, Tumka. She earned her MBBS degree from PMCH Patna in the year 1979, followed by a diploma in gynecology and obstetrics from Darbhanga Medical College in 1983, and later obtained her MS in obstetrics and gynecology from PMCH Patna in 1988. Dr. Rai began her medical career after securing an impressive rank in the BPSC examination. Her early years of service were spent in some of the most challenging and underserved regions of Bihar, including Asthavan in Nalanda district and Janjalpur in Madhubani district. Working tirelessly under extremely difficult circumstances, often without adequate electricity, water or basic infrastructure, she devoted herself wholeheartedly to the care of poor and underprivileged women. These formative years reflected not only her clinical competence but also her extraordinary resilience, empathy and commitment to humanity.
In 1997, Dr. Rai joined Patliputra
Medical College, Dhanbad as a resident surgeon. Through years of sincere dedication and academic excellence, she rose steadily through the ranks, becoming assistant professor in 2004, associate professor thereafter, and ultimately professor and head of Department of Obs and Gynae in 2015. She continued to lead the department with distinction until her retirement on 31st March 2022, after which she was granted an extension in recognition of her invaluable contribution and the immense respect she commanded within the institution. Her association with the Dhanbad Society of Obs and Gynae since 1997 has been one of the tireless service and leadership. As secretary, president, faculty member and mentor, she has played a pivotal role in strengthening the academic and professional stature of the society. Beyond medicine, Dr. Rai has remained deeply committed to social welfare. Her life beautifully reflects the ideal balance of professional excellence and compassionate service. Dr. Pratibha Rai's journey is not merely the story of a doctor. It is the story of a healer, a teacher, a leader, and an inspiration to generations. Her unwavering dedication to patient care, medical education, women's health, and social service truly exemplifies the noblest ideals of the medical profession. Today, as we honor you with this Lifetime Achievement Award, we celebrate not only her extraordinary accomplishments, but also the countless lives she has touched with compassion, dignity, and grace. Ma'am, your legacy will continue to inspire generations to come. We salute your remarkable journey and your invaluable contribution to the field of Obs and Gynae. May I now request our chief guest and dignitaries to kindly come forward to felicitate Dr. Pratibha Rai, ma'am.
I request the audience to kindly stand in honor of her lifetime.
We now request Dr. Pratibha ma'am to bless us with her words.
हिंदी मंच पे उपस्थित और सभागार में उपस्थित सभी गणमान्य चिकित्सकों का मेरा हार्दिक अभिनंदन और जोहार। आप लोगों ने अपना बहुमूल्य समय न जाने कितनी कठिनाइयों को झेल कर यहाँ आए और हम लोग के इस प्रोग्राम को काफ़ी माने गर्वान्वित किया हम लोगों को कि झारखंड जैसे छोटे शहर में आप लोगों ने आके अपना योगदान दिया और हर तरह से आप लोगों ने नई नई जो भी इन्वेस्टिगेशन हुआ है, जो भी ये आप लोग अपना काम किए हैं उस सबको यहाँ बताए। जैसे कि मुझे लगता है कि यहाँ के सभी चिकित्सक जो भी यहाँ उपस्थित थे वो सब लाभान्वित हुए हैं और फ्यूचर में इसको अप्लाई करेंगे। मुझे तो लग ही नहीं रहा है कि मुझे लाइफ टाइम अचीवमेंट अवार्ड मिला है, क्योंकि मैं अभी भी अपने कोई लोगों के साथ ही समझती हूँ और हमेशा मैं तैयार रहती हूँ। जब भी ये लोग बुलाते हैं मैं आती हूँ, अपने से भी कहती हूँ कोई ज़रूरत हो तो मुझे हेल्प करो। और मेरी हमेशा इच्छा रहती है कि अंडर प्रिविलेज सोसाइटी, एनीमिक पेशेंट और गरीब बच्चे हैं, भूखे पीड़ित बच्चे हैं, लोगों की सेवा करूं और मैं उसमें सफल भी होती हूं। कहते हैं ना कि आप कुछ ठान लीजिए तो कायनात भी आपका मदद करती है। मैंने अपने स्तर से ब्लड डोनेशन कैंप, एनीमिया प्रोटेक्शन, ब्रेस्ट फीडिंग और भी कई तरह की चीज़ें करती हूँ, तो उसमें मुझे सफलता मिलती है। और मैं चाहूँगी कि मेरे जितने भी जूनियर्स हैं इसको फॉलो करें और भी अच्छा करें कि हमारे झारखंड में कोई गरीब नहीं रहे, कोई अशिक्षित नहीं रहे। इसके अलावा मैंने ब्रेस्ट कैंसर, सर्वाइकल कैंसर, इस सब के जागरूकता के लिए भी स्कूल में जाके कुछ प्रोग्राम की हूँ और वहाँ के बच्चे बहुत लाभान्वित हुए हैं। मैं इन्हीं शब्दों से अपना ये करती हूँ और आप लोग सबका बहुत बहुत धन्यवाद जो आप लोग आए, अपना समय दिए और इस प्रोग्राम को सफल बनाए। धन्यवाद।
बहुत बहुत धन्यवाद मैम आपका इन शब्दों के लिए, आपके आशीर्वचनों के लिए। मैम ने सही कहा, लाइफ टाइम अचीवमेंट अवार्ड के बावजूद भी हम लोग मानते हैं कि मैम आज भी बहुत एक्टिव हैं। थैंक यू सो मच मैम फॉर योर kind words. Your words will continue to inspire generations. We now request our dignitaries for the release of conference souvenir. May I request the conference souvenir head, Dr. Abhijit Mandal, to present the souvenir and the PPH reckoner. We had a wonderful PPH workshop yesterday morning. So we also want to release the PPH reckoner along with our conference souvenir. May I request Dr. Abhijit Mandal to be there on the stage. If you all can please stand. Can we have Dr. Mitra Saxena ma'am also on the stage and Manjupuri ma'am for the release of PPH reckoner. of our Golden Jubilee celebration of DSOG, we shall now mark this memorable occasion with sapling plantation and cake. Sapling plantation. DSOG at 50 stands tall with pride, honoring its glorious past while inspiring the future of obstetrics and gynecology. Behind these 50 successful years are teachers who guided, leaders who inspired, and members who carried DSOG forward with dedication and love. Today, as DSOG celebrates its Golden Jubilee, we salute every hand and every heart that contributed to this remarkable journey.
आज के परिप्रेक्ष्य में जब हमारी पूरी धरती के अस्तित्व पर ही संकट आने पड़ा है, लगभग पूरा विश्व घोषित या अघोषित रासायनिक युद्ध में रत है। हर तरह के प्रदूषण ने हमें घेर रखा है, तो इसके निवारण की एक ही संजीवनी नजर आती है, वृक्षारोपण एवं पर्यावरण का संरक्षण। हमारी धरती का हर पौधा हमारे अस्तित्व का हिस्सा है और हम जब इसे सींचते हैं तो हम जीवन को सींच रहे होते हैं और अपनी धरती को और अपने भविष्य को सुरक्षित कर रहे होते हैं।
वृक्षाणां जीवितदायिनी तस्यं जलं प्राणदायकं जीवनस्य स्रोतं सन्ति वृक्षाः। अर्थात पेड़ों को जीवन देने वाला जल ही है जो जीवन का स्रोत है और वृक्षों के कारण ही जीवन पुष्पित होता है। हम वृक्षारोपण तो कर देते हैं लेकिन उसे सींचने में कहीं पीछे रह जाते हैं। तो आइए, जब DSOG अपना 50वां साल मना रहा है तो आज सब मिल के प्रण लें कि अपने आसपास के पौधों को जल से सींचकर इस धरती को हरा भरा व अपनी आने वाली पीढ़ियों के लिए रहने योग्य बनाएंगे। Now we request all dignitaries for the formal celebratory cake cutting ceremony. Join us for the cake cutting.
May I request all past presidents and secretaries, Dr. Shivani Jha ma'am, Dr. Savita Shukla Das ma'am, Dr. Raj Lakshmi Tobin, our treasurer, Dr. Nupur ma'am, Dr. Sangeeta Karan ma'am, all the seniors, please join us on stage. Dr. Asha Rai ma'am. Seniors to please come on stage. Thank you so much everyone, and now the moment we have all been eagerly waiting for. It is my proud privilege to invite our esteemed chief guest, President Foxy, Dr. Bhaskar Pal sir, for the presidential address. Sir, your vision, leadership and approachable nature has brought fresh energy and direction to Foxy. We are truly privileged to have you with us today.
Thank you, Neha and Neetu, for the wonderful job. It's a pleasure to be here. Dr. Komal Singh, President, DHANBAD Obs and Gynae Society, and especially Dr. Reena Barnwal, Secretary. I think we fixed up this date more than 6 months back, and I think Reena has got completely fed up with me because 3 months back she was pestering me for my topic when I was still dealing with topics for that month. Okay, so then she realized that it is a futile exercise and started chasing Shoma. It's a pleasure to have Dr. S.K. Dash and Dr. Pratibha Rai and Dr. Kavita Priya on stage, and my dear friend Dr. Madhuri Patel. And I will tell when we come back here next, but even in Madhuri is here, we're coming back to Jharkhand for the East Zone Yuva Foxy Junction. Thank you, Madhuri, for that. And my dear friend, Dr. Avarani Sinha, Vice President 2026, Dr. Shoma Datta, Joint Secretary, Foxy, the committee chairs who are present here, Dr. Apurva Datta, Dr. Suman Sinha, and Dr. Kavita Barnwal, past Vice Presidents, Dr. Sampath Kumari, Dr. Mitra Saxena to be Vice President, and past committee chair, Dr. Priya Ganesh Kumar. It is a pleasure to be here and be here for the Golden Jubilee celebration for the DHANBAD Obs and Gynae Society. The last time I was in DHANBAD for the 5th conference which was organized during when Neha was there, and we have very pleasant memories of that and very unpleasant memories of that, because we coming from Varanasi, Jaideep Tank and myself, and our train was 6 hours late. It was 2 hours late by the time we went to Varanasi station, but we will forget. I think Neha had a challenge restructuring the program so that we can make it. Of course, being from the East, it is natural that East will feature strongly in this year's programs. So we've already been to Gaya for the East Zone Yuva conference, and the only time Gaya has done a big conference before was in they had done the AJ OSB for a long time, for which I had been there. And then we are here today, and we now go back to Patna for the Stillbirth Conclave. As you know, this year we have less of traditional conferences and have more of conclaves. And the conclaves are 2-day focused, theme-based programs, single hall program, along with hands-on stations. So we've already done PPH, and we have already done art of birthing. In the middle of June, we do sexual medicine and cosmetic gynecology, with which Dr. Apurva Datta from Jharkhand is very closely associated. And then we come back to Patna in the East Zone for the Stillbirth Conclave, which is in collaboration with the Stillbirth Society of India. And then we come back to Jharkhand again in Ranchi in middle of September, 12th and 13th of September to be precise, for the Urogynecology and Vaginal Surgery Conclave organized by Dr. Kavita Barwal, Dr. Siman Sinha and Dr. Archana Kumar. And I hope that most of the societies of Bihar and Jharkhand will have either had or have planned the REACH CMEs. And the REACH CMEs are 2-hour modular CMEs. We are running 26 modules, a total of 1150 programs across the country, where however the small the society maybe will be there. I know that Deoghar had it recently, Arpita Di. And we also had a memorable REACH CME in Katihar not so long back, where Dr. Abharani Sinha and Dr. Pratibha Singh were there, and they witnessed the breach collapse first, and they were very scary. Means you can find it mesmerizing talking of it now. But they were on the bridge when it was about to collapse. They got down from the car, crossed the bridge, and saw the bridge collapse. And they were stranded for the night. But that is where I think that is what Foxy is all about, and it's a pleasure being here. And I wish maybe from 50 we'd like to be here at the 60th, and maybe if alive at the 75th. But we wish a very, very dynamic society going ahead. You've got a good breed of youngsters, and please keep it up. Thank you.
Thank you so much, sir, for your visionary and motivating address. Every successful conference needs a heart that works tirelessly behind the scenes, and Dr. Reena Barnawal ma'am has been that driving force for this beautiful event. I now request the organizing secretary, Dr. Reena Barnawal, to kindly propose the vote of thanks. Dr. Reena Barnawal.
Our respected Chief Guest, Dr. Bhaskar Pal sir, Guest of Honor, Dr. Madhuri Patel ma'am, Dr. Abharani Sinha madam, honorable dignitaries on the dais, esteemed faculty, and dear friends, a very good afternoon to all of you. It's truly a moment of pride and gratitude for me as the organizing secretary of 6th DSOGCON to stand here and propose a vote of thanks. Foremost, I would like to express my heartfelt gratitude to our esteemed Chief Guest, respected Dr. Bhaskar Pal sir. Your presence among us today has been deeply encouraging, and your words have not only inspired us, but reminded us why we chose this noble field of caring for women. I also extend my sincere thanks to our guest of honor, respected Dr. Madhuri Patel ma'am and Dr. Abharani Sinha ma'am for gracing this occasion and for being here with us today. Your guidance and support mean a lot to all of us, and we are truly honored by your presence. I am enormously grateful to the conveners of our PPH workshop, respected Dr. Manju Puri ma'am and respected Dr. Mitra Saxena ma'am, and senior faculties of our workshop, respected Dr. Sheila Mani ma'am, respected Dr. Poonam Goyal ma'am, and Dr. Rajashmi ma'am, Dr. Nivedita ma'am, for the hard work of planning, inspiring, executing, and making us learn in the best possible way about a dreadful and a life-threatening nightmare of PPH. I am deeply grateful to respected Dr. MC Patel sir and Dr. Sampath Kumari ma'am for their esteemed presence and valuable support at the 6th DSOGCON. I feel honored to thank our patrons, Dr. S.K. Das sir and Dr. Pratibha Rai ma'am, for their constant blessings and support. I feel blessed to thank our scientific chairperson, Dr. Kavita Priya ma'am, for her valuable insights, planning, and support in organizing this conference. All our respected faculty and speakers, thank you for being here, for sharing your knowledge, and for nurturing the spirit of learning that brings us together. Your gracious participation greatly enriched the conference and inspired us, all the attendees. My special thanks to Reverend Dr. Komal Singh ma'am, whose constant encouragement and leadership have been a strong pillar behind this conference. Without your vision, this would not have taken shape the way it has. To our dear delegates, thank you for traveling, for taking time out of your busy schedules and for being a part of this academic family. Your presence gives life and meaning to this conference. I would especially like to acknowledge our organizing team, scientific committee and volunteers. Many of them have worked quietly behind the scenes, late nights and early mornings, ensuring that everything comes together seamlessly. This conference is truly a reflection of their dedication. I am also grateful to our sponsors and partners for their generous support and trust. As we gather here with the theme SWASTHA, SASHAKAT, Healing Women, Strengthening Communities, I hope this 6th DSOGCON brings not just learning but also connection, inspiration and renewed purpose. With these words, I once again thank each one of you for being here and for making this beginning so meaningful. Thank you so much, and I wish you all a wonderful and enriching conference ahead. Thank you, everyone.
Thank you so much, Dr. Reena ma'am. From the smallest details to the grandest arrangements, your hard work and commitment are visible everywhere today. Coming together is a beginning, keeping together is progress, and working together is success. We hope you have a memorable academic feast, enriching scientific deliberations, and a wonderful stay here in Dhanbad.
May I now request all the dignitaries and everyone present in the hall to kindly rise for the national anthem.
पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जगति तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you everyone, and now the most awaited cultural presentation of the evening. Please take your seat and enjoy the special skit presentation by the members of DSOG. May I request our dignitaries to please take seat and wait for the skit.
Gracias. काम नहीं कराते क्या करें? चलिए चलिए
Good afternoon, everyone. नमस्कार, जोहार। हमारे स्किट में एक पीपीएच राक्षसी है। जैसा कि हम सब जानते हैं, हमारे इतिहास में एक सावित्री हुआ करती थी। उसने कभी अपने पति की जान बचाई थी। तो आइए देखिए हमारा ये कलयुगी सत्यवान अब क्या करने जा रहा है। आई रिक्वेस्ट, मैं सबों से अनुरोध करती हूँ कि कृपया बैठे। इस स्किट के पीछे हमने 6 महीने से मेहनत की है। थैंक यू वेरी मच।
बरस की,
मैं 16 बरस की,
तो मैं 17 बरस का।
16
17
17
16
मेरा जाए नैना, 1-2 बरस ज्यादा दूर रहना, 1-2 बरस ज्यादा दूर रहना। कुछ हो गया तो फिर ना कहना, मैं 16 बरस की, 17 बरस का, मैं 16 बरस की, तू 17।
कुछ कुछ रकमा पास आना, एक अच्छी अच्छी गुड़िया दे दो ना। सारा जहां सो गया, चांद कहीं खो गया।
बना के क्यों बिगाड़ा रे, बना के क्यों बिगाड़ा रे, बिगाड़ा रे नसीबा। ऊपर वाले, ऊपर वाले, बना के क्यों बिगाड़ा रे, बिगाड़ा रे नसीबा। ऊपर वाले, ऊपर वाले, बना के क्यों बिगाड़ा रे।
रुको, कौन हो तुम?
मैं पीपीएच राक्षसी हूँ।
मेरी पत्नी को लेकर कहाँ जा रहे हो तुम?
मुझे यमराज ने भेजा है तुम्हारी पत्नी को लाने के लिए।
यमराज ने भेजा? राक्षसी जी, राक्षसी जी।
हटो, तंग मत करो मुझे। हर 10-10 मिनट में यमराज मुझे मृत्यु लोक भेज देता है।
राक्षसी जी, रहम, मेरा छोटा बच्चा है। राक्षसी जी, मेरी पत्नी को लौटा दीजिए।
यह एनीमिया और पीआईएच जिसकी वजह से पीपीएच हुआ है, उसे तो कोई कुछ नहीं कहता। यमराज मुझे ही बार बार भेजता है।
राक्षसी जी, मेरा मासूम बच्चा, मेरी पत्नी को वापस कर दो राक्षसी जी।
तुम्हारी पत्नी को बचाने में तो डॉक्टर लगे हुए हैं, तुम क्या करोगे?
मैं कुछ भी कर सकता हूँ राक्षसी जी, कुछ भी कर दूंगा।
अपना खून दोगे तुम? बोलो, खून दे सकते हो?
हाँ राक्षसी जी, आप मेरे प्राण ले लो राक्षसी जी, आप मेरे प्राण ले लो।
जाने तुझे देंगे नहीं, जाने नहीं देंगे तुझे, जाने तुझे देंगे नहीं। चाहे तुझको रब बुला ले, हम न रब से डरने वाले, राहों में डट के खड़े हैं हम। यारों से नजरें चुरा ले, चाहे जितना दम लगा ले, जाने ना तुझको ऐसे देंगे हम। जाने नहीं देंगे तुझे, जाने तुझे देंगे नहीं।
ओहो, यमराज भी मुझे घड़ी घड़ी मृत्यु लोक भेज देता है। मैं इतनी अच्छी राक्षसी हूँ, मुझे क्या अच्छा लगता है इन जवान जवान औरतों को ले जाने में? लोग अपनी पत्नियों का ध्यान नहीं देते, कम उम्र में शादी कर देते, ना अच्छी से देखभाल करते। ओहो
राक्षसी जी,
आहा, ये क्या था? आत्मा तृप्त हो गई।
राक्षसी जी, राक्षसी जी, मेरी पत्नी को वापस कर दीजिए।
अरे बस, यमराज का हुक्म है, मैं कैसे तुम्हारी पत्नी को वापस करूं? ओहो, मेरे पीछे क्यों आ रहे हो?
राक्षसी जी, मेरा बच्चा छोटा है।
चलो जाओ, मैंने कह दिया ना। हाँ, पर मैं एक काम कर सकती हूँ। तुम्हारी मेहनत से, पत्नी प्रेम से मैं बहुत प्रसन्न हूँ। मांगो, मांगो कोई वरदान, मैं तुम्हें वरदान दूंगी।
राक्षसी जी, आप क्या बॉलीवुड फिल्में देखते हो?
कहाँ टाइम मिलता है मुझे, घड़ी घड़ी तो मृत्यु लोक आना पड़ता है।
राक्षसी जी, आपने जोहरा जबी सॉन्ग सुना है?
जोहरा जबी सॉन्ग? तब तो नहीं। हाँ, सुना है।
तो बस आप मुझे इतना वरदान दे दो कि मैं जोहरा जबी सॉन्ग पे डांस करूं।
ये कैसा वरदान? ठीक है, तथास्तु। अरे, तुम अभी भी मेरे पीछे आ रहे हो? लौट जाओ।
राक्षसी जी, आपका वरदान कैसे पूरा होगा?
क्यों, क्या हुआ? जाओ डांस करो।
राक्षसी जी, पर आप तो मेरी जोहरा जबी को लिए चले जा रहे हो।
हैं? जोहरा जबी? गूगल? अरे, ओहो, ये मानव तो बड़े तेज होते हैं। सतयुग में सावित्री ने फंसा दिया था यमराज को, और कलयुग में इसने मुझे ही फंसा दिया। बस, चलो तुम्हारी पत्नी को वापस करते हैं।
memories. With hearts full of gratitude and pride, we once again thank all our respected dignitaries and delegates for making this celebration memorable.
It was truly a pleasure being your host this morning. Thank you for your warm patience and wonderful presence. 50 सालों की ये कहानी, मेहनत, समर्पण और अपनेपन की निशानी। आप सबके साथ से ये उत्सव और भी खास बन गया। आभार, साधुवाद, धन्यवाद। आते रहिए हमारे शहर यूं ही बार बार। जय हिंद, धन्यवाद। जय झारखंड। We all can now proceed for the lunch. I know it's getting very late, but we can have a short lunch and come back again for the lunch. Very short of time. We will continue with our scientific program. Those who want to have their lunch, they can please go downstairs and have their lunch and come back again. So we'll be starting our panel on menopause. And I would request Dr. Varsha, our session in charge, to take over the stage. Dr. Varsha, can we have her here? I think Dr. Varsha was in the skit, so maybe she's somewhere. Dr. Varsha. May I request all the panelists, Dr. Abhijit Maldan, Dr. Apeksha Sahu, Dr. Durga Patwari, Dr. Isha Rani, Dr. Manisha Mishra, Dr. Meghna Bhagat, Dr. Priyam Prasad, Dr. Rashmi Singh, Dr. Shalini, and Dr. Vidisha Tolia to come for the panel discussion on menopause. Please come forward. And may I request our moderator, Dr. Manjupuri ma'am, to kindly take over the panel discussion. May I also request Dr. Savita Shukla Das as expert for the session to please come on the stage. Because of some unfortunate incident, Dr. Gayatri Singh ma'am could not make for the conference. So may I request Dr. Savita Shukla Das ma'am as expert for the session. I request the coordinators to arrange the please keep the 4 chairs this side and 4 chairs on the other side so that the screen is visible to the audience. Sangeeta Karan ma'am to come as expert for this session and accompany Dr. Savita Shukla Das ma'am.
A very good afternoon to all of you, and may I request everyone to please settle down. May I request everyone to please settle down so that we can start the panel. Request please. Yeah. So I welcome all my panelists here. We have Dr. Abhijit, Dr. Apeksha, Dr. Durga, Dr. Isha, Dr. Megha, Dr. Priyam, Dr. Rashmi, Dr. Shalini, Dr. Vidisha, and our expert, Dr. Savita Shukla Das. Welcome to all. So the panel was supposed to be on menopause. So given the time frame, which is only 45 minutes, so we thought that let's talk about decode the menopausal therapy, because that is what everyone is scared of, and many women who actually need it do not get it. And also talk about little bit of screening while we are discussing everything. So that is why the panel is on decoding menopausal therapy. Now we all know that estimated mean age at natural menopause in India is about 47 years. And menopause transition constitutes a biological window for preventive interventions lasting usually 4 to 5 years. And menopausal symptoms are multidimensional. So you might have people going to psychiatry with irritability, depression, sleep disorders. They might come to you with vasomotor symptoms, which often say nikal jayenge, don't worry, so tied away. So those are the things, and then there would be people who might come with dyspareunia because of the dryness of vagina, and they find it difficult to discuss all these things. And of course, we have our older women going to ortho with fractures because we have not done enough, right? Because we had not sensitized them what can happen. And menopause predisposes women also to lot of chronic health disorders. But then they go to the physicians only after they have got the disorder. So we are there in that position to prevent all those things in them, and that is why the importance of this panel. And we all need to understand that the life expectancy of Indian women has risen from 40 years now to 73 years. So that means we have good 20 plus years in our menopause if we say the median age is 47. With this background, we understand that there are disadvantages and the advantages of menopause hormonal therapy. We have benefits like symptom control for vasomotor problems. We have skeletal benefits. We have decreased coronary heart disease, and these are the things which are there. And whereas we look at the risks, you have strokes, you can have cancer, so all these can be related to that. So in about 70s and 80s, it was considered as the elixir of youth, and then when we have the WHI Women's Health Initiative report in 2002, then it was no to everything. And now we are, although the late report said that those side effects were seen in the higher age group, because all the people which were recruited that age in that study were plus 60 times, and that is why they already had comorbidities. That is why the risk factors were more. So you can use it now. But now, because once it is gone off the thing, now even if someone comes to us for, with complaints, we do not kind of go forward and tell them that you can have menopausal replacement therapy. So the principles are right woman, right age, right hormone, right regime, right route, right dose, and right duration. So it is these rights which we are going to discuss in our panel today. And these are the guidelines which are latest. I would all of you would like that all of you go through these guidelines by the Indian Menopausal Society 2026, released in February. So my first question is, a case is a 50 years lady presents to you in the OPD for a discussion regarding menopausal hormonal therapy, as she has not had her periods for the past 1.5 years. She is concerned about the impact of menopause on her health. So Dr. Vidisha, how would you kind of go ahead and counsel her and discuss the problem with which she is come to you?
Thank you, ma'am, for giving me this opportunity. Coming to MHT, first of all, I would like to hear her symptoms, and she is already menopausal because she has 1 year of amenorrhea. So I would like to discuss her with the indications and the symptoms which goes with the MHT, starting of MHT. So I think the most benefited symptom which we give MHT is vasomotor symptoms like hot flushes, night sweats, cold sweats, which leads to palpitations, anxiety, poor quality of sleep, and frequent getting up in the nights because of night sweats. So this is the most benefited symptom. Then again, the urogenital symptom of the urogenitary syndrome of menopause, which includes the genital symptoms like genital irritation, dryness, burning sensation, as well as sexual symptoms such as lack of lubrication, pain, discomfort, and obviously the urinary symptoms like symptoms of recurrent UTI as urgency, frequency, dysuria. Again, in women who have attained early menopause, or what we call premature ovarian insufficiency.
So this one is kind of 50 years. She's attained
yeah,
menopause in the 90s.
yeah. So
for her, what counseling would you do?
Yeah, if she is having any of these symptoms like vasomotor symptoms, genitourinary syndromes, disturbed sleep, menopause-induced depression or mood swings, or a generalized body pain and aches, which is not contributed to any other orthopedic condition, we could start her with MHT.
So you can, and she says that she's, gone through the Google and says
she is
that,
well aware of the.
And she's learned that the bones remain strong, the heart stays strong. So can she start it prophylactically right now? What would you suggest?
Not prophylactically, ma'am. If she has any of these symptoms, we don't use MHT as a prophylactically for like osteoporosis, or if she could develop coronary heart disease later on or dementia later on. We do not start prophylactically, but if she is suffering from any of these symptoms, then we could go for MHT.
So of course we should counsel her for healthy lifestyle at this particular point in time. Alright, so the indications which are recommended indications are vasomotor symptoms, symptoms related to urogenital atrophy, and of course, like she said, any patient who develops menopause and even diminished ovarian reserve, that is less than 40 years of age, we are supposed to give them replacement therapy. And of course, these are also indications where it can be started, but of course the evidence is little less, but it does improve. Related, menopause-related depression, changes, sleep disturbances, aches and pains. Of course, for prevention of coronary artery disease and for osteoporosis and dementia, it is a big no. You can't start it just because of this, because you have so many other methods which are effective and more safe as compared to MNT. So the same lady, if we look at her, so she's having a discussion, and she says that supposing she's got vasomotor symptoms, and she says how safe it is, or when you assess her for her eligibility for giving. So what are the contraindications where you cannot give MHT? So this is for Dr. Megha.
Thank you, ma'am, for the opportunity. So we need to counsel the patient, and MHT we need to say here, like as you had already mentioned, if we select the patient properly in the right patient with the right dose and the right duration and the minimum effective dose according to her symptoms and as well as the route of administration, it's far off safe, and we should counsel the patient. But prior to that, we should do a proper screening of the patient to rule out the contraindications as well. Like we need to first of all take the history, whether she's having, not mainly in India but in Western culture, more of history of smoking, alcohol. Then we need to do a detailed breast examination, if needed a mammography, then a lipid profile, and to rule out any history of TIA, strokes or any cardiovascular disorders. As well as we need to do a liver function test, lipid profile.
No, what are the absolute contraindications? Where we do not consider MHT. That is what
there are certain absolute contraindications where we need to counsel, and these things are there. We need to, like she is having any active liver diseases, any unexplained vaginal bleeding, or history of breast cancer, or any endometrial cancer. Then a history of stroke, TIAs, and DVT, history of venous thromboembolism, DVTs.
Absolutely. So these are the conditions wherein it is actually contraindicated. We have to think of other methods, and we do have other methods available. So any history of breast cancer, any history of cerebrovascular disease, previous thromboembolic active liver disease, unexplained vaginal bleeding, high risk for endometrial carcinoma, and of course transient ischemic attacks. So I think these are the things which we need to make sure that these are the ones who are at high risk we should avoid. You want to say something?
No.
So the key message is, for most women, menopause should be viewed as a window of opportunity rather than a disease of estrogen deficiency. It is time to pause, reflect, and follow therapeutic lifestyle management. We should not leave any stone unturned. When a woman comes to us with any of these problems, she may not have any problem. But if we find she's menopausal and she's come with some itching in the vulval region or something, we need to make sure we give her that whole package of regular checkups, screening, supplements. All that should start at 40 years, and gynecologists must not hesitate in prescribing MHT to the right patient in the right dose for the right duration. Case 2. So we have a 51 years old lady which presents to you in the OPD. She has not had her periods for the past 9 months. She has episodes of feeling of warmth followed by profuse sweating, due to which she is unable to sleep. So, Dr. Durga, how would you manage her now?
Thank you, ma'am, for the opportunity. This is basically a case of menstrual transition. First of all, to manage this case, we have to take proper history and systemic breast examination and pelvic examinations. We should do investigation to rule out.
Would you like to grade? Okay, it's already said that she's unable to sleep, so it is already a severe malady. So whenever a patient comes to you with vasomotor symptoms, we need to understand, is it affecting her quality of life or not? But here it's obvious, right? So you are going to assess her now, right? Okay.
So we will do investigation to rule out pregnancy, and other investigation to rule out other pathological causes, and we have to do screening test. And in this case, she's having quite severe vasomotor symptoms. So first line of treatment is a lifestyle modification, which include weight reductions, regular exercises, diet, balanced diet, stay in cool environment. And if all this doesn't work, then we should go for MHT. Low dose estrogen progesterone combination can be given, and if not contraindicated. In case of contraindication, we can use other option like SSRI, gabaline or pregabalin, and CBT can be offered, and also calcium and vitamin D supplementations to be given.
Absolutely right. So whenever you have a patient who comes to you with these symptoms, let's first assess how much is she disturbed with that. Because sometimes if it is not disturbing her routine life, then we just counsel her that this is a part of transition. If it is okay, then she can always change her environment and say wear some loose clothes and have air condition. And also tell her if she comes to in summers, the winters mein thoda better ho jayega. Tea, coffee, or those smoking and other things can be stopped. So we work around on those things. But in case it doesn't, then of course we have to offer her MHT after proper evaluation. Thank you so much, Durga. So the most effective treatment for vasomotor symptoms is hormonal therapy. But first line therapeutic lifestyle management is what is actually desirable, and if she is not responding to lifestyle modification, then we give her menopausal hormonal therapy. And here we need to understand she need not be menopause. I said these things can start even in the perimenopause phase. So even if a patient who comes to you in perimenopause phase, we should not hesitate in giving her hormone replacement therapy and giving her this advice. Thank you. The same patient, how would you do the risk assessment before initiating MHT? We have discussed it a little bit, but Isha, can you elaborate it a little more?
Thank you, ma'am.
Yeah.
Risk assessment before starting menopausal hormonal therapy is very important, and the most important risk which we have to assess is cardiovascular risk. We have to take a detailed history of habits, whether she is having any history of smoking or alcohol intake, any history of hypertension in the family, any history of early stroke, and we have to grade her according to the CVA risk assessment grading. If she is having a low grade or a moderate risk, then we can offer her MHT, but if she lies or falls in the high grade category, then it is absolutely contraindicated to start MHT. Along with cardiovascular risk assessment, we have to also assess her on the risk of cancers, breast cancer and endometrial cancer, regarding any family history, and current screening also has to be done. Also for breast cancer, we have to offer her mammography before starting her on MHT, and also along with cardiovascular and cancer risk, we have to give them the risk factors, what they should be concerned about, like what are the risk factors when they should consult a gynecologist immediately if they are having such symptoms while on MHT.
So I fully agree that we need to do a detailed assessment, and aim is to look up any cardiovascular risk factors, any thromboembolic risk factors, and any risk of cancers. So that is all what we need to see. It can be on history, it can be on blood pressure management, you can measure her blood pressure when she comes. Please do a clinical breast palpation, offer her a mammography after 40 years, every 2 years they should be offered mammography. If not 40, after 45 years. And her BMI needs to be measured. And that is a good time to tell them to follow healthy lifestyles because they are symptomatic. So you tell them that if this works, then everything is going to be better. Of course, you do her blood sugar, and we always do a GTT, that is the fasting, and we do a 2 hours, 75 gram glucose. We do a lipid profile, we do a mammography, and all this is mandatory before we move on, right? So that is what is to be assessed. Thank you there. And of course, we have these risk assessment tools which are available, from wherein you can put in all the factors and find out. And if the patient is low risk, that is less than 5% risk of having cardiovascular disease, then it is okay to give MHT. Otherwise, we think of other things, right? So my key message here is that treatment for vasomotor symptoms, treat all patients with vasomotor symptoms affecting their quality of life. So that is the first thing you need to assess. And first line therapy is therapeutic lifestyle management, right? And do not hesitate in starting MHT. And another important thing here is that when a patient is in the perimenopausal period, you can even give her low dose combined oral contraceptive pills. They will also look after the contraceptive part. Right, in case you give the sequential therapy, MHT, then she might conceive in that, but here she would not. So that is what is the information. So we can, after doing a risk assessment, we can start them on combined oral contraceptive pills as well. Thank you so much. So my third case is a 58 years old postmenopausal lady presenting with this pyonia. On per speculum examination, the vagina is atrophic, cervix is flushed with the vault. Per vaginal examination, uterus is small, atrophic and mobile, and fornices are clear. So how would you manage Dr. Abhijit?
Good evening. Thank you, ma'am, for giving me this opportunity to share this academic platform. So as the patient is 58 years old and postmenopausal woman and having history of dyspareunia, and on examination atrophic vagina is present. So it is a case of atrophic vaginitis which can be dealt with the moisturizing of the vaginal epithelium to increase its thickness by applying estrogen, which can be in different potency, E1 into E3. According to the potency, we can choose the suitable formula. And during dyspareunia, we can use the water-based jelly also for the lubrication.
Fine. So what we need to understand is that the first line is never a hormonal therapy first. We can always offer them some lubricating jelly, right? And of course do a little bit of counseling as far as the sexuality is concerned, because the libido also goes down. So there is lack of lubrication. That is what you need to explain her. Tell her nothing is wrong, but it may be lack of lubrication either because of decreased libido or because of declining hormones. So it needs a sexual counseling as well. And at the same time, we also must make use of this opportunity to ask her if she's had a pap smear done in the past, although she's 58. So we must do a screening also for them. So we must not miss out. I think every time we should repeat that whenever a patient comes to us with any problem, we must do a breast examination, not only for starting MHT, otherwise. Offer her a mammography. Yeah.
Counseling regarding self-breast examination.
Yeah, that also should be included. We must do her, we must offer her all the investigations. That, TSH, her complete blood count, if her hemoglobin is low, let's make her healthy. That's the time when you can make use of all your, this is opportunistic screening. So we must not forget that that is also to be done. Yes, you are right that in case the local jelly doesn't work, then of course, once you have explained, she would understand. And then in that case, you have to give her a local vaginal, ointment. Any other condition where we give local vaginal estrogen creams?
Local vaginal estrogen cream during where the vaginal defense is very low, we can do.
No, any other symptom with which a menopausal patient might come to you, wherein you might...
In this patient?
No, in this patient, it is dyspareunia. But can a menopausal
urogenital symptoms we can apply.
Yeah. So recurrent UTI.
Recurrent UTI
that would be another condition wherein, this works. These are ointments which are available. And can you just throw some light on how these ointments do, how would you tell her to use these ointments? How frequently?
First of all, we have to choose the correct thing. After lubrication, if it doesn't work, then we should go for estrogen cream. And DHA cream also available, and oral drugs are also available. We have to give her option which way she can.
No, which one will you prefer? Would you prefer a vaginal cream in this, or would you prefer a systemic oral preparation?
I will prefer for this patient, as no other symptoms are present, local application will be better for her because there will be no unopposed estrogenic effect in the system. So I will first of all counsel her and tell her to use this as a week, daily for 2 weeks, and then twice a week, then weekly, then she can stop after getting the desirable effect.
Do you need to prefer because the uterus is intact? Would you like to give her progesterone because you are giving only unopposed estrogens?
No, 58 years old progesterone, I would not prefer for her.
Right? I'm saying age is not a barrier.
The triphasic pill will not work this.
Sorry, I couldn't get you.
The triphasic pill, where the progesterone estrogen.
Here, actually, anyone who wants to add on as to why do we not give, it is unopposed estrogen, but why don't we want to give progesterones?
Because ma'am, local application of estrogen may not cause endometrial hyperplasia.
So it's very small dose. So it does not normally require, progesterone for at least if you use it for 6 months to 1 year. And here normally 2 weeks time is okay. So it has got an applicator. So ask her to put the tube on that, fill up the applicator. Also, lubricate the tip of the applicator, put it on her vulva, introitus, and then push it. It goes in also and then pushes it. So you have to tell her how to use it. So every night for 2 weeks, then every other day for next 2 weeks, every third day for next 2 weeks, once a week for another month or so, and everything is going to be fine. Is it right? So this is what is available. We have Evolon gel, we have Premarin gel, we have E2 gel available, right? So it is very, very useful. So the key message is for genitourinary syndrome of menopause, women with moderate to severe symptoms who do not respond to lubricants and moisturizers, low-dose vaginal estrogen therapy. Systemic will be given only if she's got vasomotor symptoms associated. So that would be a good candidate for systemic. It would work on both, right? And I've already told you that. So other indications are recurrent UTI and also those patients of breast cancer who operated, who have vasomotor symptoms. There we can't give them oral therapy. This would be a good option after consulting their oncologist.
Ma'am, patient having breast carcinoma or breast cancer history, they can be offered the SARM, ACRM.
Yes, but this is also one of the ways because there the amount which goes, that would be very limited.
Those may be filled, like
no, you can definitely offer, but it has to be done in consultation with the gynae onco who is treating the gynae or the surgeon who who is treating the patient. Is it right? We have other options also available. But this is when we are talking that there is a local problem. Then
with systemic manifestation of
no, if there is a systemic along with the local problem.
Along with history of breast cancer.
Cancer, we are never going to give them systemic. That is sure. In cancers, we are not going to give them systemic. I am only talking about patients who have been operated for breast cancer. They have symptoms. This is one of the options because very little dose goes in. And it does not require any. Yeah, do you want to say something?
As you said, operated breast cancer patients, if they have vasomotor symptoms as well, we can offer them these preparations. But how are these preparations going to help her with her vasomotor symptoms?
It is a lower dose. They are more than 25, and of course above 40 you definitely think that so we rather call it as primary ovarian insufficiency. That is the term which is used. So it is defined as hypergonadotrophic hypogonadism before the age of 40 years with intact ovaries, and it includes the spectrum of declining ovarian function and reduced fecundity. Is it right? So we normally would have these patients coming for infertility to the infertile people, the specialists, right? And 50% of these will have periods, but they are not going to have any good oocytes for pregnancy. They have to be offered donor oocytes, and 5 to 10% might conceive spontaneously, right? So if it is a premature ovarian failure, then what would it be like? What would be the history like?
Ma'am, it would be, as said in this case, it would be like prolonged cycle duration, cycle length, and then scanty flow, and spread over 6 months or 1 year, she's having those kind of cycle length.
So I think we need to differentiate between premature menopause. Menopause means post. So that means she's already had 1 year of no.
She will have complete amenorrhea.
Complete amenorrhea. For more than 1 year, then we say it is premature menopause, if happening before 40 years. But in case she's having irregular cycles with raised FSH, then we use the word primary ovarian insufficiency. She's not yet menopausal. She might stay like this for maybe 2 years, 3 years before she goes into menopause, right? Okay. Thank you so much. Alright, so the same lady, what are your concerns, Apeksha, in this patient? And say she comes to you and you tell her that you have got primary ovarian insufficiency. So what are the things which you would like to counsel her for?
Good evening everyone, and thank you ma'am for the question. Ma'am, since she is 35 years old, we just need to understand what is her parity, because at this 35 most of the people are getting married, having a late marriage. So if she happens to be a case of having nulli parus, something like that, so my first concern will be about her fertility. Now if she is somebody who has completed her family, in that case still we need to consider, because early menopausal, which is a very big concern nowadays, being an infertility specialist, we do have women at the age of 26, 27 who are having AMH as low as like 0.56, something like that. So apart from fertility, there will be vasomotor symptom, there will be increased risk of heart diseases, some neurodevelopment like dementia and all these stuff, some other condition like urogenital atrophy. They do have a difficult family life, more of irritability and all, and it becomes difficult for the family to cope up with that. So apart from fertility, these are the other factors which might affect, and long term the heart receives this osteoporosis and the mental effect of dementia and all.
Absolutely. So it is not only that they come for, they don't have any symptoms, you need to treat them because they are supposed to have their periods till the age of 47 years and she's just 35. So if we don't give her now, she's bound to have cardiovascular problems, she's bound to have osteoporosis, she's bound to have all the changes with the menopausal women will have. So we need to put her on MHT.
My one more question that comes to my mind being an infertility specialist, like post-COVID era, I mean, we are often seeing more women with a premature insufficiency. Now, COVID is a thing which has increased the cardio thromboembolic disorder. Now, in this, I mean, yet there are no studies about it, but in cardiovascular disease, when we are seeing COVID people having a more of a thromboembolic disorder, cardiac arrest at an early age, so we are still not sure how MHT might help them or may not help them. Apart from giving a low dose estrogen and all, but still that question keeps bouncing onto my mind because post-COVID era, I mean, what being in Lady Harding, there might be patients who are requiring low molecular weight heparin, maybe say like in a month, 1 or 2, but post-COVID era there have been a lot of study where we are requiring for APLA positive and all a lot. So ma'am, how good are we prescribing like hormonal therapy to them?
I think it's a very good question, Apeksha. So basically, you know, we don't know what COVID is done and we do have a lot of unusual things happening. But there is no correlation fixed as such. We do not have studies which actually prove that COVID is led on to all these things because the data is not, you know, kind of compiled. But we need to do more, you know, we need to use MHT more judiciously. I'm saying this is a kind of patient where the evaluation should be very thorough, the follow-up should be very thorough, and we should counsel them that if she has already had COVID and she had, you know, heart problems and she had, you know, lung problems, she was on a ventilator, she can have, you know, pulmonary hypertension. So those are the things which we need to be a little more cautious and take more opinions on that. Is it right? So a little more detailed workup would be required. Thank you so much. Thank you. So remember that these are the patients where you can put them on OCPs also. She's a young patient. She's a young patient, so it need not be MHT alone. Put her on OCPs. It would be a good case for putting her on OCPs. Okay? Provided the pregnancy is not an issue. And of course, we have to tell her that she has to go for a donor egg. She can't have a you know, pregnancy of her. Okay. So these are the impacts of primary ovarian insufficiency, emotional trauma, loss of fertility, vasomotor symptoms, urogenital atrophy, osteoporosis and fractures, cardiovascular disease, neurocognitive, all these. So that means we have to start screening her like any other menopausal patient and treat her. That is what is important. बिल्कुल ऐसे भेज नहीं देना उसको treatment करना बहुत जरूरी है. That is what is important. So my key message is all patients of POI or premature menopause need to be counseled for therapeutic lifestyle management and prescribed MHT till the age of natural menopause. That's approximately 47 years. ये नहीं कि 40 तक ले जाए 35 से 40. It has we should aim to 47, right? Okay. Now Shalini. Tailoring MHT, how to decide the dose, duration and route?
Ma'am, as per the estrogen and progesterones which we most commonly use as part of MHT, there are different estrogen preparations like we have 17-beta estradiol, we have CEE which is combined equine estrogen, and we also have estradiol valerate. And in progesterones we are most frequently using dydrogesterone and micronized progesterone. As far as which preparation is to be used in whom, is like vasomotor symptom is one thing which requires a systemic therapy, whereas rest may do well with a local therapy as well. And there are some specific uses of CEE as compared to 17-beta estradiol. Like CEE is lipid profile friendly, it raises the HDL level and it decreases the lipoprotein A level. So therefore it is preferred in patients who have low HDL. And whereas 17-beta estradiol, the transdermal route, It is preferred in patients who have a CVD and a metabolic risk. So therefore it can be used in patients of type 2 mellitus, type 2 diabetes, in patients with insulin resistance, and in patients who have a high BMI. And plus the progesterone use, it is only to prevent the endometrial hyperplasia which is caused by estrogen. So any progesterone preparation can be used to counteract the endometrial hyperplasia. And we are most commonly using...
But which ones are better? Like you have norepinephrine, you have medroxyprogesterone acetate.
Ma'am, we have dydrogesterone and we have micronized progesterone. It also depends upon the route we are using. Like the vaginal route is preferred. So micronized progesterone comes in a vaginal route. So that is preferred over the oral route. So ma'am, I would say that medroxyprogesterone should be preferred more than dydrogesterone. And as far as, and there are some doses of all, we have the standard dose, like we know, like CE is used as 0.625 milligram, but the dose should be tailored as per the patients, the needs, the side effects, the compliance. All these things have to be taken into consideration while we are tailoring the dose of MHT. And there is one thing more, like we should start with a low dose. We reach the dose which is apt to suppress the symptoms, and then we should continue at the low dose possible. So, and it also depends upon what type of regime we are using. Like when you are using a continuous regime of HRT, so we have to use a lower dose. So in those patients, a lower dose of medroxyprogesterone or a dydrogesterone is preferred. But in patients who require sequential MHT, we usually use a higher dose of progesterone, either 300 or 10 milligram of dydrogesterone.
So yeah, thank you so much. So basically, I think we need to understand is there are two ways you can give. Either you give continuous or you give sequential. Sequential would mean that you are giving estrogens and then you add progesterone for the last 12 days. That is what is sequential. So she's very rightly said that when we give continuous, so we give lower dose of estrogen, lower dose of progesterone. And when we give sequential, then it has to be higher dose of estrogen and higher dose of progesterone, which is very, very valid. But you know, when we talk about which preparation is better, then we have bioidenticals. All micronized preparations have least side effects. You are right, medroxyprogesterone is absolutely fine. It used to be used, but now because we have micronized and we have dydrogesterone, they both are more friendly, metabolic friendly. So they are supposed to be, a little better. And of course, when you say, and for estrogen, it is fine that we use conjugated equine estrogen, but again you have, estradiol, which is propanova, which we normally say. So that is also considered to be a little more, friendly. But you are right when we say that CE is definitely, it improves the HDL levels. Right, so we can use either of them, but I think this is what is the latest, that these are the ones which are preferred. So when we look at the regime, I think Shalini's already, talked about, or would anyone want to say which regime, E plus P or only E? Yeah.
Like ma'am, in patients who are hysterectomized, definitely a estrogen only regime can be preferred, but in patients who are not, and we need to have a progesterone to counteract the estrogen hyperplasia which is caused. So preferably in patients who are just menopause in empty menopause transition or just 1 year post menopause, the preferred would be definitely estrogen and progesterone. But in patients who might have a subtotal hysterectomy or those who are known cases of endometriosis, so irrespective of the uterus present or not, it's better to add a progesterone. So estrogen only is basically in those patients who do not have a uterus, and combined in patients with a uterus.
Do not have the uterus, and also uterus has not been removed for endometriosis.
Yes ma'am, not for endometriosis. Yeah, so
because progesterone is the culprit which right route is estrogen, oral route is to be avoided because it has a first pass, it goes to the liver. Right, so that is why it is to be avoided in patients who have metabolic syndrome like they have hypertriglyceridemia, active gallbladder disease, risk of VTE because all coagulation factors are again made in the liver, obese patients, diabetic, hypertensive smokers, all these high risk patients, you don't give a oral route. That is you prefer a vaginal route. And of course, vaginal route is the route of choice for genitourinary syndrome, and progesterone oral route is avoided. If, when we give micronized progesterone orally, they have that nausea, vomiting, and they have being sleepy and other things. So, vaginal route can be given, and LNG also is a very good idea. So LNG can also be coupled with estrogen therapy, and that will reduce the risk of thromboembolism. Right? Okay. So my last question is to Dr. Priyam. Dr. Priyam, can MHT be prescribed for cancer survivors?
Good evening, ma'am, and thank you so much. First of all, MST is not absolute contraindicated in all the cancers. Before prescribing MST, we will see type of cancer, its grading, is it grade 1 or grade 2, histopathological type, recurrence rate, or whatever it is, a genitourinary syndrome or vasomotor syndrome. Then, first of all, we can see most common is uterine cancer. In uterine cancer, grade 1 and grade 2, MST can be prescribed after oncologist and gynecologist consultation, but before reducing the risk recurrence, as bilateral or salpingo-oophorectomy is done, and MST is prescribed up to the natural age of menopause, that is the age of 47 years. Because in uterine cancer, estrogen and progesterone receptors both are called, that is why we will use generally systemic MST.
And also medroxyprogesterone acetate will be a choice. Instead of micronized, you would want to put them on medroxyprogesterone acetate.
Yes, ma'am.
So that is also very important.
Yes, ma'am. And otherwise, cervical cancer, in cervical cancer, whatever the case of cervical cancer, we have done hysterectomy or patient has been gone to surgical menopause, we will prescribe the MST until the age of the natural menopause, so that the genitourinary and vasomotor symptoms can be subsided, and cognitive behavioral therapy is first of all given, lifestyle modification is given, vitamin D, calcium, all simultaneously, all helping up to the counseling to the patient. Now, ovarian cancer, in ovarian cancer, we see what is the histopathological type? Is it serous cancer, or is it 6-cord tumor cancer, or is it granulosa cell tumor cancer? In ovarian cancer, we can prescribe MST except 6-cord tumor cancer, granulosa cell tumor cancer, and serous cell cancer. We are absolute contraindicated in MST. And now, last but not the least, in our country, breast cancer. In the breast cancer, systemic MST is absolutely contraindicated. As you have said, that increases the risk of cancer. So, in this case, there is, if any, vasomotor symptoms or genitourinary syndromes, local application is preferred. Along with cognitive behavioral therapy and lifestyle modification is recommended to the patient. And before patient came at the age of 40 or 45, whatever they came, self-breast examination, along with all the screening tests, family history of cancer. Either it is ER receptor positive or BRCA1 or BRCA2 gene, is it thyroid cancer or colorectal cancer, we have to check which type of cancer in that patient or that lady, maybe after that, or family completion is done before that age. If mother is having family history, so we prescribe her child that your daughter should be complete her age up to the age of 25 to 30 years, so that if cancer occurs, so we can her child her brother. Thank you, ma'am.
Thank you, Vidisha. So basically, it is not an absolute contraindication. We can't allow the patient to suffer. If she's got problem, we have to find out a solution, but that has to be a multidisciplinary approach. We have to get in touch with the oncologist, discuss it out, look at all these aspects, the type of tumor, the stage, the recurrence and other things, and then accordingly kind of give her. So now I will move on to our expert, ma'am, if you want to put some tips on how should we generally manage our menopause patient.
Thank you to give me an opportunity to share the session. Thank you to all the panelists.
Absolutely.
They are well prepared and they answers every question very well. And in addition to this MST, we should patient to take daily health management, day-to-day management like exercise, nutritions. In nutritions, we can prescribe her calcium, vitamin D3 regularly, and take sun 2 to 3 hours daily, and exercise to prevent the osteoporosis and muscle reduction. They should do exercises and muscle to build the muscle, and they should take excess protein to prevent the sarcopenia, muscle loss, and just aerobics. She should done aerobics, and all the exercises is most important in addition with these MST.
Thank you so much. So basically, anyone who's saying...
Excuse me, ma'am. Ma'am, thank you for you, ma'am. Actually, MST सबसे neglected topic रहा था, but during this panel हम लोगों ने बहुत पढ़ा थोड़ा बहुत, ठीक है, और मतलब कि अच्छा knowledge हुआ. Thank you so much.
So we still have 1 minute. Can you quickly give one message जो आपकी अब इस panel के बाद practice बदलेगा? फटाफट बताओ, इधर से शुरू हो जाओ. How will your practice change? What are you going to do if you get a menopausal patient? कोई भी एक चीज बता दीजिए जिसमें हम उनकी केयर को दोबारा से नहीं मैं मेरे पेन अच्छा चलो ऑडियंस से बता दीजिए. हाँ, स्क्रीनिंग फॉर कार्सिनोमा सर्विक्स, कार्सिनोमा बॉडी यूट्रस और कार्सिनोमा ऑफ ब्रेस्ट जरूरी, ठीक है? और कोई जल्दी से सब लोग ऐड कर दीजिए.
Our Indian females, especially menopausal, are not even aware that what they are facing is actually a problem and can be treated. तो हमें सबसे पहले उनको आगे बढ़कर पूछना पड़ेगा कि आपको ये सारी प्रॉब्लम्स हो रही हैं. अगर हो रही हैं तो आप उससे निजात पा सकती हैं.
चलिए, I think the organizers are behind me, so I conclude that for most women, menopause should be viewed as a part of healthy aging rather than framing this natural period of transition as a disease. And prevent over-medicalization by promoting hormonal therapy as empowerment. So we must not deprive them of the MHT, and MHT is not one size fits all. You have to suit the MHT for a particular patient, right? Thank you so much.
Thank you so much, ma'am, for such enlightening panel talk. Ma'am, kindly felicitate the panelists, ma'am. interesting talk on menopause. And now we would like to call upon stage Dr. Pratibha Rai ma'am, Dr. Shivani Jha ma'am, Dr. Renu Upadhyay ma'am, and Dr. Nupu Chandan ma'am to take a seat as chairperson. And I would like to call Dr. Abha Rani Sinha ma'am for the next talk, screening in preeclampsia.
Good evening, everyone. Today's talk of Abha Rani Sinha is screening of preeclampsia. She is one of the beloved doctor among us. She is MBBS honors gold medalist, DGO, FICOG professor and HOD master trainer of Oxy. Special interest in high-risk pregnancy awarded for Dr. D.K. Tang Trophy and Sadhana Desai population. So, please start.
Thank you, dear chairpersons, esteemed audience and dear friends. And there are many students in this audience and I am so happy to see them and meet them today. And first of all, thanks to the organizing chair, Dr. Komal, and organizing secretary, Dr. Reena, and the whole team of DHANBAD OBS and Gynae Society for inviting me to give a keynote in this 6th conference of DHANBAD OBS and Gynae Society. And I'm going to talk about screening of preeclampsia because we all know that hypertensive disorders of pregnancy are an important cause of maternal mortality and morbidity, and it has a huge burden. If we look at the global prevalence, it is around 5 to 10% of pregnancies. In India, it is 7.8%, and it is one of the major cause of maternal mortality, leading to about 12 to 18%. While I was in the medical college, I was really surprised to see that every month, when we used to present the maternal mortality, now hemorrhage is coming after HTP. So HTP is very, very important. So we all need to screen these cases in the first trimester of pregnancy because if we see the classification, just to revise it, chronic hypertension which is present before pregnancy or diagnosed before 20 weeks. In preeclampsia, what happens? There is incomplete invasion of this extravenous trophoblast, and therefore there is insufficient maternal blood flow from the spiral artery, and therefore leading to placental hypoxia. And here there is SFLT1 is secreted from the placenta, which suppresses the vascular growth endothelial factor, vascular endothelial growth factor, and therefore there is endothelial dysfunction. And this endothelial dysfunction affects all the organs of the body. And there is appearance of the various clinical symptoms which may be in the form of eclampsia, HELLP syndrome, proteinuria, fetal growth restriction, and even it may represent as edema. So even FIGO encourages all countries and its member associations to adopt and promote strategies to ensure screening, particularly in low-resource countries. Actually, always when we look at the multi-marker screenings, the main limitation that we have is the cost of the screening. So now we will see what we can do for the low-resource settings and what is feasible for us and at least what we should do. So all pregnant women should be screened for preterm preeclampsia during early pregnancy by the first trimester combined test with maternal risk factors and biomarkers as a one-step procedure, and the risk calculator is available free of charge at https fetalmedicineaward.org research access preeclampsia. So there are different clinical models for prediction of hypertensive disorders of pregnancy. If we look at NICE, ACOG and ISSCHB, they use maternal history and risk factors. The PMSMA, it is risk assessment at 12 weeks, and then depending on the risk, we start aspirin for high-risk women. FOXY recommends the HDP gestosis score. I'll be talking in detail about the gestosis score for early prediction, which is a simple India-specific tool. This is important that this is especially for Indian women, and if the score is more than 3, then we label these women at high risk and we start aspirin for these women for 16 weeks plus calcium. Now if we talk about the combined test, it includes the maternal risk factors, the measurement of mean arterial pressure, serum placental growth factor, that is PLGF, and uterine artery pulsatility index. Now, if we look at the maternal risk factors, a pregnant woman is considered to be at high risk if she has any one major factor, which could be a history of hypertensive disease in previous pregnancy, chronic kidney disease, autoimmune disease, diabetes mellitus, chronic hypertension, or multifetal gestation. They are all major factors. Or if she has any two moderate risk factors, like if the first pregnancy, if the age is less than 40 years, more than 40 years or less than 19 years, that is a teenage pregnancy. If the inter-pregnancy interval is more than 5 years, if there is a family history of preeclampsia, if there is primary paternity, or BMI at first visit is more than 35 kg per square meter, or it is an IVF pregnancy. Now, these risk factors have been described by various professional organizations, especially NICE and ACOG, for the identification of women at risk of PE, but this approach to screening is inadequate. If we only consider the risk factors, we know it is inadequate for effective prediction of preeclampsia. So, if we look at the detection rate, if we are just using these risk factors, according to NICE guidelines, the detection rate is only 39% for preterm PE and 34% for term PE, and the false positive rate is 10.3%. So now coming to the HDP gestosis score, as I said, this is developed in India. It is a dynamic scoring system and which can be done even at the basic level healthcare worker in any setting. So when should we do it? It should be always done at the first visit, and preferably should be repeated at every antenatal visit until 32 weeks of gestation, or at least once in every trimester, or on emergence of any new risk factors. It is also accepted by the National Health Mission India, and it is routinely practiced in many states. Yesterday only we had the World Gestosis Conference in Pune, in which Dr. Hema Divakar was elected as the president of this society. Now, what is this process of risk scoring? The risk scoring involves all the existing and emerging factors in the pregnant women, and there are 3 scores, 1, 2 and 3 for each clinical risk factor as per its severity in development of preeclampsia. So with careful history and assessment of women, a total score is obtained time to time, and whenever the score is more than 3, we know that these women, they are marked as at risk for preeclampsia, and this is also available online if we click on www.hdpgestosisscore.com, and this is the scoring. It's a busy slide, but we can see that the scoring is given 1, 2 or 3. I think this should be printed and kept on in the ANC clinic of each and every women, every practicing gynecologist. This should be on the table, and whenever you see these risk factors, you can just chart it out and you can say whether it is 1, 2 or 3, and whenever it is more than 3, we know that these women, they may develop preeclampsia, and in them we can start aspirin early. A simple way is just taking the mean arterial pressure, but again the taking of blood pressure is very important. It should be taken by validated, automated and semi-automated devices, and it is MAP with a false positive rate of 10%. So for low resource countries, at least we can do this, we can have the risk factors, and along with that, if we have the MAP values, if we combine them both, we have got a good detection rate. Now PLGF, several studies have shown that women who subsequently develop PE have significantly lower maternal placental growth factor concentrations in the first trimester than those with normal pregnancy, and it has got a detection rate alone only 55% for early onset and 33% for late onset preeclampsia, and it has got a 10% false positive rate. And there was a systematic review and meta-analysis that also showed that PLGF is superior to other biomarkers for predicting preeclampsia, and alone it can have a detection rate of 56% at 9% false positive rate. The other marker that has been used is PAPA, and low levels of PAPA are associated with higher incidence of preeclampsia. A study was done, a last study on around 1,32,076 pregnant women in the first trimester, and it was found that the maternal PAPA concentration of less than 5% is associated with the risk of developing preeclampsia with an odd ratio of 1.94, and it has a detection rate of 16% and 8% false rate to predict preeclampsia. And the conclusion was that if we use this PAPA as a single marker, it is not an accurate predictive test for preeclampsia. Now uterine artery Doppler PI, again this is very important because this abnormal uteroplacental circulation can be observed in the uterine arteries by ultrasound, and that is from as early as the first trimester of pregnancy. So in this what we do a transabdominal ultrasound, we have a sagittal section of the uterus, and the uterine arteries are identified, and with the use of the color Doppler flow, a mapping is done at the level of the internal cervical os, and the uterine artery PI and the peak systolic velocity are measured. And the average of the left and right uterine artery PA is used for risk assessment. And when do we say it's abnormal? If it is greater than 90th percentile. And this was found to have a detection rate of 48% with an 8% false positive rate for the identification of early onset PE. And the detection was for late onset was again very less, that it was 26% at a 7% false positive rate. So patient-specific risk for preterm preeclampsia can also be calculated by the Bayes theorem, which combines the priority risk from the maternal characteristics and medical history with the result of various combinations of biophysical and biochemical measurement. And a woman is considered high risk when the risk is greater than or equal to 1 in 100. And here we use the combined test, that is the risk factors plus the mean arterial pressure along with the PLGF and uterine artery PI. And this is what the combined screening is showing. So if it is low risk, if it is less than 1 in 100, and it is high risk if it is more than 1 in 100. The low risk women, they are just taken up for routine prenatal care, whereas those who are high risk, they are in them aspirin is started 150 milligram right from 11 to 14 weeks until 36 weeks. Here we can see that the best results are with when we are doing the combination of all, that is risk factors along with the MAP, uterine artery PI along with the PAPA and placental growth factor. The other form of screening, especially for low resource setting, would be a contingent screening, where routine screening for preterm PE by maternal factors and MAP is done in all pregnancies, and reserving measurements of PLGF and UTPI, that is uterine artery PI, for a subgroup of the population which are selected on the basis of the risk derived from screening by maternal factors and MAP. Here we can see this chart, like initially we are doing only two things, that is maternal risk factors and MAP, and in these patients we see who are screen positive and who are screen negative. Those who are screen positive, they go the secondary stage of screening, that is with the placental growth factor and the uterine artery PI, and if they are screen negative, then in those cases we just go for the routine prenatal care, and those who screen positive, even with the second stage screening, then we start aspirin. So when this two-stage screening was done, there was a study in which about 1,20,000 single-gem pregnancies were studied by this, and it was found the preterm PE was found to have a screening positive rate of 10% with a detection rate of 71%. This was the famous trial, that is a combined multi-marker screening randomized patient this was developed from a study of approximately 60,000 single-term pregnancy. Here the combined screening detected 76.6% of cases of preterm PE and 38.3% of term PE at a false positive rate of 10%. And this screening was important because those women who tested positive, they were started with 150 milligram per day of aspirin from 11 to 14 weeks until 26 weeks. But they found no evidence that aspirin could reduce term preeclampsia. This is a very important observation, that whenever we are using aspirin, what we are reducing is the early preeclampsia. Nothing is working on the late preeclampsia. So here still we have a gap where the prediction is not helping us in reducing the incidence of late preeclampsia. Because this study showed that the use of aspirin, though reduced the length of stay in the neonatal intensive care unit, that was mainly due to the reduction in the preterm delivery associated with early preeclampsia. So it did not have any effect on the late preeclampsia. Whenever we are screening, it should have some advantage, and the advantage is that we can start aspirin along with calcium supplementation in those who are screened positive, and along with that, we can start our monitoring and surveillance. Measurement of BP is very, very important. I think all of us know that the patient should be relaxed and her bladder should be empty, she should be in a sitting position, the instrument should be at the level heart, the cuff should be adequate, and Potapov phase 5 should be used to diagnose diastolic BP. And the use of a protein lipstick should be used to detect proteinuria. But these days, it's better that we use 24-hour urinary protein or protein creatinine ratio. This is about the latest HDP guidelines which has been introduced by FOXY in 2026. Now, as I was talking, there are limitations of first trimester screening. That while in preterm preeclampsia, the abnormal placentation is all those things to trigger factor of the disease, and effects are available to be detected at 11 to 13 weeks. But in the late onset form, the placental dysfunction seems to depend upon the villus overcrowding, which takes place in the third trimester and does not give any clue at the time of the first trimester screening. So when we are these days, we all know that in the antenatal care we have the inverted pyramid model, that is the 11 to 13 week screening, which can pick up the vast majority of the women who will develop any pregnancy complication. But this inverted pyramid model is not able to pick up these term preeclampsia. We all know that this is not a very small problem, as late onset preeclampsia in our clinical practice is 3 to 6 times more common compared with the early onset time, and available data have shown that though outcomes for mother and baby are more severe in preterm preeclampsia, but still the contribution of term preeclampsia to maternal morbidity is substantial. So if we want to optimize the antenatal care of preeclampsia, the inverted pyramid model based on the first trimester screening does not seem to meet all the requirements, and using this approach and giving aspirin to the screen positive cases may certainly reduce the incidence of preterm preeclampsia and its related complications, but this has little effect on late preeclampsia and its associated maternal risk. So according to the inverted pyramid model, most of the pregnancies will develop term preeclampsia would be assigned to be apparently low risk groups and which falls outside of the pyramid. So I'd just like to conclude that preeclampsia is a complex and heterogeneous in nature with varied presentation. Prediction of preeclampsia is to be based on multi-parametric approaches, and the HDP gestosis score, which is developed in India, is a dynamic scoring system which can be done even by basic healthcare worker in any settings. And screening for PI that combines maternal characteristics and clinical history with biomarkers along with uterine artery Doppler performs more efficiently compared to other methods till date, but still it may have limitations in terms of affordability, as I said, in low income groups. So depending on the available resources, I could say that at least you use any of these methods which may be used for preeclampsia screening. However, it is essential that preeclampsia screening be integrated into routine clinical practice. So whenever your patient is coming for MT scan at 11 to 13 weeks, either uterine artery PI, and at least you can screen for the risk factors and you can measure the MAP. So I think that much will be enough. So while first trimester preeclampsia screening and intervention with aspirin is an exciting development, the regimen does not predict or prevent most cases of preeclampsia. So still we need researchers, still we need trials to identify ideal combination of markers that can be used for
Thank you, Abha. Thank you for your brilliant talk. We think it will be helpful for us to day-to-day practice is increase maternal mortality. We should decrease this maternal mortality in our chamber, in our hospital. You have given the chart for the scoring pre-eclampsia score. We should go for that. Thank you, thank you.
Thank you so much.
You are brilliant throughout your academic. I am admiring you from very beginning.
Childhood friends.
And here are so many students of you. Thank you, Abha.
Sure, Kavita. Actually, the recommendation is 150. But the problem is that most of our women are inmates, and if she is an inmate, we can give 75.
Can I request Dr. Leena, Dr. Komal ma'am, Neha and all the chairpersons to kindly come forward?
नहीं सुनाई पड़ा सुनाई
Request all the chairpersons to kindly felicitate Dr. Abharani Sinha ma'am. हमको भी मतलब May I request Abharani ma'am to felicitate all our chairpersons, our senior members. Pratibha Rai ma'am, can we have a round of applause for Pratibha ma'am? May I request ma'am to felicitate our past president Shivani Jha ma'am and a school friend. Ma'am, please felicitate our past secretary, Dr. Renu Upadhyay ma'am, our present vice president. I request ma'am to felicitate Dr. Nupur Chandan ma'am, treasurer of DSOG. Thank you so much ma'am for doing the honors. Thank you all the dignitaries on this dais.
Good evening. As we move forward to the next scientific session, I would like to call the respected chairpersons on stage. I would like to call Dr. Ritu Tiwari ma'am, Dr. Sangeeta Karam ma'am, Dr. Asha Rai ma'am, and Dr. Shweta Sajiv. I request you all to please come on the stage.
Ma'am, please, to enlighten us on the topic screening for various gynecological cancers. We welcome you, ma'am.
I welcome Dr. Priya Ganesh ma'am. She is pioneer in oncology, her oncology work, especially colposcopy. I have attended her clinic. I am lucky to attend her clinic. Over to ma'am.
Thank you very much. And at the outset, thank you DHANBAD Society. This is my third visit to DHANBAD, and truly feel that you all are close-knit, and I'm very happy to be with you. So bring greetings from Mumbai, and the topic today for me is screening for different malignancies. I would like to start my deliberation by saying that the progress is impossible without change, and those who can't change their mind can't say anything. That's like from Bernard Shaw. This is very true for screening, because screening has a little backset in our country, and that's why we do have to have a change in our mindset. Cancer rates in India are increasing, and we also know that HPV is contributing to various different types of cancers, right from cervical cancer to even HNL cancers, penile cancer, anal cancer, and so forth, also to vaginal warts. And so when we talk about the HPV-related cancers, the mortality is quite high, and this is from the GLOBOCON 2022, and you'll be surprised to know that every 5 minutes one person is dying due to HPV-related cancers in India. And look at our burden. What are we contributing globally? For cervical cancer, 20.5%, vulvar cancer, you can just read through it, and it's a massive thing that India is contributing to various different cancers globally. So when we talk about cervical cancer, so I've pertinently brought 3 cancers that I'm going to discuss with you all: is cervical, endometrial, and ovarian, and the screening for it. So 1 out of 4 dying due to cervical cancer is an Indian, and we know the risk factors for cervical cancer. And the global strategy for that being 90-70-90, that is 90% by vaccination, 70% by screening, and 90% by treatment of the precancerous and cancerous conditions. Now, if this 90-70-90 is to be applied to our country, we are going to have almost 1 lakh deaths being averted in the next decade and 10 million by next century. But what is the ground status? The ground reality is that we are just 3% where we have to be 70%. We are just 0.1% where we have to be 90%. And again, treatment just 10%. So can you see the ground reality where we are? And we do have lot of gap to be covered. And when we talk about screening modalities, it's always the biggest question mark to our gynecologists. What exactly should I adopt? And WHO has given all the 3 approaches of molecular, cytology, visual inspection. And if you want to have this impact of screening and vaccination put together, we can avert almost 61% of cancer reductions can happen. And so again, that's like without intervention, you're going to have 57 lakh women in India will die due to cervical cancer by 2070. And again, the ground reality is we have a very minimal screening because of lot of barriers. People do not come to us. So screening is pertinently for comparatively asymptomatic women. But who come to us? These are the symptomatic people normally who comes to us, and then we are left out with trying to understand their morphology, the cervix and all that. So when we know about cervical cancers, we know it has got a long phase of precancerous conditions caused because of an HPV, which are low risk and high risk, and the persistent of HPV is the root cause for cervical cancer. So there is a paradigm shift when we're talking about the screening, VIA, PAP, HPV. But when we talk about the limitations in VIA, we know that it is observer specific. I was just talking in the morning to Dr. Komal and Dr. Reena that we can have you all remember we had a colposcopy workshop at DHANBAD, and we can have a VIA workshop, because that's very, very important that people should know what the things are. Now talking about PAP test, many of us are still with PAP, but PAP again has got their own limitations, because again it is an observer specific, and again it has got a false negative rate of about 70%. Now the cases where reported NILM. And again, the biggest cloud hanging on our head is inflammation. So PAM coming up with inflammatory report. What to do with that? Every time it is inflammation. So that is where we talk about molecular test, and we also know that, you know, even in a normal cytology, there is a 5% chance of HPV 16 and 18 being positive, and having even a single round of HPV testing should do wonders. Now, I was lucky enough and was privileged to bring this FOXY GCPR for prevention and management of cervical cancer whilst I was the Onco Committee Chair. And it says that, you know, how do you approach? Now, when should you start screening for cervical cancer? Age to start screening is 25 years in a good resource setting, but you can universally 30 years. And then when you stop at 65 years with 3 consecutive negative cytology or 2 consecutive negative HPV testing. What should you do if there is a hysterectomized patient? If it is done for a benign cause, no need to do screening for the vault and all that. But if it was done for cancer or pre-cancer, definitely it has to continue for long 20 years. So now we have good resource setting. We have a poor resource, a low resource setting. Preferred is HR-HPV. Cytology every 3 years can be acceptable, or BIA 3 to 5 years. And in low resource setting, affordable HPV, fantastic. At least you do twice in lifetime. I'm telling you, it's going to be brilliant. Because they're not going to come back to you, no? It's only once they might come to you. And BIA is acceptable. So now we do have these algorithms. I'm sure this is from FOXY GCPR. You all have it. And primary screening with BIA, with HPV DNA. So this is the new addition. That there's a single visit approach with a single, HPV. If it is positive, you can treat. You don't have to sort of look out for the lesion. That's the change. You treat the transformation zone and don't look for the lesion. It might have a little over treatment. Now, if you do with the cytology, most of the candidates, we are all with cytology. So, negative. Now, if it is positive, ask us to do an HPV. And if it is more than LSIN, you will do a colposcopy. And if you are taking up screen triage and treat, if it is with HPV, which is with a high sensitive test, with a very good negative predictive value, put on those tests which are very specific tests, like, PAP test, your cytology, colposcopy, or a genotype, which has got very good positive predictive value. This is a link for GCPR. Now I come to ovarian cancer. Now ovarian cancer again is increasing in our country, and we know that the challenges are that there is no definitive pre-invasive or precursor lesions, and the symptoms of ovarian cancers are very vague, like abdominal pain or bloating or bowel syndromes, altered. So what are the screening methods? The screening methods are symptom index, pelvic examination, CA-125, and transvaginal sonography. Now GOPS symptom index. So what is sensitivity of 56% and specificity of 79%. Now we all know CA-125. Now this is the only FDA biomarker which is approved for screening purposes. Now more beyond CA-125 is ROCA, where you actually have a sequential CA-125 measurements. You look into the menopause and then the area under the curve. So ROCA is again a very good methodology of screening. Of course, transvaginal sonography is very good. Now we do have guidelines for screening in an average risk of asymptomatic women. So usually for an asymptomatic women, we defer from doing this screening because we don't want to have an over-treatment. But for a high-risk women, where there is a genetic predispositions, definitely you have this genetic testings, and you will do the index case genetic study, and then you will try to understand for the remaining of their pedigree. And the women who have completed the family definitely can go into prophylactic BSO or Lynch syndrome hysterectomy with BSO. Now, what is the evidence for RRSO? That is your risk-reducing salpingo-oophorectomy. Of course, yes, it reduces high-grade, serous ovarian cancers. RRSO is, it's when you compare it for the BRCA mutations, they are very good. Chemo preventions are also there. And then when we talk about tumor markers, there are plenty of tumor markers you can see over here. The role of tumor markers is for diagnosis, for monitoring, for recurrences, and the CA-125 is one test. Now, along with CA-125, because it has got very low sensitivity and specificity, the limitation being it can be positive in endometriosis, PID. There is another marker called as HE4. Now, you have this HE4 along with the CA-125, that is ROMA test. and elevated HER are expressed very early in the early stage of ovarian cancers. It can be used for therapeutic monitoring, recurrence estimations and all that. So now you have this ROMA test. This is a very diagnostic, accurate test. You have a high significance in, rather than using CA-125 alone. So what happens with the ROMA test? Sensitivity and specificity increases. Then you have transvaginal ultrasound with the simple cells, with the complexes, and you have B rules, M rules in an iota classification. So that's again where the sensitivity increases by 95 and specificity by 91. So then you have this RMI index. Now what you look into is US score. Then you have menopausal and CA-125. So when you have this RMI and the cutoff being 200, it again is one of the very important things. Like when a post-menopausal ovarian cyst is there, measure CA-125, do the TVS, calculate RMI, and then you have two flow charts. You have RMI less than 200, RMI more than 200. If it's RMI less than 200 and cyst fulfilling all the criteria of simple cyst, less than 5 centimeter, unilocular, you can just conserve, you can repeat these tests, nothing to be done much. But if you have an RMI more than 200, you will go in for a CT scan, you will have an MDT, and that's how you will review with an MDT team. Now I come to the last cancer, that's an endometrial cancer. Now endometrial cancers are also very high nowadays, it's increasing. Compared to ovarian cancers and all, we are seeing uterine cancers, endometrial cancers increasing because of the late menopause, nulliparity, unopposed estrogen therapies, and the persistent ovulations. So the factors associated with increased risk, premenopausal women, you can see, and postmenopausal women. And nowadays, morbid obesity again is one of the major concern. We are getting so many of our cases with morbid obesity and estrogen secreting tumors and all that. So warning signs is irregular, heavy, postmenopausal bleeding, and here comes the role of ET. Now for the ET value, if we have a cutoff of 5 mm, you can see the sensitivity of 90 and specificity 48. But you have a cutoff of 4 mm, you have 98 and 36 to 16. So definitely we do have this, and American Cancer Society's recommendation is asymptomatic women who have Lynch syndrome or a family history of colon cancer, they should be tested annually with endometrial biopsy beginning from the age of 35. Progesterone to be added to estrogen and hormone replacement therapy, and women who are undergoing surgery for colorectal cancer so do not wish to preserve fertility should go for prophylactic hysterectomy or oophorectomy. Now Lynch syndrome, LS test is also now becoming an important test. And I'm sure you all also must be doing this LS test to understand Lynch. Now, so among the endometrial cancers, Lynch syndrome approximates to 2 to 6%, which are again because of DNA mismatch repair genes. So recommendation for screening for asymptomatic patients, note for endometrial cancer, no risk factor, nothing to do. You can just do a transvaginal ultrasound if there is a risk factor of estrogen excess. Tamoxifen usages, of course, do an annual solo histogram. Genetic risk factors, annual endometrial biopsy. And abnormal physical examination, TB. Symptomatic patients, you can do an office endometrial biopsy and transvaginal ultrasound. DNC if the other things are not feasible. So, dear friends, I come to the end of my talk. I'm doing it a little fast because I know what a pressure it is on organizers if it is running late. So, so we are from the empirical, from dead end, we are having an alternative ending. Promote screening for your women, for your patients, and for yourself also. I do want to ask only one question from my people over here, beautiful people in red. How many of you all have gone for screening? Your own screening. Forget patients. Cervical, breast, only 2 I'm asking. Yeah, see? So that's I'm seeing only 2 hands being raised. So dear friends, please take this up seriously. We aren't immune, we aren't steel body. We are also humans, and we don't want our beautiful ladies to, pass away with cancers. So this is my, we have been doing a lot of training programs. With this training program, around 2,500 doctors have been trained so far. In our training program, we also cover up other cancers also. It's not only colposcopy and cervical because that's a need of the hour. So I leave you all with a wonderful ray of hope that once we do the screening properly and we treat it in the better positive way, definitely we will not be losing our ladies to cancers. Thank you very much.
Thank you so much, ma'am, for that presentation. We now move to our next presentation, and I would like to call on our esteemed speaker, Dr. Monica Meena ma'am, and she will enlighten us on the role of robotic surgery in gynae and oncology. Welcome.
A very good afternoon to all the chairpersons, esteemed guests. And now, since it's nearing the culmination of the academic program, I understand we need to rush because of the paucity of the time. So at the outset, I would like to thank DHANBAD OBSTETRICS Society for giving me this platform to speak upon the topic, which is the evolving landscape for the women's care. Over the past decades, we have seen the evolution of the surgery from the open conventional surgery to the minimally invasive surgery in the form of keyhole or the laparoscopic surgery to the robotic platform, which is the state-of-art technology nowadays, which actually helps the surgeon when we talk about the gynecological cancers and even the precise benign condition where we have to preserve the fertility in the cases of fibroids or the endometriosis. Robotic platform adds to the surgical expertise when it comes to the survival of the patient and to provide the best of the surgical outcomes. So, the robotic surgery, since the presentation is uploading, I would just want to talk about the evolution of the surgery has been, we all have learned from the open conventional method of the surgery. We have learned the anatomy, landmarks and everything from the open approach in our residency days, with the evolution to the minimally invasive surgeries in the late 90s, where the benign surgery in particular have been done by the minimally access surgery. And in 2010, the first robotic surgery, Da Vinci, was done in All India Institute of Medical Sciences by Dr. Dogra, the urologist. He did the anterior pelvic exentration, which involved hysterectomy as well as the bladder removal for the cancer. And after that, there was no looking back. The people, even the patients are coming and they have been asking for the best of the surgical methods, even for the benign condition. And now the case is that we are actually being asked by the patient to get the robotic surgery even for the benign conditions. So what we have so finally it opened. So the robotic surgery, as is the myth, is the people think, the common masses think that is the surgery being performed by the robot, but it is rightly so called, should be called as robotic assisted surgery, because like the car is being driven by the driver, the surgeon, the specifically trained surgeon, is the one who has the onus of doing the surgery, and he actually makes the robot perform the surgery. The movements he is doing on the surgical console are exactly being replicated on the patient's abdomen with the help of the robotic instruments. So these are the components of the Da Vinci exercise system, which includes the patient cart on the extreme right. This is the patient cart where the robot is docked on the patient's abdomen and instruments are entered inside. The middle one is the vision cart, which provides the connection of the monitor and all the settings with the cautery settings. And this is the most important, the surgeon console, where we surgeons are seated comfortably performing the surgeries for n number of hours, even it be the complicated surgery without even getting tired. So once we talk about the robotic surgery, what it makes it so special when we compare it to the open or the laparoscopic surgery. Yes, there is difference between the laparoscopic and the robotic surgery also. If I may give the analogy, like if you are offered to eat a paratha with the help of your hands versus have a paratha with chopstick, what would you prefer? I'm sure you'll prefer eating it with your hands. So similarly is the case, like if you are doing the surgery with the help of the chopstick in the laparoscopic surgery versus the robotic surgery, which gives us the access of actually doing the open surgery without actually putting my hands inside the abdomen. Only the small incisions and through which the instruments behave like the my hands. So what is the special feature which makes Da Vinci or the robotic system special is the human eye vision, which is the best camera possible with the 3-dimensional stereotactic vision and 10 to 15 times magnification with the binocular vision, which is not there in laparoscopic surgery. The ergonomics of the instruments provide 7 degrees of freedom versus 4 degrees of freedom in the laparoscopy. The filtrations of the tremor and scaling down of the movements is also seen. So if you see the comparison in this tabular form, the robotic surgery definitely have an upper hand in terms of the incision, which is comparable with the laparoscopy, though smaller, it's less than 5 to 8 millimeters. The pain is less because of the less fulcrum effect over the abdominal wall through the entry. The blood loss is minimal, the scars are tiny of course, and the post-operative recovery is the most important point, which is less than 24 hours. Usually for the benign condition, we allow our patients to mobilize and allow them orally within after 6 hours of the surgery, and we discharge the patient the same day for the benign conditions also. So the picture speaks it for all. Now talking about the indications of robotic, the robotic was introduced initially for the pelvic surgery, more so to work in the narrow pelvic spaces, especially in the urological or the gynecological cancer. Then the role of robotics has evolved in other specialties also. So the main focus of the robotics in gynae malignancy includes the uterine cancer or the cervical cancer, the early stage, which we can perform the radical hysterectomies with pelvic paraortic lymphadenectomy with the best of the precision. The ovarian cancer, though it has a limited usage, but early cancers which are localized and early cancers smaller the size of the ovarian masses, or the stage 3C ovarian cancers post neoadjuvant chemotherapy for interval cytoreductive surgeries, there have been an evidence to prove that the robotic surgery offers the maximum advantage. And of course the vulval cancers, which are less spoken about but very important, for doing the inguinal lymphadenectomy, which is a very special topic close to my heart, because our team was the first to depict the first robotic whale, that is the video endoscopic inguinal lymphadenectomy by lateral approach in the world. And we have been presenting these videos in various conferences. So in the cervical cancer, as I told, the radical hysterectomy and the nerve sparing part of the hypogastric nerve is what makes the difference here. And various meta-analysis have proved, I will not go into the details because of the paucity of the time. This is a video showing the pelvic lymphadenectomy of the right side. You can see beautifully how the magnified view of the pelvic vessels, I mean the external iliac artery and the vein, which is coming into the picture. So this is the vein. This is the artery and this is the vein which is coming into the picture, and it is, the vision is so magnified, we can go layer by layer to dissect out the fibrofatty tissue and the lymph nodal packets, and it is actually possible to get in between the vein and the artery to clear the complete lymph node clearance with the visualization of the obturator nerve and obturator vessels. So had there been some resident, I would have loved to ask them the boundaries of the pelvic lymph node dissection, but due to the paucity of time, I think I should rush again. Again, this is a very interesting video showing the anatomical delineation of the uterine artery. So we were doing the radical hysterectomy, and you can very well see here the delineation of the internal iliac, the division of the internal iliac artery, and here if you can make out the tortuous course which is being dissected out, this is the uterine artery which is arising from the anterior division. And in subsequent, I mean, you can see the ureter here, the water under the bridge, the typical. So this is where we clamp the uterine artery in the radical hysterectomies in CA cervix or CA endometrium. Again, in the endometrial cancer, the same application is there, but the additional advantage is performing the sentinel lymph node biopsy, which can be done with the incooperative IC
represents the fourth leading cause of the female cancer mortality worldwide, and it accounts for 4.3% of all female cancer deaths. Ovarian cancer is the third most common gynecological cancer after breast and cervix, and 75% of cases are of the adnexal mass having malignant is high. So in ultrasound, if there is a unilocular mass, there is no septa, the chance of malignancy is 0.6%. If it is multilocular mass, the chances of malignancy is increased to 10%. But if there is any solid mass in the adnexal mass in ultrasound, the chances of malignancy is 35 to 40%. So this chart represents the area under curve. If area under curve is shown, largest in tumor with the diameter of 7 to 11 centimeter. But it is small. But the area under curve is significantly smaller in very small tumors and smallest in the very large tumors, more than 15 to 20 centimeters. That means if the tumor is very large, the chances of malignancy is less. If the tumor is very small, adnexal mass is very small, the chances of malignancy is less. But it is in the size of 7 to 10 centimeters, the chances of malignancy is very high. Now the CT scan. This is the staging workhorse. It is mostly used in the pre-operative evaluation of the disease extent and mapping of the peritoneal spread. So the strength is it evaluates the nodal, peritoneal and distant metastasis along with the pleural effusion, liver parenchymal disease. It can also identify sites that may preclude the optimal debulking, but it has limitation that it cannot detect a small peritoneal implant that is less than 1 centimeter size. So the MRI, this is the problem solver. It has the primary role of characterizing the complex or indeterminate adnexal masses after initial ultrasound. So in diffusion weighted images, it is essential for differentiating benign from malignant solid tumors. It is also used for local staging, that is evaluating the invasion of bladder, rectum or pelvic side walls. As we compare CT versus MRI, CT is the first choice for global staging and the follow-up, but the MRI is a problem solving for the indeterminate masses. In anatomical scope, CT scan is the excellent choice for CT, chest and nodes, but MRI is best for pelvic details and soft tissue. As I told earlier, peritoneal spread is CT scan is limited for less than 1 centimeter implants. And while for smaller tumors, we can the MRI has high accuracy with functional sequencing. So next comes the role of serum biomarkers. So CA125, it is mostly raised in the epithelial serous carcinoma. It is the most common. Next is the HE4. It is also raised in the epithelial cancers. Next is the AFP and beta ACT, which is more commonly used in the germ cell tumors. LDH is also used in germ cell tumors, and inhibin B, it is in the granulosa cell tumors. So CA125 is not it has itself pitfalls, like CA125 cannot be detected in the 10 to 20% of patients. It may be high, it may be elevated in non-malignant cases like endometriosis, tuberculosis. It is also associated with serious cancer, but not to the other histological subtypes. And also in the figure stage 1, only in 50% of cases the CA125 is raised. Now next comes the HE4. HE4 has a full sensitivity of 78% and specificity of 86% for the detection of the borderline malignant ovarian tumors. And also it is not influenced by the pregnancy or the menstrual cycle, and it is rarely increases in patients with endometriosis or other ovarian masses. So role of scores. Next comes the risk of ovarian malignancy algorithm, ROMA score. It is calculated, and if in the premenopausal woman it is more than 1.31, it has the high chances of the malignancy, and in postmenopausal women if it is more than 2.7, it has high chances of malignancy. So the issue of in conclusion, all adnexal masses should be assessed by the expert serologist and the clinician. The correlation between the ultrasound features and the other clinical variables like the age, serum markers, family and personal history should be performed, and suspicious adnexal masses should be considered as ovarian carcinoma, and patients should be sent to gynecological oncology units. Now to differentiate between the primary and secondary ovarian cancer, how to differentiate? So up to 30% of ovarian cancer are malignant, metastatic, which mostly come from colon, appendix, breast and gastric. So if the ovarian tumor is solid, it mostly comes from lymphoma or tumors from the stomach, breast or uterus. But if it is solid and cystic, it mostly comes from the colon, rectum and biliary tract. So our tumor markers are really useful in cases of metastatic ovarian cancer. So in cases of breast cancer, CA 15.3 in one paper has been shown p-value of less than 0.002. So it can be used, but further studies is required for this case. And similarly, the ratio of CA 125 to CEA, if it is more than 25, it signifies the primary breast cancer, primary ovarian cancer. So the decision, the treatment should be preoperatively planned at the multidisciplinary team meeting after workup aimed at ruling the unresectable metastasis, secondary ovarian and peritoneal metastasis from the other primary malignancies with the family history, symptoms, radiological features, or CA125 to CA ratio. Now the staging of ovarian cancer, like surgical staging. So how the surgical management of the stage 1 and 2 ovarian cancer. The first, the midline laparotomy should be done, and apparent stage could be managed. Stage 1 could be managed laparoscopically, but laparoscopically rupture of the tumor should be avoided because it will increase the stage from 1A or 1B to 1C. So fertility preserving surgery, unirectal salpingophorectomy should be directed to selected menopausal patients requiring desiring the fertility. Peritoneal washing or cytology should be done, and peritoneal biopsies are recommended. And at least infracolic omentectomy is recommended. Bilateral pelvic and para-aortic lymph node dissection should be done. So there are some pitfalls like role of lymphadenectomy or role of minimally invasive surgery. So as we can see this paper, this is a meta-analysis of more than 10,000 patients. Almost 50% of women with early stage breast cancer were not adequately staged. It has shown if a hospital has high volume center or a surgeon with high volume surgery doing surgery, the lymph node dissection rate and the omentectomy or debulking rate is high. So there are few steps which are easily omitted during early ovarian cancer patients, like the procedure which are difficult or associated with increased morbidity, like sampling of the para-aortic lymph nodes, a biopsy of the right diaphragm, pelvic lymph node sampling, or the intracoelentectomy omentectomy. These are really very difficult procedure and easily missed. But the easy procedures which should not be missed, like biopsy of the all paracolligators, biopsies of the side wall, and peritoneal washing. So occult metastasis in upstage patient. Apparently in early ovarian cancer, if we do cytology, it will upstage in up to 25 to 35% of cases. And if we do lymph node dissection, it may increase up to 40% of cases. So this is the LION trial, which shows in early ovarian cancer in stage 1, if we do lymph node dissection or if we don't do lymph node dissection, the progression-free survival and the overall survival, there is no difference. So the second pitfall, the role of minimally invasive surgery. This review found there is no good quality evidence to help quantify the risk and benefit of laparoscopy for the management of early ovarian cancer as a routine clinical practice. So next comes the staging of evaluation of the extension of the disease. This comes right in the treatment of the ovarian cancer. The treatment debulking procedure, residual tumor or the complete cytoreductive surgery at the primary debulking surgery is the one of the most important prognostic factor in advanced epithelial ovarian cancer. Currently, it is considered as the surrogate for survival. So if it is a figure stage 2B to 3B, upfront debulking can be possible, it should be proceeded. But in figure stage 3C or 4, if patient is fit for extended radical surgery, then we can proceed for extended surgery. And but we have to we have to assess the risk-benefit analysis. If the patient is not physically fit, then we should not do the surgery and we should send the patient for neoadjuvant chemotherapy. Why? I'll tell you later on. So the first, the optimal cytoreduction is the most important prognostic factor. If we in the primary debulking surgery, if we don't leave any visible disease, the progression-free survival and overall survival is more than 100 months in the figure stage 2B to 3B. While if we leave the disease less than 2 cm, less than 1 cm or up to 1 cm, the progression-free survival or overall survival has greatly decreased to 50 months. That is more than half of the life of the patient has decreased. So this is again the LION trial, lymph node sampling and the systemic pelvic and para-aortic lymph node dissection. In early cases, as I said earlier, the 5-year progression-free survival is 73.4% versus 78.3%. There is no difference in progression-free survival. Similarly, 5-year overall survival is also 81.6 months versus 84%. No difference. So this is a LION trial, prospective randomized trial. It includes the newly diagnosed epithelial ovarian cancers, figure 2B to 4, macroscopic complete resection, pre and intraoperatively clinically lymph node negative. They are randomized intraoperatively to lymph node dissection versus no lymph node dissection. And the primary endpoint was the overall survival. They continue neoadjuvant chemotherapy, while in primary debulking surgery only 41%. Overall survival and progression-free survival has no difference. But the post-operative death is significantly reduced from 2.5% to 0.7%. Grade 3-4 hemorrhage has been significantly reduced from 7.4% to 4.1%. And also the rate of infection is decreased from 8 to 1.7%. So, just this point. What is HIPEC? This is the hyperthermic intraperitoneal chemotherapy. It is the administration of chemotherapy at the optimal temperature between 42 to 43 degrees Celsius. The synergy between heat and drug toxicity starts at 39 degrees Celsius and falls off at the 43 degrees Celsius. Temperature above 44 degrees Celsius causes the apoptosis in the normal cells. So we use cisplatin, and this GOG 172 study shows there is a reduction in death of more than reduction in death or more survival, overall survival more than 12 months with this HIPEC surgery. So why hyperthermic? This leads to destruction of cancer cells. This leads to augmentation of the cytotoxicity and increased penetration. So this is the open technique in which we do cytoreductive surgery, and then we introduce the two cannulas for insertion of the chemotherapy and to the outside for drainage. This is the open technique, and second one the closed technique. So evidence where the HIPEC has been benefited. So IDS after upfront incomplete CRS for stage 3 epithelial ovarian cancer, salvage CRS for recurrent epithelial ovarian cancer, advanced stage 3 requiring IDS after NSAT. But this has the mortality rate of between 0 to 18% and morbidity of 30 to 70%, and it should be restricted to high volume institution as per protocol basis. So thank you.
Thank you, sir, for your wonderful talk. I would now request President Ma'am and Secretary Dr. Reena, please come up on the stage for the felicitation. Sir, please be on the stage. I would request the respected chairpersons to please join in. I request the respected chairpersons to please be on stage and for the felicitation. you all for the wonderful session. We move on to the next session.
Good evening everyone. We shall start our next session. I would like to call our respected chairperson, Dr. Soma, Dr. Manisha Mishra ma'am, Dr. Nikita Sinha ma'am, and Dr. Alka Singh ma'am. Ma'am, please come on stage. Now I'd like to call Dr. Priyanka Aswal, Consultant Hemato-Oncologist at Sulphuric Cancer Institute, Dhanbad.
Good evening everyone. We are running short of time, will be fast for the session. So thrombocytopenia, at the outset first I would like to thank Dr. Reena ma'am and the whole DHANBAD Society of Obstetricians for giving us the opportunity for this interactive session between hematologists and our physicians. So let us start. So what is this thrombocytopenia being the second most common hematological disorder in pregnancy which we encounter. So we'll be discussing the topic under the following headings like etiology, what is ITP and TMAs in pregnancy. We all know that thrombocytopenia occurs in 10% of the pregnancy and by definition it is platelet count of less than 1.5 lakh. So thrombocytopenia, we know it's most of the time it is an incidental finding also. So considering the pregnancy specific and non-pregnancy specific causes of thrombocytopenia, if we divide them by trimester wise, so in first trimester if we are encountering thrombocytopenia, the common causes is ITP and hereditary thrombocytopenias and TMAs. In second trimester it is most commonly gestational thrombocytopenia and preeclampsia and HELP, and in third trimester mostly again it comes HELP and gestational thrombocytopenia. Whenever we see a patient of thrombocytopenia, how should be our approach? Our approach should be like first do a peripheral blood smear examination to see whether it is a true thrombocytopenia or an artificial thrombocytopenia. Along with thrombocytopenia, just see whether we are having any other abnormalities in other lineages like lymphocytosis, or if there is any microspherocytes, histiocytes or blast are there. So all these things should be considered while evaluating a thrombocytopenia with a proper approach. So the investigations we have just seen, CBC peripheral smear, thyroid function test, DAT test, APLA, ALE profile, H. pylori test, all viral serologies and autoimmune disorders, they should be ruled out before labeling the patient as thrombocytopenia. Now coming to one scenario, if you are encountering a 29-year-old female in her third trimester with a platelet count of 88,000 with no active bleeding. So what we think in this scenario is this could be. Any suggestions? I will only tell. This is most likely a gestational thrombocytopenia towards the cause definitely. If sepsis, then using higher antibiotics and other therapies for malignancies or retained fetus that can also be used. So APLA is also very important secondary cause of ITP in pregnancy. So its frequency ranges from 20 to 50%. We all know if APLA in pregnancy if diagnosed, we use aspirin and LMWH both. If the patient is having a previous history of thrombosis, both should be used, and only APLA with minimal 1 or 2 antibody positive we can use, only aspirin also. So these are some rare causes of thrombocytopenia which can be present, but this should be kept in mind, especially drug-induced thrombocytopenia, some nutritional deficiencies which are also associated with thrombocytopenia, infections associated with thrombocytopenias. So my take-home message will be the gestational thrombocytopenia is the most common cause of thrombocytopenia, and ITP should be considered in first trimester with low platelet count, and steroids and IVIG combination should be started as early as possible. And
TTP and complement-mediated angios, these are life-threatening emergencies. Only gynecologist can pick up this first and refer the patient to hematologist later. This should be picked up very early because they are very life-threatening. So I conclude my talk. Thank you very much.
Everyone, esteemed doctors present here, all stalwart of the DHANBAD OBSTETRICS Society. As a doctor, we are not only obstetrician, we have to deal as a physician, sometimes dermatologist also. So we will give some time to revise skin disorders in pregnancy. Pregnancy is a physiological condition. It is categorized by altered endocrine, metabolic and immunological milieux. This dramatic alteration results in multiple cutaneous changes, both physiologic and pathologic. There are different types of dermatosis in pregnancy. Physiologic changes associated with pregnancy, pre-existing dermatosis affected by pregnancy, dermatosis specific to pregnancy. The physiological changes which happen during pregnancy are due to increased melanocyte stimulating hormones, estrogen, progesterone, which leads to pigmentary changes, vascular changes, structural changes, hair, nail, like that. The pigmentary changes are melasma, hyperpigmentation around areolae, linea nigra abdomen, darkening of nevi. Vascular changes generally spider angiomas, palmar erythema, varicosities, non-pitting edema, pyogenic granulomas. The structural changes most common is stria gravidarum. Hair changes are most of our patients are worried because during pregnancy there is hypertrichosis, which is due to prolongation of growing time of hairs, and after having delivery the patient has hair loss because of elongation, because of transition to telogen phase. There is androgenetic alopecia also due to alteration of hormones. The nail changes are onycholysis, brittleness, subungual hyperkeratosis, transverse grooving, which we generally observe. Some diseases are potentially worsened during pregnancy. Some infections like Candida vaginitis, Condyloma echominata, human papilloma viruses, herpes simplex infection, leprosy, trichomoniasis, varicella. Some immune-mediated diseases also get worsened, SLE, dermatomyositis, polymyositis, some metabolic diseases also. Dermatosis specific to pregnancy are well-defined dermatosis associated with pregnancy, pemphigoid gestationalis, pruritus urticarial papule and plaques of pregnancy, recurrent cholestasis of pregnancy, which is prurigo gravidarum, impetigo herpetiformis. Incompletely defined eruptions associated with pregnancy are prurigo gestationalis, pruritic folliculitis of pregnancy, which are collectively called as atopic dermatitis of pregnancy. Generally, we call them eczema, and miscellaneous disorders. Pemphigoid gestationalis is also called herpes gestationalis. These are usually identified by the lesions around umbilical. The incidence is 1 in 50,000 pregnancies. Usually begins with urticarial papules and plaques around the umbilicus and extremities. They are sometimes bullous lesions as the disease progresses. Lesions of pemphigoid gestationalis tend to spare the face, palm, and soles. Mucosal surface are fewer than 20%. I think that we should skip this. The laboratory findings we will see in histopathology. We'll skip. The treatment is oral corticosteroid, 20 to 60 milligram per day of prednisolone. Severe cases require treatment with rituximab, cyclophosphamide, IV immunoglobulin, cyclosporin in refractory cases. One more is pruritic urticarial papule and plaques of pregnancy, where umbilicus is usually spared. It is a very itchy erythematous papule that coalesces into plaques, classically found on the abdomen, sparing the umbilical areas, and are found primarily in abdominal stria. These usually appear in late in third trimester, which resolve with delivery. There are rarely any recurrence. Fetus and mother are not affected by these eruptions. So we generally don't do any treatment, only cold compress, antihistaminics like this. Intrahepatic cholestasis of pregnancy is we expose day to day. Its onset after 30th week in 80% of patients. There is steatorrhea often noted by the patient, followed by vitamin K deficiency. It usually resolves after delivery, but it recurs with subsequent pregnancies also. There is increased fetal complication. ICP is a disease of late pregnancy corresponding to the period of highest placental hormone level. ICP spontaneously remits at delivery when hormone concentration normalizes. Twin and triplet pregnancy categorized by greater rise in hormone concentration. The gold standard for this is serum bile acid level, more than 11 micromole per liter. Recent study also says that increased urine bile acid level is also specific for ICP. 55 to 60% cases only show increase in SGPT and SGOT levels. The treatment, as we know, we have to decrease the serum bile acid level. We should use ursodeoxycholic acid. The dose is 15 milligram per kg per day, or 1 gram per day till delivery. Antihistaminics, close obstetric surveillance, and weekly fetal CTG registration at least from 35 weeks of gestation. We should consult dermatologist, hepatologist, pediatrician in severe cases also. One is pruritic folliculitis of pregnancy. It is very itchy. It presents as papules and pustules concentrated around hair follicles. Often lesions begin on the abdomen and spread to the extremities. Its onset of most often in third trimester resolves after 2 to 3 weeks of pregnancy. Papular dermatitis of pregnancy, pruritic generalized eruptions of pruritic eruptions of 3 to 5 mm erythematous papule surrounded by a small firm central crust may erupt any time during pregnancy and resolve after pregnancy. Recurrence in Impetigo hypertrichosis or pustular psoriasis of pregnancy is also very itchy and is a form of pustular psoriasis that occurs during pregnancy and may be life-threatening also. Many of the affected women have had no personal or family history of psoriasis. Recurrence in subsequent pregnancy is reported, and there is increases of fetal morbidity, mortality associated with placental insufficiency with risk of stillborn. The disease tends to remit promptly after delivery. In laboratory findings, there is leukocytosis, neutrophilia, elevated ESR, hypoferric anemia, hypoalbuminemia, calcium, phosphate, vitamin D levels are decreased. Treatment is systemic corticosteroid, sometimes cyclosporin, sometimes IV immunoglobulins also. We have to replenish calcium fluid electrolyte for if decreases. There is prurigo gestationalis also. Systemic treatment is topical corticosteroid, antihistaminics. In severe cases, we have to use systemic corticosteroid and antihistaminics, sometimes phototherapy. Other miscellaneous disorder are there. These are my references. Thank you very much. I invite you all in 11th AOGSBJ conference, which will be in Devghar, 18, 19, 20 September 2026. Please come there and grace and bless us also. Thank you so much.
I would like to call Dr. Komal Singh ma'am, Dr. Reena ma'am to felicitate Dr. Neha Priya ma'am, please. Without wasting our time, I would like to call Dr. Kavita Priya ma'am. Consultant at Rastriya DHANBAD. Please ma'am.
Good evening. At the outset, I would like to thank Dr. Komal and Dr. Reena for giving me an opportunity to speak today. With the permission of the respected chairpersons, I'd like to begin. My topic today is pregnancy test, reading between the lines. It sounds a very prosaic topic, but I'm very passionately interested in it, and I'm hoping to convey that interest to you. Shift conversation. So obviously the two lines, and I found that there's a lot of interest in how to interpret this pregnancy test reading. So we know that the pregnancy test becomes positive due to the HCG level, human chorionic gonadotrophin, which is produced in the placenta. and how problematic it is when we think that the EDD is around ultrasound, it is 16.6. We do not want to fall into the pitfall section in previous. So we fast track to the first antenatal visit and check when the first positive UPT was documented. And so we find that it was faint positive on the 10th of September, strong positive on the 15th of September. So that means if by 10th September she was around 4 weeks, definitely by 15th she would be 4 weeks for sure. And that means that her EDD cannot be later than May 28 and is likely before May 28. So this gives me a sort of timeline. So her LMP by August 5th, EDD May 12th is probably correct. Definitely we cannot defer the EDD to June 12th. So this helps in my treatment. So another example of how it helps to set the timeline, in a lot of early pregnancy patients, when we suspect that something may be wrong, or even in the very first visit when the patient comes to us, and we send her, suppose we send her for an ultrasound, often we get a finding, and when you feel that the patient is just a little suspicious, she just has amenorrhea, but she doesn't have many findings typical of early pregnancy, so then you might send the first ultrasound a little early. So then, again I'm giving you an example of an antenatal patient with an LMP of March 13th, which makes her gestational age 7 weeks 3 days on May 2. Now definitely any ultrasound, both TBS and transabdominal, should document a heart rate here. But the UPT was found to be slightly faint positive on April 16th. So you have thought of, so you kind of made a rat that things may be wrong. And plus she has spotting from May 12th. Now the USG report that comes says that there is a mildly irregular gestational sac, so such and such corresponds to 5 weeks 1 day. And the yolk sac and fetal pole are yet to be appreciated, and could it be an intrauterine early pregnancy? Now if you think it's an intrauterine early pregnancy, you have to wait, repeat the ultrasound and rule out for sure that since it's a wanted pregnancy, you have to rule out for sure that it's not an early pregnancy, because you can't suggest termination straight off. But if you backtrack to the first UPT and you find that, see that it was faint positive on April 16th, so at least 4 weeks on April 16th, likely more, at least 7 weeks on May 8th, if not more, so then she cannot be that misproportion. She cannot be an early pregnancy, and she's a case of misproportion, and you do not have to continue the pregnancy. So this helps a lot in our clinical practice, and I would say that just as we are religious about writing the LMP and the EDD at the first and every subsequent antenatal also we observe that, we should be religious in documenting the first positive pregnancy test. It can be of immense value to some other obstetricians who suppose end up taking that case, and to ourselves when we go in for further treatment. So now, why does it have 2 lines? Now we are reading between those lines. Why 2 lines? 2 lines, one is the control line. Now control line is something I've always found very interesting. What does the control line actually tell us? What is it actually? It contains antibodies, but these do not bind to HCG. They bind to other components in the urine or reagents regardless of HCG presence. So why have a control line? This is a proof that your test is absorbing the urine properly. So it is a quality check. So that's why it's important. If there is no control line visible, it means that the test has failed. That means either the urine was insufficient, the test was expired, there was a manufacturing defect. If only control line visible, not pregnant. Both lines visible, yes, pregnant. Faint control line, usually still valid, but may indicate low fluid absorption or near expiry. Now, we are coming to the faint positive pregnancy test. First of all, how to interpret the following faint positive pregnancy test result. Now, it is
pathobiology of chronic pelvic pain. Chronic pelvic pain has three overlapping mechanisms that drive the transition from acute nociception to chronic centralized pain. It has peripheral sensitization, central sensitization, and cross-organ sensitization. Multiple overlapping pain pathways are common and expected in CPP. Treating a single organ rarely resolves the whole clinical picture. Clinical evaluation. Clinical evaluation is not acceptable to view them through a narrow lens. We have to see where is the site of pain, what is the onset, when did it start, sudden or gradual, what is the character, whether it is sharp or dull, whether pain radiates to anywhere, and association of the pain, any other symptoms along with pain, time course, exacerbating or relieving factors, and severity. Pain history is also very important. We have routine information as described earlier, medical or surgical history, social history, sexual history, and pain focused intake from or validated pain questionnaire. Pain score. Pain score is very important as acute lesions tend to cause more severe pain than chronic lesion. Inflammatory lesions causes more severe pain than any other lesion. To understand the characteristics of pain, its duration, frequency, intensity, location, and when it commences, and quality of the pain, if the pain is cyclic, continuous, or throbbing. A change in the pain score can also be used to follow up and understand the progression of the pain. Many patients and physicians think that CPP results mostly from gynecological causes, but studies have shown that gastrointestinal and urinary cases commonly contribute. We can see that about 37% of the cases it is the GI causes, about 31% it is urinary, 20% of the cases it is reproductive, and another 12% it is musculoskeletal. About 40% of laparoscopies and 12% of hysterectomies in USA annually, even though it is not, the chronic pelvic pain is not the origin. There is an acronym, Are You Moving Song, to define the causes of the pelvic pain. Are you moving? That is the organ system. R stands for reproductive, U for urinary, M for musculoskeletal, O for other, V for vulvovaginal, V for vascular, I for idiopathic, N for neurogenic, G for gastrointestinal, and SOM for systemic modifiers like S sensitization, O overlapping pain conditions, and ME for mental health. Red flags. When to suspect serious pathology? We all know in cases of postmenopausal bleeding, unexplained weight loss, hematuria or GI bleeding, pelvic mass on examination, fever or new onset severe pain, known malignancy or risk factor. What are the investigation? No doubt USG is the first line imaging, then MRI can be used in selected cases like deep endometriosis, STI testing when infection is suspected, and laparoscopy. Laparoscopy should not be used reflexively, reserved for the cases where surgical finding will be meaningfully alter the management. What are the differential diagnoses of CPP? It may be gynecological causes as endometriosis, adenomyosis, and so on. Musculoskeletal causes, pelvic floor myalgia, myofascial pain, and pudendal neuralgia. Urological causes like interstitial cystitis, bladder pain syndrome. Neuropathic or centralized causes like fibromyalgia overlap and nociplastic pain. Gastrointestinal causes, it includes irritable bowel syndrome, functional bowel disorders. See the overlapping of the chronic pelvic pain. And what is the management of the chronic pelvic pain? It is pharmacological, pelvic floor therapy, psychological causes and lifestyle modification.
conservative and medical management, we can use OCP, dinogestrone, medroxyprogesterone, GnRH agonist, and newly available drug elagolix. Role of the pain management. Pain management is very important in chronic pelvic pain to diagnose neuromodulation, medication optimization and interventional therapy. Role of gynecologist. When the cause of the pain in pelvis, we have a role. Role of physiotherapist. When the musculoskeletal contributes to the pain, then physiotherapist has a well-defined role. It supports self-management with tailored rehabilitation strategies. Role of psychologist and sex therapist. Surgery in chronic pelvic pain. When surgery may help clear structural pathology is confirmed, advanced or deep infiltrating endometriosis, discrete ovarian or adnexal pathology. When surgery is insufficient, in cases of centralized pain, surgery has no role. Repeated procedure may increase adhesions. Surgery can reinforce maladaptive pain behavior. Pain severity does not really correlate with lesion burden. Surgery is appropriate when anatomical findings directly account for the pain phenotype. Take-home messages. Chronic pelvic pain is multifocal. We have to look beyond the uterus and ovaries, consider endometriosis, pelvic floor dysfunction, bladder, bowel and neuropathic causes. Listen, validate and document. Early empathetic listening improves patient trust and treatment adherence. Don't overlook pelvic floor myalgia. Examine and refer early to physiotherapy. Hypertonicity is common and treatable. Coordinated multidisciplinary care. Collaboration with pain specialists, physiotherapists, urologists and psychologists for optimal outcomes. Address sexual dysfunction openly. Include partner if possible. Dyspareunia is common but manageable with holistic care. Empower with education. Discuss chronic pain mechanism, treatment expectation and lifestyle changes. Thank you so much.
I would like to call Dr. Kavita Priya ma'am. Please come on the stage. I request to our respected chairperson, Dr. Nikita Sinha ma'am and Dr. Manisha ma'am to felicitate Dr. Kavita Priya ma'am, please. I request to Dr. Alka ma'am, Dr. Soma ma'am to felicitate Dr. Sadhna ma'am. I request to call Dr. Komal Singh ma'am, Dr. Reena Barma ma'am, Dr. Neha Vilasnu ma'am, Dr. Neetu Sahai ma'am, Dr. Renu Patha ma'am, please come on the stage. Please ma'am.
Hello, may I request Abharani Cinema, please ma'am, if you are here.
Yes ma'am, please come on the stage.
so much, everyone. Kindly be seated for the valedictory, please.
Good evening, everyone. Thank you for all for bearing with me till so long and being with me, supporting me. So first of all, I would like to announce the prizes for the free paper presentation. First prize goes to Dr. Vidisha Kedia. Second prize goes to Dr. Vishwabharti. And third, it goes to Dr. Archana Kumari. So starting with the valedictory, on behalf of the DHANBAD Society of Obstetrics and Gynecology and the organizing committee of 6 DSOGCON, I express our sincere gratitude to all the distinguished speakers, delegates, and respected faculty members, guest speakers, chairpersons, and participants for their valuable presence and active participation in this conference. First of all, I would like to thank my patrons, Dr. S.P. Das, and my convener, Dr. Pratibha Rai ma'am, for their constant blessings and support with me. Ma'am, I would like you to come on the stage if the ma'am is there. Sir is there. Dr. Das sir is not there. Okay. I would like to thank our treasurer, Dr. Nupur Chandan ma'am, for always being there in supporting my decisions. Nupur ma'am, where are you? Ma'am, Nupur ma'am is here. Please, valedictory wala wo leke aayiye na. Aayiye ma'am. Kavita ma'am, I request you, Dr. Neetu Sahai, Dr. Neha Pradeshi, to please come on the stage to start felicitating them. I request Kavita ma'am to felicitate Dr. Nupur ma'am for being an excellent treasurer, and she has been, I think, since the time I know, she has been the treasurer of the DHANBAD Society of Obstetrics and Gynae, and she has been managing it very well. Next, I would like Dr. Komal ma'am to felicitate Dr. Kavita Priya ma'am. She's an excellent, she's our scientific committee chairperson, and she has been extremely resourceful and supporting and guiding me throughout the organization of the scientific sessions. And of course, Neha Priyadarshini was also there with me. Dr. Neha Priyadarshini, Komal ma'am, and Kavita Priya ma'am, and me. We were the 4 people coordinating with the scientific sessions. It was excellent. And then I would like to call upon my scientific committee, Dr. Renu Pathya ma'am, Dr. Alka Singh, Dr. Neha Priyadarshini, Apurva Gupta. They have also been always supportive and guiding me through what topics should be covered and in the sessions. Then, Renu ma'am, where are you? I've seen you, ma'am. Ma'am, please aayega. Aayega ma'am, please. No, ma'am. Dr. Alka is also there. I've seen her. Dr. Alka, Dr. Neha Priyadarshini, Apurva is not there. Please come. I request, because I know the time is not permitting, so I'm not going to the stage, and I'm requesting my colleagues to felicitate them. Then I request my workshop committee, Dr. Rajlakshmi Tubit, Dr. Arpita Das, Dr. Isha Rani, Dr. Shreya Karan, and on my stage, especially Isha, I want to thanks a lot for designing such a beautiful PPH ready reckoner. And Isha, you are excellent. She has been there with me till 12 o'clock at night, and with the printer, Amit, रात के 12 बजे से 8 बजे, and उसने बहुत अच्छा PPH रखना बनाया है. Thanks a lot, Isha. Then I would like to call upon the reception committee, Dr. Rupa Prasad, Dr. Neha Bajaj, Dr. Devrishi Gupta, Dr. Alka Singh, Railway Hospital. I think she is here. Dr. Alka, where are you? Dr. Alka, yeah, please come. And Dr. Meena Singh. Dr. Meena Singh, please come. Please come. Yeah, please. The group photo होना चाहिए. रजिस्ट्रेशन कंप्लीट है। नेहा प्रदर्शनी को कंसिडर कर दिया। डॉक्टर नेहा प्रदर्शनी को कंसिडर किया मैम। डॉक्टर नेहा प्रदर्शनी को फॉर द साइंटिफिक कमिटी। अब धीरे पता नहीं साइंटिफिक कमिटी का हो गया। इनॉग्रेशन को बहुत अच्छा कंडक्ट किया एंड बट थैंक्स ऑफ टू डॉक्टर नीतू साहब जिन्होंने कॉन्फ्रेंस को स्मूथली रन किया। मैंने इस बारे में जो बात की 2 दिन पहले, उसके बाद मैंने चर्चा तक नहीं की डॉक्टर नीतू से करना क्या है, कुछ छूट रहा है, क्या हो रहा है। थैंक यू डॉक्टर नीतू, थैंक यू नेहा। नाउ आई वुड लाइक टू कॉल प्री पेपर कमिटी डॉक्टर गायत्री सिंह, डॉक्टर विश्व भारती। दे आर नॉट हियर बट उन्होंने प्री पेपर का कमान संभाला एंड वी हैड 3 papers in our presentation and that was very good. मैम जो हमारे मैडम लोग थे, माधुरी पटेल मैम और डॉक्टर मंजूपुरी वगैरह, दे रियली अप्रिशिएटेड कि उनका टॉक एक्चुअली बहुत अच्छा था। I would call my cultural committee team, cultural committee head I have to say, Dr. Neelam Bala and Dr. Meena Singh. Dr. Neelam Bala and Dr. Meena Singh, they had organized the cultural events, planning kiya, and it was executed very well. Dr. Neelam Bala and Dr. Meena Singh. Now I would request upon our Spread and Tall Committee, Dr. Sangeeta Karan ma'am, Dr. Krishna Agarwal ma'am, for helping out with me with the sponsors. Dr. Sangeeta ma'am, please come, and of course Dr. Kavita Priya ma'am and Dr. Pratibha Rai ma'am, उन्होंने भी मुझे बहुत सपोर्ट किया फॉर द स्पॉन्सर्स। साधना मैम ने किया, नेहा प्रदर्शनी, डॉक्टर सरवांगला मैम, सब लोगों ने मुझे बहुत सपोर्ट किया फॉर द स्पॉन्सर्स। दे वर ऑलवेज देयर विथ मी। सबको उन्होंने सब लोगों ने, सब डॉक्टर्स ने कहा हमारे स्पॉन्सर्स को प्लीज सपोर्ट रीना, एंड दे वर ऑल देयर फॉर मी। Now I would like to thank Dr. B.N. Chaudhary sir and Dr. Biswas sir. They were the heads of the food and stall committee, food and catering committee. The food which we ate in these 2 days were chosen by them, and the food was extremely tasty, and everybody appreciated the food. The food was very good, and thanks to RADISSON also. Obviously food तो उनका ही था, but choice हमारे seniors की थी. Now Vidisha has come. I would like to call upon our sponsors. हमारे जो special sponsors हैं, our platinum sponsors, Mr. Anmol Jha, if he's here, Anmol Jha, and Ujjwal, please come on the stage. And somebody from Mankind and Alchem, if they are here. They are our platinum sponsors, and I would like to call my gold sponsors, Lupin, Intas, Alembic, Sun Pharma, and Bayer. They have been, they are the highest sponsors of our conference. Sun ने speakers हमारे माधुरी पटेल मैम को लाया, plus Dr. Sujata Dalvi को लाया. All these sponsors have always been helpful, and सारे बाकी sponsors को मैं thanks करती हूँ कि because इनका बिना इनके contribution के conference success नहीं हो सकता. We are totally, because of their help only, we are able to organize such a scientific event, and which is very important for our enrichment, our knowledge, our revision, and gaining new knowledge. तो ये बिना हमारे medical sponsors के नहीं हो सकता. So we should always be thankful to them and supportive with them. Now next I would like to move to जो हमारे कॉन्फ्रेंस के जो पिलर्स रहे हैं, मिथिलेश जी है, मतलब राइट फ्रॉम मतलब एक साल से मैं हूँ, मतलब ये मेरे साथ खड़े हैं, you, Mitlesh ji, for every step, for every work I have done this year. He has always been there for me. बिना मित्लेश जी के शायद बहुत सारा इवेंट नहीं हो पाता. Next, I would like to call upon Mr. Pawan Sharma and team because इन्होंने registration counter इतना अच्छा संभाला कि मतलब I didn't have to hire somebody for the registration. उन्होंने मेरा काम एकदम easy कर दिया. खुशी, where are you? खुशी ने भी बहुत help किया in the registration. खुशी, आ जाओ please take it for खुशी, खुशी, आ जाओ. खुशी कहाँ हो? But you are excellent. जहाँ डालते हैं तुम्हें, no wonder you are हनुमान of Dr. Jha. तो ले लो ना के बदले. खुशी के बदले उनका कलीग ले लेगा, क्योंकि मैंने देखा है कि आज अगर इमेजिका है तो उसमें बहुत हद तक खुशी का है और आज भी कॉन्फ्रेंस में उसने बहुत हेल्प किया हमारा बिना कहे. मैंने उनको कहा भी नहीं, but she was there. Then I would like to thank Vishnu ji. विष्णु आइए प्लीज. थैंक यू. ये मतलब मैं मना करती रह गई और वो कहते रहे कि मैं रहूँगा, आपके साथ रहूँगा. और मुझे आज पता चल रहा है कि इनकी कितनी ज़रूरत थी. मुझे पता नहीं था क्योंकि ऑब्वियसली मेरे साथ मतलब पहली बार मैंने इतना नज़दीक से एक कॉन्फ्रेंस का देखा. लास्ट ईयर देखा बहुत कुछ, उससे बहुत कुछ सीखा EOGSBJ की वजह से. थैंक्स टू लास्ट EOGSBJ हमारा 5th DSOGCON, डॉक्टर नेहा प्रियदर्शनी और जो भी लास्ट के इवेंट्स को हम नहीं भूल सकते क्योंकि हमेशा हर इवेंट हमें नेक्स्ट इवेंट के लिए कुछ जरूर सीख देके जाता है. तो अगर आज का कॉन्फ्रेंस का अगर सक्सेस का कुछ डेडिकेशन जाता है तो वो EOGSBJ 5th DSOGCON को भरपूर तरीके से जाता है. एंड हमारी सोसाइटी आज फॉक्सी चैप्टर में अपने आप को एनरोल कर गई है. सब ने हमारे बहुत अप्रिशिएट किया, हमारे जो फैकल्टीज आए से बाहर से. और इस बीच में 2 गुड न्यूज़ शेयर करना चाहती हूँ. डॉक्टर माधुरी पटेल मैम ने मुझे मैसेज कहा है कि लिखने के लिए कि वी प्रेजेंट आवर PPH किट एट AICUG सूरत. थैंक्स टू द PPH किट. मैं सोच रही थी कि मैं बाद में बोलूँगी जब किट के वाले कमेटी के बारे में मैं अप्रिशिएट करूँगी तो, बट मैं अब रुक नहीं पा रही हूँ क्योंकि एक और अनाउंसमेंट है कि डॉक्टर संपत मैम ने कहा है वी हैव गेन्ड द फॉक्सी कॉन्क्लेव, GDM कॉन्क्लेव. उन्होंने कहा कि रीना इट्स योर्स. If I become president, GDM conclave you have to conduct here, and I wish I could consult Dr. Apurva for that because क्योंकि I think we are going to propose his name for the next secretary if he agrees. So whoever will be the secretary in 2028, please be prepared for the GDM conclave, which is a Foxy conclave, and it is honor for our society कि हमें ये conclave मिल रहा है, and that too without asking. And अगर मिलता है, I'm sure Samad ma'am is going to win, and nobody goes back with her words. It is yours. So whoever becomes secretary for 28, please be geared up. वो करना है. Please start thinking about it. Next, I would like to call upon Rajesh ji, audiovisual Rajesh ji. आपने पूरा 2 दिन आप और आपके स्टाफ, मैं चाहूँगी कि अगर आपके स्टाफ भी आ सके जो आप इम्पोर्टेंट स्टाफ है उनको बुला सके, क्योंकि मैं उनका नाम नहीं जानती हूँ. क्योंकि अगर कोई भी कॉन्फ्रेंस होता है तो और भी शुरू थोड़ा बहुत जो दिक्कत आता है क्योंकि हमारा सोसाइटी में भी कॉन्फ्रेंस होते हैं. तो अभी तो राजेश जी को पहली बार रखा था हमने, तो धीरे धीरे क्या होता है कि इम्प्रूवमेंट होता जाता है. जो थोड़े थोड़े माइन्यूट जो डिफिकल्टीज आ रहे थे, आई एम श्योर नेक्स्ट टाइम नहीं होंगे और अच्छा हम कर पाएंगे क्योंकि हमें पता नहीं होता ना कि क्या ग्लिचेस हो सकते हैं. सो पता चलेगा. थैंक यू राजेश जी, एंड आई एम श्योर नेक्स्ट टाइम और अच्छा हम करेंगे 2028 में. एंड नेक्स्ट आई वुड लाइक टू कॉल विक्की जी, डेकोरेटर. हमारा जो शामियाना जो सजाया, द गेट जो हमारे वेलकम गेट्स है, मुझे नहीं पता कैसा बना है पर लोगों ने बहुत अप्रिशिएट किया, बहुत अच्छा बना है. आई डिडंट हैव टाइम टू सी, बहुत अच्छा किया. मेरे फोटोग्राफर्स डॉक्टर इसरार और शंकर को थैंक यू बोलना चाहती हूँ. प्लीज आ जाओ. इसरार एंड शंकर, थैंक यू फॉर पेशेंटली हमारा फोटोग्राफ खींचने के लिए. लेके सारा कट कॉपी पेस्ट सारा करेक्शंस के बाद इतना बार करेक्शंस एंड पेशेंटली इन्होंने सारा प्रिंटिंग किया। अमित जी प्लीज ऊपर आ जाइए। नहीं मैं पहले और कोऑर्डिनेटर्स का मैंने नाम इसलिए लास्ट में लिया क्योंकि हम साथ में फिर ला करके एक साथ ग्रुप फोटो कराएंगे। नहीं मैम आई डिडंट सफर मैम, आई एंजॉयड अ लॉट, फैमिली सफर। नहीं वो अच्छा नहीं मैम एक सेकेंड। हाँ नेक्स्ट Amit, thank you all so much. Then I would like to call upon RADISSON, Avantika, Deepak ji and Sandeep, जो सितंबर से हमारे विम्स एंड फैंसीज को हैंडल कर रहे हैं। अवंतिका, संदीप एंड दीपक प्लीज कम। नहीं वो मैं करूँगी, मैं वो लास्ट में करूँगी। पर्टिकुलर राधिका हमारे सारे डिजाइनिंग का पार्टनर था फ्रॉम रांची, दे नॉट हियर बट थैंक्स टू देम। एंड अभिनंदन, थैंक्स हिम, आई थैंक हिम फॉर अ ब्यूटीफुल कल्चरल नाइट वी हैड यस्टरडे। एंड माय स्टाफ रंजीत, उषा एंड सूरज प्लीज कम ऑन द स्टेज। रंजीत ने मुझे सारे टाइपिंग एंड ऑल में हेल्प किया, उषा सिस्टर और सूरज 2 दिन से मेरे साथ लगे हुए हैं, दे हैव बीन वेरी हेल्पफुल टू मी। नेक्स्ट आई वुड लाइक टू कॉल जो हमारे 1 साल के जो सारे सर्वाइकल कैंप्स हमने जो किया उनमें सपोर्ट मुझे रहा सबसे ज़्यादा हमारे पैथोलॉजिस्ट डॉक्टर रणविजय सिंह, हमारे कल्याणी के ओनर मिस्टर प्रकाश, वेयर आर यू, मिस्टर पीयूष प्लीज आइए, एंड साक्षी, डॉक्टर सुमित अग्रवाल प्लीज कम ऑन द स्टेज। मैं बुला रही हूँ पीछे से, बट मेरा अगर आज जो भी थोड़ा सा सोसाइटी में जो मतलब जो भी मुझे थोड़ा सा रिकग्नाइज कर रहे हैं मेरे वर्क को, आपके बिना नहीं हो पाता। थैंक यू फॉर ऑलवेज बीइंग सपोर्टिव फॉर 1 ईयर विद माय सर्वाइकल कैंप्स। और साक्षी, आई विल ऑलवेज बी इंडेप्टेड टू हर, दो शी इज नॉट हियर, वो उसने बहुत साथ दिया है हमारा। झांसन तो शायद नहीं है, he is also been very helpful. Now I would like to call my hall coordinators. इतना अच्छा हॉल एग्जीक्यूशन किया आप लोगों ने कि मैंने आपको लास्ट में मैं आपको बुला रही हूँ क्योंकि मैं चाहती हूँ बहुत बढ़िया से। मनीष, अच्छा हाँ पीयूष भैया मेरे घर, मनीष जी प्लीज आ जाइए ऊपर। मनीष जी प्लीज आइए। मैंने जब स्टार्ट किया था सर्वाइकल कैंप, मुझे याद है मनीष जी ने कहा था मैम बस बोलिए और वो हाजिर हो जाएगा। इतनी गर्मी थी जब फर्स्ट टाइम मैंने कहा था, एंड वो फर्स्ट टाइम था, एंड मनीष जी ने कहा कि डोंट वरी मैम, वी आर देयर विथ यू, कुछ भी होगा आप मुझे बोलिएगा। एंड थैंक यू मनीष जी। आई रिमेम्बर वो धैर्यवाद हमारा जो था फर्स्ट सर्वाइकल कैंप। नाउ द हैंड्स, माय वर्किंग हैंड्स, I would like to call Vidisha, Vishu Bharti, Shreya, Radhika, Homa Fatima, Apsara, Dr. Avantika, Dr. Vinita, Isha, Dr. Neetu, Dr. Neha Pradarshini, Dr. Varsha, Dr. Neelam Bala, Dr. Jayanti Kashyap, Dr. Alka, Dr. Ritu Chaudhary। आप लोग पूरा टाइम साथ रहे, प्लीज आ जाइए। मैं चाहती हूँ कि मैं उनके साथ फोटो खिंचाऊँ, इसलिए मैं उनका नाम बुला रही हूँ। हाँ बिल्कुल,
all of them.
Actually मुझे उनका ग्रुप फोटो खिंचाना है, इसलिए मैं कह रही थी कि मैं इनको नाम जिसका
I'm really indebted to them for such a wonderful performance, perfection, and with coordination they have worked. Many of them left, maybe they were present on time. They have really done a good job. Dr. Vidisha, Dr. Shreya, Dr. Radhika, I think are not with us. Dr. Homa Fatma, they have left. But I would still appreciate their work. They've really done a wonderful job. All those who are here, please give them a big round of applause. They were there behind all the scientific session, and when no one was present at 8 o'clock, every day they were both the days they were present. I'm really happy with the work they have done. Thank you all my session in charges. They have really worked hard. You all deserve a big round of applause from all the seniors present here and from lots of blessings from my side also.
Thank you to all my hall coordinators and 3 cheers for you. Hip hip hooray! Hip hip hooray! Hip hip hooray! Thank you, and I'm very thankful to all of you. No, ma'am, it's not over. Still, it's left. Now I would like to call my.
We had prizes for the free paper. First was Dr. Vidisa, and second Vishwa Bharti, and third Dr. Archana. Dr. Archana is present. You can come.
साढ़े 8 बजे वाला बस तुरंत होने वाला है हम बस दो बचे हो गया.
Now I would like to call my skit committee people. Dr. Sadhana, ma'am, you are the one-man show director. इतना अच्छा डायरेक्ट करते हो, प्रोड्यूस करते हो, because like डायरेक्टर nice movie. और आपको एक बहुत बढ़िया PPH किट को करना है ये सूरत में. मैम ने कहा है, डॉक्टर माधुरी मैम ने, प्लीज प्रिपेयर फॉर इट. डॉक्टर साधना, डॉक्टर नीलम बाला, डॉक्टर वर्षा, डॉक्टर पूनम, डॉक्टर मीना सिंह. Big round of applause for all of you.
मैं डॉक्टर विकास चंद्रा सबसे फर्स्ट डॉक्टर है हमारी फैमिली के, और उनकी वजह से आज हम लोग 25 डॉक्टर्स हैं हमारी फैमिली में. एंड वी हैव बीन फॉलोइंग हिम. माय फादर वाज गाइडिंग अस. हम लोग तीनों भाई बहन डॉक्टर हैं, स्पाउसेस डॉक्टर हैं. वी आर रियली ग्रेटफुल टू एवरीवन फॉर दैट. थैंक यू पापा मम्मी. एंड आई वुड लाइक टू थैंक माय इन-लॉज, माय बच्चे जो बहुत कोऑपरेटिव हैं. अभी तक मैं बच्चों को देखा नहीं है, बट और बहुत बार उनको देख भी नहीं पाती हूँ. और जो मेरी एक शोभा सिस्टर है जो मेरे एब्सेंस से मेरे बच्चों का केयर करती है, क्योंकि वो लोग के बिना मैं नहीं कर पाती ये काम. और नाउ आई वांट टू थैंक माय लाइफ पार्टनर, माय लव एंड एवरीथिंग, माय हस्बैंड, जिनके वजह से जो हमेशा साथ दिए मेरा बिना बोले हमेशा सपोर्टिव रहे हैं. और उन्होंने कभी मुझे रोका नहीं कि तुम जो करना चाहते हो करो. उन्होंने कहा भी नहीं तो रोका भी नहीं, और हमेशा सपोर्टिव रहे. उन्होंने कहा कि जो तुम्हें जरूरत हो बोलना, बट हमेशा बैकबोन पिलर की तरह मेरे साथ रहे हैं. थैंक यू